Good morning, everyone. If you can start, please finding your seats and finding your way into the tables, we'd appreciate it. We're going to get started here in just a second. Hey, good morning and welcome to day 2 of Memorial Hermann Rocket Sports Medicine Institute's Sports Medicine Update. Thank you again for being here. We really appreciate it. Had a great day yesterday and fixing to get started today. Just a couple housekeeping reminders. Make sure all electronic devices are on silent, please. Restrooms are right out in the hallway. Um, If you have any questions, please try to speak into a microphone or the speaker will repeat your question if you don't have a microphone, so that's just fine. Remember, we are on Zoom, so stay away from the cameras and that type of thing. If you have any questions, just feel free to ask somebody and that type of thing. With no further ado, thank you for being here. I'm going to turn it over to Kathy.
Good morning, everyone. My name is Kathy. I'm one of the outreach athletic trainers with Memorial Hermann. Today's first speaker is Dr. Clarissa Garcia. She is a pediatric cardiologist and medical director at Pediatric Cardiology Associates of Houston, focusing on general cardiology, preventative cardiology, and cardiac health in athletes. She previously served as department chair of pediatrics and was on the Women's Hospital Pediatric Symposium Committee. She has her medical degree from the University of Texas Medical Branch at Galveston. She completed her pediatrics residency at the University of Utah and fellowship in pediatric cardiology at UT Southwestern. She provides sports physicals and cardiac screenings for local organizations and foundations, and she enjoys coaching her children's sports teams. Today, Dr. Garcia will be presenting on sudden cardiac death in athletes.
All right. Good morning. Good morning, everybody. As mentioned, my name is Clarissa Garcia, and I'm a pediatric cardiologist in the Houston area. And today we will be talking about sudden cardiac death in the pediatric population, a good way to start your morning and pique your ears. But this is obviously a topic that is very important and something that in any field that you are working with children, working with athletes, this is one of those things that you hope to never experience. But we'll be talking about some things that could kind of prepare you for things to be looking out for in certain athletes to try to prevent this and some screenings that we can do. So first of all, I did say I was a cardiologist, but I'm also a mother, and I am a mother of athletes. And so this is also very close to my heart just because of how important I feel that sports are for the young. We don't want patients off the field. We want them on the field, but we want them on the field and we want them safe. And so I always tell patients, like, right now, when I'm restricting you, I know you feel like I don't want you playing, but I do. I just need to make sure that you're safe to do that. So always keeping in mind that these patients are athletes. This is changes their lives. So this is me and my daughter. I've been her cheer coach for 6 years. I retired this year as a grand champion. And then my son's a swimmer. That's my third son's a swimmer. My second son, or for Cy-Fair High School, my second son is a baseball player for Cy-Fair High School. And my oldest son won state with Cy-Fair, played at SFA, and is starting as a high school Cy-Fair football coach next fall. So we definitely love sports and we support everything that you do. So thank you for all that you do. So today we will be going over the definition and statistics of sudden cardiac death, our role, depending what we do in healthcare, we all have a different role. We'll be talking about cardiac screening, some common causes of cardiac death, some non-cardiac causes of sudden death, and the future directions and conclusions. So sudden cardiac death is the unexpected natural death from a cardiac cause within a short-term period, generally less than 1 hour from the onset of symptoms in a person without any prior condition that would appear fatal. In this case, we often know that patients did have symptoms that kind of maybe could have keyed us into them having pathology, but what they're basically saying is no one knew that they had that, and then they suddenly have, they suddenly collapse or they're suddenly short of breath and they pass away within an hour. It's often due to a cardiac arrhythmia, which can be difficult in the fact that it's hard to diagnose postmortem, but it is also helpful with the use of ICD that we're able to get a lot of these patients back. So characteristics of sudden cardiac death. So about 1 in 53,703 athletes per year, which we know doesn't sound like a big amount, but if you think about it, if it's our one athlete in our school, in our district, it matters a whole lot. Males, there's a male predominance. As far as race, there is a Black predominance. And as far as sports, more basketball, soccer, and football. So talking about the role of primary evaluation. So the American Heart Association has developed a 14-point history and physical screening prior to athletic participation. And those are those questions that, are on all the ISD sports clearances that everyone has to check off, yes or no. That really covers most of these. Both the AHA and the American Academy of Pediatrics advise that the pre-participant screen should be utilized for athletes as well as all non-athletes. So this is whether you're considering band, trainers, other things where they're also utilizing a lot of energy. The role of the primary care provider or screener, who would be us in this case, is the most important person in identifying the children at risk, so primary prevention. Despite our best efforts, not all patients who experience a sudden cardiac arrest can be identified prior to the event. And the PCP, or the primary screener, which in this case many times is you all trainers, is important in developing a secondary prevention plan. And I know I've talked to some of you, work really hard in making sure that people are ICD trained, that ICDs are available, that everyone is able to have that second chance. We should be advocates to increase basic life support training for non-medical community members. So that means also our teachers, our librarians, different people in the school who can support. So what about EKGs? This has been a hot topic, EKG screening. So studies showed in Italy that there was a high reduction of sudden cardiac death. They even went as high as 85 to 90% when EKGs became mandatory. But the difference in the US is a little bit different, where we did not see such a significant reduction in sudden cardiac death with EKGs. And so in that case, the European Society of Cardiology, they do recommend screening, where the American Heart Association has not said that, yes, we should be doing EKG screening on all. Why would that be so different? So the big difference is the reason for cause of sudden cardiac death. In Europe, in Italy, there is more arrhythmogenic right ventricular cardiomyopathy, which is a genetic condition. So that happens to be more prevalent in Europe, more prevalent with the genetics over there. And so for them, it makes a big difference because EKG is a primary screening tool for that disease. So the AHA, while they have not endorsed an EKG screening for all, they really want us to focus on history, physical, and family history. The AHA rationale for not recommending ECGs is one, there is a low specificity of EKGs. As you know, there are multiple patients that can be flagged as abnormal and end up being normal. High prevalence of non-specific abnormalities. So when you see the non-specific ST segment changes or a slower heart rate, they're just random things that we can see that don't always mean that there is something wrong. But like I always tell families, if your child is the one child who gets picked up by this EKG when thousands didn't have an abnormality, it is important to us. It is a value to us. So like we talked about, there is a difference in the underlying causes. And additional studies on U.S. athletes suggest that EKGs may increase sensitivity, but we admit that there are limitations. So that brings us to Texas, where we all are. Texas House Bill 76, Cody's Law. That is, parents may opt in to add an ECG to mandated sports physical. School districts are required to offer ECGs, but not required to pay for them or help athletes access them. So that's that little checkbox that we all now have on the sports physical saying, do you want an EKG or not? And if they do, I think some schools are providing the EKGs, some are just providing information on where you can get those EKGs. It's very different amongst districts. Individual school districts make their own requirements. So the American Heart Association, this is the 14-point screening question. I won't go through all of them. You can read them. You've looked at countless of papers that have these questions on there. But there is just two that we do not have on our on ours mandated in Texas, which is prior testing for heart condition and disability from heart disease in a close relative less than 50. Those are not mandated, but I have seen them in some of the districts' paperwork. But otherwise, all of these are usually in the screening tools. Now, the American Academy of Pediatrics, they cut it down to a 4-question screening. So there could be a quick screening when patients are coming in. The AAP recommends 4 questions that you should ask all children. Oh, that's doing it on its own. Hold on. Not sure. I have some IT assistance. That's fine. I'm fine with that. Oh God.
No, we just keep, I don't understand why hospitals keep buying older and older tests.
I don't know, but let me look, because no, it's okay. No, I don't want that. I'm gonna, it should show up like this, but I'm gonna see. We're back. Oh, where'd I go? Where do you want to be? Right there? Right there? Okay, there you go.
All right, we're back. Okay, so the 4 questions. Have you ever fainted, passed out, or had unexplained seizures suddenly and without warning, especially during exercise or in response to a loud noise, doorbells, alarms, clocks, or ringing? Have you ever had exercise-related chest pain or shortness of breath? Has anyone in your immediate family or the distant relatives died of heart problems or died unexpectedly before age of 50? These include unexpected drownings, unexplained auto crashes where the deceased was a driver, or SIDS. Are you related to anyone with specific diseases such as hypertrophic cardiomyopathy, Marfan's, long QT, short QT, arrhythmogenic cardiomyopathy, Brugada, CPVT, or anyone younger than 50 years of age with a pacemaker or defibrillator? So some very specific questions, but as you can see, there is kind of a trend, especially with exercise-related symptoms. So if you have an abnormal screen, a positive reply to any of the 4 questions, or an abnormal EKG, then they should have a prompt comprehensive cardiac evaluation, and the child with the positive response should be restricted from athletics. This is very different among people. I notice that sometimes they say, hey, you need to go see cardiology, but you can keep participating. Some will automatically say you can't come back until you're cleared. And I think that is dependent on each person making that decision. But we do have to be pretty cautious with that, because I feel like you're at the point where you're saying, I'm worried enough about you to see a cardiologist, but I'm still letting you participate. That can be a little bit tricky. That is, where of course you want to have cardiologists available to see your patients quickly, and we're happy to help with that. So causes of sudden cardiac death in the pediatric population. So in most cases, unfortunately, we never really find out exactly what happened. Some of that has to do with it being arrhythmia, and obviously you can't pick up the arrhythmia once someone has passed. That also has to do with people accepting more autopsy testing, such as genetic testing after the autopsy, but sometimes we just never find out what it is. But the most commonly found one that we do diagnose a lot of times is hypertrophic cardiomyopathy, some of the other cardiomyopathies, myocarditis, and arrhythmia issues. So we'll go through those. So let's start with a clinical scenario. So this is a 13-year-old male who presents for annual sports clearance. He has a positive family history of an uncle who died suddenly while playing basketball in his mid-20s. An autopsy was not performed, and father never got evaluated by cardiology. He reports that he will occasionally have mid-sternal chest pressure when he exercises, and his examination is consistent with a harsh murmur. So if you think about those questions, he does have the exercise-related chest pain, and he has had a family member who died young. So that should prompt a cardiac evaluation. This patient did present to us and had these abnormal, I don't want to touch the screen again, so I'm just going to point them out here. So had some abnormalities on the EKG. One had some ST junction changes where we see some that are rise, some that are dropped. And we also have very high Q waves, which can signify some left ventricular hypertrophy. So that makes us very suspicious that there could be something cardiac going on. We go on to do the echocardiogram, and we find that this heart, this is if we're looking at the heart in cross section. This is the left ventricle, this is the muscle, and we see that it's very thickened. Here you also see the heart, right atrium, right ventricle, left ventricle, and you can see that left ventricle is thickened. So this is consistent with the diagnosis of hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is an autosomal dominant disorder caused by a mutation. So meaning that if father had it, then he had a 50% chance of passing that along to his son. In many cases, parents don't get screened, parents don't go to the doctor, so you're usually getting a second degree relative. But when you don't know dad's history and you do know uncle's history, it's important that this patient is screened. There is variable phenotypic expression, meaning you can carry the gene but not always have the phenotype or actually show the cardiomyopathy. And this is predicted to be in 1 in 500 individuals, which is pretty high considering how many patients are being screened. This results in asymmetric hypertrophy of the ventricle. The left ventricle often, the ventricular hypertrophy often develops over a prolonged latency. So it's not usually something that you see in early childhood. It usually peaks in adolescence and early 20s. And the annual mortality rate of this is 3 to 6%. So screening for these patients, or if someone comes in with a family member who has that, when they're less than 10 years of age, you don't always have to get them screened right away unless they say that a patient or a family member died in their teens and you want to get them diagnosed early. But if they're in our period, usually the adolescent period, they should be getting screened about annually if there's known family history of hypertrophic cardiomyopathy. As they get older, they're not screened as often because it usually has developed by that time. So that is one of the types of cardiomyopathies. There are 5 types. There's hypertrophic, the one we talked about, but there's also dilated, where the heart is just very large and not squeezing well. Arrhythmogenic was the one we talked about, where the right ventricle is more prone to arrhythmias. But those are things that you're really looking out for as far as cardiomyopathy. The next scenario is an 11-year-old who presents for syncope. The family reports that he's had multiple syncopal episodes, even in childhood, and most recently a few weeks ago. They usually occur when he's running or playing. There was a few times on the playground. Most recently, he was running from band to get his instrument and he fainted. He never had chest pain. He never had palpitations, and his exam is normal. And in fact, he had seen a previous cardiologist and everything was normal. So in this case, we are positive for that passing out with exertion. So we proceed to do an EKG, and his EKG is normal. But with that history of just having that exercise-induced syncope, we go on to do an ultrasound. The function looks normal, the size of the heart looks normal. That's very reassuring. But when we do a deeper dive, a very close look here, you can see that the top corner there, you can see that there is a coronary that should be coming from the left side going to the left that's actually going to the right side. And so you have an anomalous coronary artery. So that gets us to congenital coronary artery anomalies. They account for 15 to 20% of sudden cardiac death. The most common one to cause death is the left coronary artery coming from the right sinus. There are other forms, but this is one that we're really looking out for, and really the only way to diagnose this is with advanced imaging. We try to mostly pick it up with ultrasound. We're very, very particular in our clinic to try to really see the coronaries anytime we have an athlete coming in with chest pain or fainting with exertion. And if we're not able to see that very clearly, then we might have to have them get a CT or an MRI to be able to find this, because in most cases, we have to reimplant the coronaries to make sure they're safe to participate. So again, just symptoms alone really keyed us in on this one. The next, this picture is of one of our athletes, and it's on the website, so I went ahead and shared it with you guys. But this is a 15-year-old female who's a cross-country runner who happens to be a friend of the family. Mom called and said, hey, you know, we're noticing she does cross country. She's always been able to run. She hasn't had any trouble the past few years, but this year she's just feeling like anything she does, her heart just spikes up. She's feeling her heart racing. She's really short of breath. She's not able to run as fast or finish the way she used to, and she's just not doing as well. And I said, you know what, go ahead, bring her into clinic. We'll get her checked out. Let's make sure everything's good. You know, in the back of my mind, I'm thinking, oh, it's just after summer. She's deconditioned. She's just feeling those symptoms, but let's be sure. So again, in the questioning, exercise-related shortness of breath, let's bring her in. We do her EKG, and here in the arrows, you can see what we call a delta wave. A delta wave is associated with Wolff-Parkinson-White. Wolff-Parkinson-White is an accessory pathway that leads to increased risk for arrhythmia. So saw the EKG before I walked in, and I was like, wow, she's a Wolff. So WPW was diagnosed. We did go ahead and do an event monitor for her to kind of prove that she was having an arrhythmia, and her event monitor went on to show SVT. And so we know that her WPW was affecting her and her activities. So like we said, this is a form of pre-excitation. There is one accessory pathway, increased risk for SVT, but also increased risk for something a little bit more dangerous, which could be atrial fib or ventricular fib, and can be a cause of sudden cardiac death. So this patient was able to go to see an electrophysiologist, get that accessory pathway ablated, and was able to return to cross country, and is now starting her senior year in cross country. So another one that's just picked up by listening to symptoms. There are some other arrhythmias that we talk about. Long QT is a big one. That one is one that we take very seriously. That can be picked up easily by screening EKGs. And then another one that's really important, I feel like, for trainers is the catecholaminergic polymorphic ventricular tachycardia, so CPVT. Their resting EKG is going to be normal, but when the catecholamines get into their system, they can go into ventricular tachycardia. So these are patients that have symptoms with exertion. We will usually do a stress test to be able to diagnose this. Another type to pay attention is if someone has a history of congenital heart disease and they had surgery before, because of the scarring on their heart, they have a higher risk of arrhythmia. So it is important for those patients that say, hey, I've had surgery in the past in my heart, making sure that they are cleared by their cardiologist to participate. Clinical scenario 4. So this is an 8-year-old who presented with a sudden cardiac death of father at 32. The autopsy report showed a ruptured aortic aneurysm, and no genetic testing was performed at that time. There was no other family history. There was negative personal history, and actually her examination seemed normal. So in this case, family history leads us to do EKG and echo. And in the echocardiogram, we find that her aorta is indeed dilated. And we go on to do genetic testing, and we find that she does have the mutation consistent with Marfan's. And we talked about her examination was normal. So this little girl was 8 years old. She hadn't quite developed. She hadn't had her changes that you might see with getting tall, or maybe a pectus or scoliosis. She is also of Hispanic origin, which I find that some of different ethnicities kind of don't show as much of those symptoms. They might be taller than they would have been, but they still are of average height. So it's things to really pay attention to. So these are the aortopathies, the cases where the aorta gets really dilated. This can lead to spontaneous rupture or can lead to rupture with collision. So these are the patients that we're saying can't play football, maybe need to stay out of basketball or soccer, depending on how competitive it is. And these are patients we want to pick up early so we can prevent further dilation. Marfan syndrome is also autosomal dominant. So again, that 50% chance of passing it along. Frequency is 1 in 10,000. This usually involves not only the heart, but their skeletal changes, ocular changes, and skin changes. To diagnose it, we mostly use the heart and the eyes, but there are other systemic things that we can find that can add points up to this diagnosis. So a patient that you see with pectus excavatum or carinatum where it's coming out, or scoliosis, those we need to just be really careful with. Clinical scenario number 5. So this was a patient also that came to us, a super strong athlete, varsity football for many years, had been seeing their pediatrician religiously, and went for their routine sports clearance, and the blood pressure was 158/85. Came in, when you see a patient that's fit but has a blood pressure like this, you're like, wow, there's something different, something's going on. So we went ahead and did exam. We found that he had no pedal pulses. Oh, sorry. God. This is fun, y'all. Okay, while they're fixing it, I'm gonna keep talking because I know what I had on my slides. So either way, if someone else can come try to fix it. Either way, was found to have a coarctation of the aorta. Because of the coarctation of the aorta, you have a high pressure on the right side because the blood can't get across the aorta. It's blocked off the side. So your pressure on your right arm is going to be high, but your pressure in your legs or the left side is going to be either normal to low. So it's very important then when you guys are doing blood pressure, doing the right arm, because that's the only way you can diagnose a coarctation of the aorta. This patient went on to have surgery for their coarctation, went back and played football. Okay, I think we're back, guys. Well, maybe not. Okay, so in continuing with the presentation, you will get the slides after the fact. The last clinical scenario was a patient who came in with a history of asthma, had been receiving albuterol, okay, had a high heart rate. And during that time, it was like, okay, well, was the heart rate coming from the albuterol? Patient had been about a couple hours from the albuterol, continued to have a high heart rate, now was having shortness of breath, difficulty exercising, went into the ER, heart rate was still high. We went ahead and recommended an echocardiogram and doing labs, and we found that the troponin was sky high, and the echocardiogram showed very low function. This patient had myocarditis from a non-COVID Coxsackie coronavirus. So it's important for you guys to remember that we can have patients that are completely healthy, never had any heart issue before, never had any symptoms, but then pick up the flu, pick up some kind of virus, and their heart is weakened. Usually that's an acute change, and they're going to have that weakness within the next week or 2 weeks, but they're going to try to come back to play. Parents are going to send them out. They're going to be short of breath. They're going to have tachycardia. They're going to feel really sluggish. And in those cases, we need to be sure that they're not having any kind of effect from that virus on their heart. Going on to the rest of the presentation. So the things that we were going to talk about in summary, it is important to pick up these patients. We want to help you screen these patients. We are available for screening of these patients, but it is also very important that we are prepared to handle these patients when they are out in the field, when they are with you as trainers. So just talking about the importance of ICD training, making sure that you have an AED available to be able to use that when needed. Defibrillation definitely saves lives. And I know that all of you here know that that's so important. I've heard of all the efforts you've made to have that available to you all. So just continue to make sure that all your staff, your team is trained in CPR and defibrillation so that if one of these does slip through the cracks, because there will be an occasion that this happens, that you're prepared to respond. Does anyone have any questions? I think the question was, how often do you have a patient that has to go for a myocardial bridge surgery? Okay, so that is a less common one, but we have found myocardial bridges. And so usually how that occurs is you can't really see that on an ultrasound, but you really have to pay attention to the symptoms that the patients are having. So if they're continuing to have exertional chest pain, then oftentimes we'll send them for a stress test. And usually the stress test will pop up positive if the myocardial bridge is significant. And then we would send them in for advanced imaging and decide if they need the myocardial bridge to have surgery. But I think I've had one in 11 years. Any other questions? All right, well, thank you. I apologize for the technical difficulties, but we do have a table outside with a lot of a lot of stuff that y'all can get for fun. And then I have these cards, which just kind of have those 4 questions on the back and kind of talk about sudden cardiac death. So if you have any questions you didn't want to ask in front of everybody, I'm happy to answer them at the table. We'll be here through around 1 o'clock today. Thank you so much for your patience.
Is it on? Thank you, Dr. Garcia. Our next presenter is Dr. Ryan Brown. He's a primary care sports medicine physician with the Department of Family and Community Medicine at the McGovern Medical School at the University of Texas Health Science Center at Houston. He received his bachelor's from Harding University, his doctor of osteopathic medicine from the University of North Texas Health Science Center at Texas College of Osteopathic Medicine. He completed his family medicine residency at HCA Houston Healthcare and his sports medicine fellowship with UTL Houston. He also has a certificate in added qualification in sports medicine. He is a Houston Police Department Cadet Medical Training faculty, Houston Marathon Medical Team volunteer, and is a team physician for Cypress Falls High School with Cypher ISD. Today, Dr. Brown will be presenting on managing the asthmatic athlete.
All right. You all able to hear me? Is this good? Okay. All right. Good morning. Like she said, my name is Ryan Brown. I am a family medicine doctor. I primarily practice sports medicine at UT Orthopedics in Cypress. So right off 290. All right. And we're going to be talking about asthma in the athlete. So in our lecture today, what we're kind of going to be going over is what is asthma? Who gets asthma? Why does it occur? How can we prevent and treat chronic asthma and asthma exacerbations? What medicines are used to help in asthma? And what else could be contributing to the athlete's symptoms, such as our previous lecture is cardiac events. All right, so let's start with the definition. Asthma itself is a chronic inflammatory respiratory condition exhibiting hallmark symptoms of difficulty breathing, cough, wheezing, and it's due to variable airway obstruction and bronchial hyperresponsiveness. I think an easier way to look at this is just look at our picture that's over here on the right side of the screen. This is a healthy bronchial where the air is going down into the lung on this side, lots of space in the lumen for air to travel. And on the right side, we have an asthmatic lung. So there's swelling within the bronchial, there's mucus plugging, and that air isn't able to get back out, which is going to result in your athlete not being able to breathe very well. Okay, so how does asthma attack? Like we mentioned, it happens kind of in two stages that work in concert with each other. First is inflammation, where the allergens, maybe in the environment or where they are going to lead to an acute response where the body releases some of its antibodies, causing smooth muscles that surround those bronchioles in the lung to squeeze down and decrease that lumen size. When that happens, now we have obstruction. The air can't get all the way down into the lungs or particularly can't get back out. And then there's swelling and mucus is building up. And again, you're not able to continue to breathe and get the oxygen where you need to get it. Okay, so why is asthma important? It's one reason it's important because it can be very dangerous for our athletes. And two, it's really, really common. So pretty much any sports team that you have, you're going to see student athletes that have asthma. Probably many of us in this room have asthma as well. Estimated roughly 25 million Americans. Happens more commonly in males as opposed to females. And it seems to strike more commonly in our athletes that live below the poverty line. So they oftentimes have more asthma diagnosed, and they do worse with the asthma that they have, which is the morbidity and mortality. If we look at this picture in the bottom here, this is particularly talking about adults. This is a study in 2022. One thing that we can notice is the asthma incidence and prevalence seems to be higher in the northern parts of the country, which is estimated probably because of the drier and colder air up there, as well as some of it being in more industrial type areas. It doesn't line up exactly with some of these graphs. We're going to look at the next one, which was studies farther back in 2008. If we look at the top left here, this is asthma by sex. So this is what we were saying. Boys are more commonly going to be diagnosed in asthma with girls. And if we look at asthma prevalence by age, once our student athletes are reaching roughly 5 years of age, it stays pretty baseline around this kind of 10% level all the way through their teenage years, which is why I'm saying if 10%, 1 out of 10 student athletes might have a good chance, and this green is Texas, almost every team is going to be, by these statistics, have at least one student athlete that is having asthma. And then on the right side here, we see there are higher prevalence in certain races and ethnicities, with our Black individuals having the highest rates of asthma as well. Okay, so asthma can present in all kinds of different ways. So you might have someone that comes to you and says, I have chest tightness or pain, coughing, prolonged shortness of breath, difficulty sleeping, wheezing, inability to catch one's breath, difficulty exercising due to breathing issues, accessory muscle use, breathing issues upon awakening at night, breathing issues with allergens or irritants, exercise-induced coughing or wheezing, well-conditioned athletes seeming unable now to perform at their peer level, personal history of asthma or a family history, and personal history of things like atopic dermatitis, where they're getting itchy and red skin, eczema, hay fever. So a lot of different things. Really, any breathing issues you at least are going to be considering, is this asthma? Okay, so let's first talk about common triggers in asthma. Triggers are important to know. Each individual might have a different thing that kind of sets their asthma off. And the more that you know what their triggers are, the more we're able to prevent you ever from progressing into these asthma exacerbations. As Socrates said so long ago, know thyself. We've all worked with these high school athletes. They oftentimes don't know themselves. So we're going to encourage you to try to know your athlete's self. So if you can know the ones that tend to have worse asthma or it seems to act up more often, if you can help them avoid or remember to take their medicine, it's always going to be helpful. So really common triggers, things like exercise, coughs and colds with the upper respiratory infections, allergens, air pollutants, changes in the weather, strong emotions, even medicines and vaping. So we're going to talk about each of these a little bit more here in detail. Okay, so first up is exercise-induced asthma. When you go from just a resting state into playing your sport or going into your practice, one thing that you're doing, of course, increasing your respiratory rate. You're usually switching from nose breathing, which allows that air to come in and humidify. And instead, you're switching this mouth breathing. The air is making its way through those bronchioles into the lungs much, much quicker. When that happens, you're having drier air make it to the lungs, probably changes of temperature air, like cold air getting to the lungs quicker. All of that is going to be a recipe to set your asthma off. Ways that we want to try to avoid this is we want every athlete to warm up before they go, not going 0 to 100, but we really want our asthmatic athletes to have a good warm up, at least 15 to 20 minutes, where they're getting all the way up to 80 to 90% of kind of their intensity, so that they've had the slow time for their body to make those changes into getting ready for a sport. Heart rate has been increasing, the air has been warmed up through the lungs. Secondly, medicines. We would like them to have their rescue inhaler, and albuterol inhaler is the red one that you normally see. And we'd ask them to use it roughly about 20 minutes before they're planning to either practice or be in their sport to really get the best. If they're taking it 1 minute before, you haven't had enough time to fully get that thing to work. And then lastly, what I would say is sometimes these asthmatic kids, they haven't been able to keep up with their friends when they were younger through their lives, and they think that that's going to plague them forever. But you might even see as these athletes are able to get more into their sport, increase their fitness, their lung capacity is going to improve, the actual blood flow to the lungs is going to improve, and overall they're going to have a decrease in their asthma symptoms. So we really want to encourage our asthmatic athletes to participate and not quit their sport because they're too worried. So if you can be an advocate there as well, it can be beneficial. All right, so next up is upper respiratory infection. So y'all might have heard a kind of general tool that we use in upper respiratory infections is the neck check, meaning that if you have symptoms of maybe sore throat, nasal congestion, ear congestion, that sort of thing with a viral illness, generally speaking, we're saying, okay, that's okay. Those are fairly minimal. You can still play. Things that are below the neck, things are talking about myalgia, so muscle aches, systemic things like fever, maybe they're having diarrhea, or they're, of course, with our asthma talk, having respiratory symptoms, we're saying, okay, maybe this patient should not. They fail the neck check. All their symptoms are going down below now. So one thing to keep up with in asthma, they might have the neck check above. Everything's good. You want them to get into play. However, you just need to be a little more cautious because these viral illnesses, of course, can set off their asthma. So just something you want to keep a closer eye on. All right, so next we're going to talk about allergens, air pollutants, and weather. These are things that we either want to avoid or mitigate the exposure to them if possible. So first up, allergens and air pollutants. Like we said, there is an inflammatory component, a mucus plugging within the lungs that can happen. So a lot of these student athletes are going to be recommended by their doctors or maybe their parents to take a Claritin or a Zyrtec. So if we're in the spring and it's March and April and their asthma seems to be getting worse, maybe a gentle reminder, are you taking your antihistamine medicine, could be beneficial. And if they are really having trouble, maybe also moving them from an outside to an inside type of training for those days when the pollen counts are really high, it's going to help decrease any risk of asthma getting worse. If you look at our picture here on the right, some of y'all may know this is Galen Rupp. He's a U.S. Olympian. This was, I think, taken in 2011 en route to winning his third 10,000 meter U.S. championship. He has a history of asthma. He has it worsening with, at least per his report, that the allergens and pollen was high that day. So he decided to start his race with a mask. so that he would decrease some of the pollen making its way to his lung. And then I think about a halfway or 3/4 into this race, he was able to take it off. So he was just trying again to get that lung primed and warm up the air and humidify it so that he wouldn't be at such risk for his asthma to worsen and decrease his efforts during that race. All right, next up, we are going to, or let's finish. I have another slide here on the air quality index as it goes with air pollution. So the air quality index is something that's put out by the government. I think I have the slide here on airnow.gov. You can always check it. When I was putting this slide together, I think this was last week on the 28th, at least in Katy, our air quality index came out to 51. So that, if y'all haven't looked at this before, references this over here. Green, 0 to 50, is telling us air quality is good. Pretty much everyone is going to be able to go outside, and if their symptoms are worse, we don't think it's going to be due to any pollution in the air. Now, living in Katy or Houston area, we're a big city, so we're going to have more pollutants in the air. So we are oftentimes, I checked kind of throughout this week, at least at this time of year, we're staying pretty consistently in this yellow, which we call a moderate level of air pollution. Air quality overall is acceptable, but some people that are particularly sensitive might start to have issues when they're outside. If you make your way up to this green and the AQI is in the 100 to 150, almost everyone that has some underlying lung issues, such as asthma or COPD, are going to have issues. So if they can, again, train inside, maybe that's the time they wear a mask to try to avoid some of the pollution making their way to the lungs. You want to try to do so. And then once you get to 150, everyone is going to start having issues. And this is where it gets kind of a public health emergency, where they make news reports and say, hey, everyone, you should stay inside these days. Okay, so weather as well. So traditionally, cold, dry air is known to worsen asthma. That's why our photograph of the US earlier showed these northern states as having worsening asthma than our southern states. We really want people to try to have proper warm-up so that air can warm up and the lungs can warm up. Using masks, scarves, and gaiters to cover the mouth as you're breathing is going to help warm that air as well. Unfortunately, for more in the Houston area, hot and humid air can worsen things as well. Usually the air is a little bit more stagnant in that area. It can feel kind of stuffy. There's going to be promotion of mold and bacteria growth within the air and the environment, which is going to worsen asthma. And then when you have changes of weather going from hot to cold to hot, and the body and the lungs aren't kind of primed for that, another time to be a little bit cautious. And then an interesting one, which I have a graphic here, is about thunderstorms. So if you have rain and stuff coming, what's happening is this pollen is being swept up into the air. That electrical activity within the clouds and the lightning is breaking that pollen up into these tiny little particles. These little particles are then raining down, and these people are breathing it in. And if you have that underlying asthma, you're going to be more sensitive. So if you start to see more asthma symptoms when there is kind of rainy or thunderstorm days, this is the reason. All right, so let's talk about, we've tried to prevent it, but things seem to persist anyways. What are we going to do about asthma? So we always want to be prepared, and we want our athletes with asthma to have their rescue inhaler on hand. I helped with a lot of our pre-participation physicals, and the ones that came through that said they had asthma, I asked if they had their albuterol inhaler, and it wasn't a very hopeful answers. A lot of them did not, and I'm sure that y'all know that. So encouraging them to have this and make sure they're getting refills from their doctor is going to be beneficial. The most common one you're going to see is called a short-acting beta agonist. In short, we call them a SABA. Their brand names are things like ProAir, Ventolin, or Xopenex. The generic is albuterol or levalbuterol. It's how it acts is where that smooth muscle is constricting, it opens the airway, so just giving that air more chance to go in and out of the lungs. You might see them on two different inhalers. So if they have really bad asthma, they might be put on a steroid inhaler. And these days, they also have kind of combined steroid and SABA combined into one. We would like people to use these right here called a spacer. So a lot of these athletes are taking their inhaler, inserting right into their mouth and kind of breathing it in. Sometimes that medicine tends to get stuck at the back of the throat. Maybe they breathe out too quickly. These spacers are made so you can shake the medicine, spray it into the spacer, and take about 4 breaths so you know that you're getting all that medicine and it's not being wasted. All right, so if we want to get a little bit fancier as well, we talked about knowing which patients or athletes on our teams have asthma. We kind of learned a little bit about what their triggers are, and we know what medicines they are. And if we wanted to be fancy, we can use this kind of baseline peak flow. So a peak flow, it's not electric or anything. You're essentially just taking this. A patient is then at their baseline where they're not having any asthma symptoms. They're taking as big a breath as they can, and they are blowing into this, and we're seeing how far up the meter they get. So if we pretend someone's normal is around 400 on this meter, And now they might be having a little bit of lung symptoms, but they below 350. They are still over 80%. And in general, we're saying, okay, your asthma might be acting up, but you're still in a safe zone to play. As opposed to if you drop down into 50, 80% of what your baseline is, then you're going to be a little bit dangerous. And one reason this comes into play, one, of course, to keep the athletes safe. Some of your student athletes might come in with one of these asthma actions plans, maybe from their primary doctor or pediatrician or their pulmonologist or lung doctor, which essentially is telling us if you're in that green zone on their peak flow, what medicines should they be taking and how often. Before exercise, are they recommending they take their kind of rescue inhaler before then? And then if things are getting worse, if their peak flow is blowing down in that 50, 80% range, these are going to be filled out to say what medicine should they take, how should they take it if it's even getting worse, and if it's real low at 50%, how are we going to take that medicine to try to help them out there? I know not everyone is going to have this, but some of their primary doctors are going to be preparing for them during their well childs once a year. All right, so we've tried everything. They're taking their medicines, but they seem to be having an acute asthma exacerbation with a lot of those symptoms, chest tightness, difficulty breathing. What do we want to do? Okay, first off, we want to try to sit the athlete. We want to put them upright, and we want them leaning forward slightly. It's easy to remember if someone finishes a race or a long run, they're oftentimes going to drop down, hands on their knees. That is just a natural way to optimize your breathing mechanics, kind of like this guy is sitting here. Number two, you want to try to stay as calm and reassuring as you can. As we mentioned, anxiety itself can worsen asthma. If someone is already having an asthma exacerbation and then someone is freaking out and telling them that they're going to die, it's only going to make it worse. So hand on their shoulder, reassuring them everything's going to be okay. Try to gently guide them to get their medicine is going to help, and try to get them to slow their breathing down, deep, slow breathing. Number three, now we have their albuterol inhaler, which they remembered to bring with them. And if you have never used one of these inhalers before, you want to prime it first if you're the one helping them with it. So that means kind of shake it for 5 to 10 seconds back and forth like this. If the spacer's available, get that going as well. And then we're going to have them inhale one breath. And if possible, they're going to hold their breath for about 4 to 5 seconds. If it's in the spacer, they don't have to hold it as long because they're going to be only breathing back and in that medicine. And you want to give them 4 breaths in between, but you're going to do 2 to 4 puffs total within that time. Hopefully this starts to improve their symptoms. If it does not, you can repeat this in roughly 20 minutes again. And if things are not going well, things are getting severe, that's when you want to get a higher level of care where they might get things at the ER, the urgent care, where they're actually putting a nebulizer on them, if y'all know what that is. We're breathing that albuterol in kind of constantly through a 15-minute interval. All right, so if we think somebody has asthma, how are we going to diagnose it? Well, our history is going to give us a pretty good idea that this is what is going on. As we saw in our last lecture, you can get tricked a little bit and we might think it's asthma. It's actually cardiac. So we would like to have baseline and true diagnoses, not just based on history. And that is done through what we call a pulmonary function test or spirometry. That's what this little girl here is doing. She is taking big breaths. She's breathing into this tube, and it is measuring kind of how much air she's able to breathe, how quickly she's able to breathe it out in 1 second. And these are all put into some formulas to say, yes, that air is getting trapped. And you might be asking yourself, well, a lot of people with asthma have many good days. How are we going to catch them on that day? They do have medicines that they give. So essentially, their breathing can be normal. They give them this special medicine, which induces an asthma attack, where then now, yes, their percentages are dropping off. They give them albuterol to show that it's reversible. They do it again, and their kind of airways go back to normal. And that's how we're able to get a true and underlying diagnosis of asthma. If you're wondering who does these, you can usually get them either their primary care pediatrician, maybe a pulmonologist, which is the lung doctor, or an allergy specialist are the 3 main people that are going to be able to do this. And then lastly, if you are having an athlete who you're looking at and they're doing all the things they're supposed to be doing for asthma, you're avoiding their triggers, they're using their medicines, and things do not seem to be getting better. Like we mentioned last time, it could be cardiac, could be acid reflux, where it's coming up from the stomach and they're having that burning sensation. And, you know, kids and even adults, it's hard to really describe what that feels like at times. So it could be this acid reflux or GERD. Maybe they just have a viral infection right now that seems to be affecting their breathing. Or lastly, there's this thing called vocal cord dysfunction. So vocal cord dysfunction is where, this is the differentiator here, rather than holding their chest, maybe they feel some of that tightness or weird changes in their breathing up here in their neck, and is where the vocal cords themselves, where that air is going to come through, are not relaxing properly. And you cannot diagnose this by that breathing test that we've done, so they might do that. Everything is normal. You actually have to have a specialized doctor, usually an ENT, ear, nose, and throat, go in with a camera, look at their vocal cords to see if they are opening and closing in a normal way. So just another thing to keep an eye on. I don't expect anyone to be able to diagnose this on the spot, but if something isn't going right, we want to look a little bit closer at these patients. All right, and I think that is my last slide. So thank you all so much, and I'm open for any questions here.
We have a couple on Zoom. The first one is, how long after a fourth attempt of an inhaler is needed before you call 911 if there's no positive reaction?
Yes, great question. So this kind of differs depending on what country you're in. Of course, we're in the USA, so like the American Lung Association recommends 2 to 4 puffs. And if there's slowly starting to improve, but not all the way, you repeat in 20 minutes. In Australia, it's still a safe thing I was reading. They have a 4-4-4 rule. So you're giving 4 puffs every 4 minutes, and you're doing 4 breaths in between each puff. Essentially what we were talking about earlier. But if someone is not seeming to get better, if you have the opportunity to put an O2 monitor on them and their O2 is low, normal should be in the high 90s to 100%, okay, use your clinical judgment and get 911. You're never going to be wrong to do that if they're having an asthma exacerbation. But if someone is struggling and it has not been 20 minutes, yeah, it's okay to repeat that even sooner, even in 5 to 10 minutes if you have to. No one's going to fault you for that.
For the spacers, are those prescribed by the doctor, or do you pick those up over the counter?
That's a great question. If anyone in here has asthma and knows, they can maybe tell us.
Okay. Most physicians will give you a prescription for them when they give you your or your child's updated inhaler, but it is separate now, and they're approximately about $35 now for the spacer. But you have to make sure with your athletes to teach them and remind them they need to be using their spacers when they're using their inhaler. It is imperative. So you have one at home, and make sure they have one with them with their inhalers in athletics as well.
Thank you so much.
Here, that way I don't have to raise my voice. I deal with this a lot, and I'm sure that a lot of athletic trainers and even PCPs have to deal with this. Oh, I had asthma when I was young, and I don't have asthma anymore, right? It's like, oh, it's been like 5, 6 years since they've had asthma. Okay, now, not trying to sound negative or ugly, really? Were you misdiagnosed the first time? Or did you really truly grow out of it? Or what? Because that's something that just blows my mind, even after 40 years of being an athletic trainer. Are you kidding me, really? So what are your thoughts?
Yeah, okay, great observation. I agree. A lot of people are going to say, yeah, I was diagnosed with asthma when I was younger, and it's hard to say. That is why we like to have this baseline true pulmonary function or spirometry if we can. It's not uncommon. These young kids to get a viral illness, they had difficulty breathing. They got taken to urgent care ER when they were really little. They got put on this albuterol that comes through again through the mask called a nebulizer. And the doctor then said, oh yeah, your patient might have asthma. Now, a young kid isn't able to truly do these testing. So, I mean, the access to this, getting into the pulmonologist, doing the testing is going to be expensive. So unfortunately, it's probably not available for everyone, but we'd like it to be. I think that is where some of the juxtaposition between that can come.
If you have a student athlete who has never experienced asthma before or is undiagnosed and they have what you presume is an asthma attack like under your watch, are you immediately activating EMS, or what are some things that you can do if they don't have a prescribed inhaler while you're waiting for EMS to arrive?
That's a great question. So if you don't have any medicine available and you're, I don't know, being the safest that you can be, it's kind of these first couple things: sitting them upright, getting them in a proper position for breathing, trying to reassure them, trying to make sure they're nice and calm, get them out of a heavy environment. If they're outside, get them inside into a cool and conditioned place. that's kind of where I would start.
So like, if you have a kid that have asthma, but then they're also having a panic attack, how would you kind of manage both of them? Like, would you still do the inhaler, but you don't know if it's an asthma attack and it's more so panic?
Yeah, that can be tough because those two things kind of fight against each other. Now, someone could have a panic attack, and like we said, that this kind of heightened emotions can actually set off an asthma attack. So it's very possible and not uncommon for them to kind of have both going on at the same time. The only secondary thing I would say is I would give them the albuterol. It's not really going to cause much harm. However, albuterol is known, and a normal side effect is for it to raise their heart rate. So if they're already kind of freaking out or feeling really anxious and their heart's beating fast, the albuterol is only going to make their heart rate faster. So it's good to know that that is a known, common, and not unexpected thing to happen when they use the albuterol. But I think this calm and reassurance and from a trusted kind of healthcare provider with them is going to be helpful. But that is the benefit of knowing your athletes too. You're knowing, okay, this is not their asthma. This is more their kind of anxiety, underlying panic disorder. But I don't think it's going to be harmful to at least give them an albuterol inhaler and see if it helps while you're trying to be calm and reassuring. Great question, though. Thanks, guys.
Thank you, Dr. Thank you, Dr. Brown. As a reminder, for those people who are on Zoom, if you guys have questions here, please raise your hand so that we can come to you with the microphone, so that way the people on Zoom can hear the questions, and that way the speaker can also answer the questions and the Zoom people can hear it as well. Thank you so much. Our next speaker is Our next speaker is Emily Barnhart. She is a board certified sports dietitian at Memorial Hermann Rocket Sports Medicine Institute. She has a bachelor's from University of Connecticut and master's from the Ohio State University. She was previously an assistant dietitian with the Texas Rangers. She's a contracted dietitian with USA Volleyball and USA Sled hockey teams. She's an owner of the Injury RD, a private practice providing nutrition education and support for injured athletes, active individuals, and sports medicine providers. She's also a certified strength and conditioning specialist. Today, Emily will be presenting on nutrition support for concussion management and recovery.
All righty. Good morning, everybody. My name is Emily, and I hope our brains are firing on all cylinders because, of course, we're going to talk about nutrition support post-concussion. Now, there we go. Now, this is my slide where I get to kind of show you where I've been, but this is also where I get to say I have had the honor of working with some really wonderful sports med providers, and it has led to a real passion for supporting what you all do and helping you take care of our injured athletes and giving nutrition a voice at this table. So, of course, the table we're talking about today is concussion, but I have a real passion for supporting y'all with our injuries in general. So what I would like to do today is, of course, help you guys have a strong understanding of the nutrients a healthy brain needs, and then, of course, how that's going to change after a concussion, and then give you some really, really simple, easy to apply solutions that you can take back to your setting. Alrighty, there are 4 big things that we want to think about when it comes to feeding a healthy brain. First and foremost, your brain uses a ton of calories. Your brain is very important. We need to feed it. Your brain is what we call a very energetically demanding tissue. Now, depending on obviously how much you eat, depending on your age, your brain uses up to 20% of the calories that you eat. For our teenage athletes that we work with, we hope that their brain is continuing to develop. So this is even higher for them. And pretty much all of those calories are going to come from carbohydrate. We want all of those calories to come from carbohydrate to the brain. Some of you might have heard that your brain needs about 7 slices of bread to function throughout the day. That's probably true for some of you. Another way that I like to think about it is the suggested minimum is about 130 grams of carbohydrate per day. Now, my fist is about 30 grams. So this is about the size of an apple, and I'm small. So some of you are going to have bigger fists than I do. But at minimum, just for our brain, we're looking for about 4 fist-size servings of carbohydrate. That's not talking about muscle glycogen. That's not talking about all of the activity that they're doing. That is purely just feeding the brain, and we want that to come from glucose alone. Your brain, just like your muscle, is also going to store phosphocreatine for those kind of emergency must-need energy situations. And then fat plays a very critical role, not necessarily for fuel, because fat's not going to cross that blood-brain barrier, but what protein is to muscle, fat pretty much is for your brain. And specifically, we're looking for omega-3s. Now, there's 3 types of omega-3s. We've got EPA, DHA, and ALA. ALA is wonderful. We love it, but not really the omega-3 that we're looking for the brain. So later on, when we talk about supplementing, we really care about the dose of DHA, a little bit EPA, and ALA, all right, whatever, but it's not necessarily going to help the brain in the ways that we're talking about. There we go. All right, so how does this change during a concussion? Well, as you can guess, those energy demands go even higher. Again, like I already said, the brain is a very, very important organ. So when it is damaged, we're going to send all troops to the front. We are going to provide as much as we can to heal that as fast as possible. Some estimates say that your brain's going to use 40% more energy when it is in kind of a TBI or a post-concussed state. So again, if I was talking about 4 fists of glucose or carbohydrate in a regular day, now we're looking for more like 6 just to feed that brain. We also see a rapid decrease in our creatine stores. So again, just kind of signaling to us that the brain is using a ton of energy and we are in a little bit of an energy crisis and we need to feed that. And if you don't remember anything else from my talk today, it is that you need to feed your athletes after concussion. We're going to talk about why that's hard sometimes. Of course, we had some damage, so we're going to need some more antioxidants. Potentially, we need more of certain vitamins and minerals and more of certain amino acids. Specifically, we're looking for those branched chain amino acids, leucine, isoleucine, valine. So this is a very wordy slide to say you need carbs, proteins, and fats. That's kind of what nutrition always comes down to. All right, so the question I want you to think about is, what is nutrition's seat at this table? I have talked to a lot of sports med providers about what we should be doing nutritionally after a concussion. And to be honest, a lot of you guys know the omega-3 research. You know the supplement research in this, and you're not sold by it. And to be fair, I'm skeptical too, and we're going to talk about this. But we're going to circle back to this question of nutrition is beyond the supplement research, right? There are still conversations that needed to be had with our athletes. But first, I do want to take a look at that research with you. And as you can guess, there's not a lot. This is a really difficult population to study. We are not going to go bang someone on the head and give them a concussion just so we can study and see what happens. So there's very few human trials. There's some really, really promising mouse trials and some stuff, but I don't really care about that because we're not really working with mice. I think it's promising and it's exciting, but not necessarily worth our time today. So we're going to take a look at the limited human trials that exist. First, we're going to talk about omega-3s. And I wanted to start our omega-3 concussion or our omega-3 discussion just by kind of saying we know that omega-3s, and again, specifically that DHA, are incredibly important to the brain. There's some really cool evolution research that suggests that our access as humankind to DHA is why our brain is the size what it is now. That's pretty cool. This is a graph I pulled up for you guys today just to show an example of that. This is from a Women's Health Initiative study that looked at 1,000 postmenopausal women and the hippocampal volume and their amount of DHA, kind of their status basically. And we're seeing about 2 years of brain aging with lower intakes of DHA. So obviously not the population that we're working with, but I just want to set the standard that it's pretty safe to assume that DHA is very important for our brain. Now, there's a whopping total of 2 studies that look at concussions in athletes, and one of them is actually not even a post-concussion. This is a trial that looked at DHA supplementation in football players over the course of a season, and they measured something called NFL. It's neurofilament light. It's supposed to be a measure of brain damage or kind of how those impacts are impacting our brain. And they did 4 groups, so they had a placebo, and then they had 3 groups that had various levels of DHA. Now, what I want to point out here is these are very high levels, right? So 2 grams of DHA specifically is what we're seeing in most of the research. If I went to a CVS right now and pulled an omega-3 supplement off the shelf, it would probably have about 0.5 gram, and that would be a pretty good supplement. So these are high doses. However, it's just a macronutrient. It's just a fat. So it's not that big of a deal, right? And what this graph is showing you over here is just that the athletes were responding to that dose. So we're seeing higher levels of DHA and those that are supplementing with higher levels. So that's a good place to start. All right. If we look at this graph right here, again, we were measuring that neurofilament light, that measure of brain damage throughout a football season. And this black line right here is our starters. So we assume they were taking more impact. And this dotted line right here is our non-starters. So we can see that over the course of the season, that marker of brain damage was increasing. And then if we go below that, we're looking at our placebo group and then all 3 of our treatment groups. So again, we're seeing a significant difference in that marker of brain damage increasing throughout the season in a placebo versus some attenuation of that damage happening when we are supplementing with omega-3s. And then over here, we're just parsing out all groups. We actually did not see a dose response. So this lowest line right here is the 2 gram dose of DHA. They added this starter versus non-starter because this group didn't do a very good job of balancing those groups. We had more non-starters in that 2 gram dose. So you got to take this with a grain of salt. Now, when you look at this slide, you're like, that's really interesting. That's really promising. But when we dig a little bit deeper into this, we can find some problems here. One, there's some questions whether NFL in itself is the correct marker to look at. So that puts a big question mark on this study. And then 2, when they measured levels of NFL throughout a swimming season, they saw similar increases in NFL in the brain for our swimmers, which we would hope are not repeatedly taking contact. So there's some questions here, but at first glance, looks pretty cool. Looks like I should automatically want to supplement all of my players with omega-3. Not so much. We have some questions. This is why our research is a little bit controversial. Now, there is one singular study that looks at omega-3 intake post-concussion, and this is in teenagers, which I love. This was here in Houston with Texas Children's. They were supplementing, again, pretty high dose, but normal to what we see in the research of 2,000 milligrams of DHA per day. They did that for a total of 12 weeks. And what I want to point out here is they had 80% compliance, which is wild. I'm very impressed by that. I don't know if any of you have tried to get teenagers to swallow 6 horse pills a day, but it can be quite challenging, especially if they don't feel good, right? So very impressed with that. Now, what I also love about this particular study is they're not measuring some blood marker or some, arbitrary thing that we're not going to be able to do in our setting. They're measuring days to return. They're measuring days until we are symptom free. And if we're looking at the placebo group, which is this dark line, versus the DHA group, we are seeing a sooner return to play. Now, unfortunately, if we go back, right, you're not seeing any stars or crosses or anything that's showing that this was a significant difference, which is unfortunate. But for me, returning to play 5 days sooner for an athlete, especially if we're in season, that's pretty significant. That's kind of cool. Now, again, we had some problems in this study as well of dividing out our groups. They found out after the fact that almost half of our placebo group already had concussions, so that could be contributing to these results. But I think more importantly, what this is showing is this is safe in our teenage population. So if I have input or buy-in from the athlete and I have the budget, which is the key word here, to potentially do this, and I'm going to throw spaghetti at the wall, it's not going to hurt, and it might get them back to play sooner. That's a really good tool to have in my toolbox. And what we know consistently across the board is DHA or just omega-3 intake in general for Americans, especially American teenagers, is not where we want it to be. And in our athletes, their levels of DHA are not where we want them to be. This is a study coming from American football players where they're showing at about a 4 to 5 on this omega-3 index. We actually want them more towards a 7 or 8. And when I was with USA Volleyball, we did very similar data collection, and we saw similar results with them. And that was in Southern California, where most of them ate fish all the time. Okay, a couple of them played in Japan in the off season. All right, let's switch on over to creatine. Now, again, in theory, we know that creatine stores are going to decrease in the brain. We know that they potentially are staying decreased. And we also know that there's some promising mouse studies. Again, I'm not going to go into those here for the sake of time, and we're not working with mice. There is one lab group that has some interesting research coming out. It's the Scoliosis lab group. They have a couple different papers, but as you can tell by this bottom slide, they're measuring things like ICU stay and duration of intubation. So they're dealing with significantly higher levels of TBI than the concussions, hopefully, that we are seeing, right? So again, we have to take this study with a grain of salt, but this is what we're working with. They are also doing high doses. This is about a 20-gram dose per day. So that's your typical loading dose. Typical maintenance dose of creatine is about 5 grams per day. It's pretty common in creatine research across the board that we're doing a 20-gram dose per day. And again, this study was looking at symptoms. So we're looking at dizziness and fatigue, and we're seeing in our DHA group about 20% of those cases are experiencing dizziness and fatigue, and in our placebo group about 80% of those cases are seeing dizziness and fatigue. So again, we're looking at high doses here, and there's a question mark. Is this a study that we can even apply to our population? Again, what I want to emphasize is creatine is probably the most studied supplement in the world. We know that it's safe. Unless your athlete is taking certain levels or certain acne medication, or they have kidney problems, I feel 100% confident recommending creatine to your athlete. So if your athlete, especially if they're already taking it and they can tolerate it post-concussion, I think that is some safe spaghetti to throw at the wall. I feel pretty good about that one. There are some other trials that haven't made it past the mouse trials yet. I'm keeping these kind of in my back pocket, but not ready to talk about them today. So again, we go back to the big picture here. I made a very kind of mediocre case for omega-3s and for creatine. But let's remember what our athlete needs. They are in an energy crisis. They need calories, they need carbs, they need antioxidant sources, which teenage athletes already struggle with that when they're feeling healthy, right? I would say they need additional omega-3s. I would say it's not a bad idea that they also need creatine supplementation. But how many people in here have had a concussion? I've had a couple. It doesn't feel good. The last thing that I want to do is go prepare a meal or go to the grocery store or use the brain power to figure out what to eat or deal with my nausea just to force something down. This is a major barrier. So yeah, looking at the supplement research is nice and shiny and fun, and it's cool to kind of have a black and white, like do this or don't do this. But at the end of the day, nutrition's role at this table is we need to help our athletes eat. And there's a lot of barriers going on there. So some quick kind of rules for you guys, especially if your athletes are feeling nauseous and they don't have an appetite after their concussion. A conversation worth having is helping them get some sort of food in and how to do that. What we try to encourage is some sort of snack every couple hours, something small. Of course, you can also drink your calories. So there's nothing wrong with Gatorade or chocolate milk or juice or smoothies. And then what I also want to maybe emphasize here is try to withhold any judgment you might have about quote unquote junk food, or probably help parents withhold any judgment they have about their kid eating junk food, because if they can lean into anything that sounds good, if we can make nutrition feel like less of a burden or a challenge, that is a helpful way to get the ball rolling. I worked with an athlete one time who was super nauseous, had no interest in food whatsoever. I said, is there anything you feel like you can eat? And this was a Canadian athlete. He said, I would love a fried Spam sandwich. Okay, great, let's do it. Eating that, not really the most nutritional food source in the world, but the athlete enjoyed it. It helped kickstart his hunger again, and we were able to take it and get rolling from there. So anything is better than nothing. Here's a snack list that I have available for you that you can share with your athletes. We want to try to find things from different categories. So remember that color doesn't have to be just straight up fruit or vegetable. Things like dried fruit or That's It bars are really easy. I want to emphasize tart cherry juice is a really great option. Something, again, if you guys have the budget, that's great to have on hand. King Orchards makes singular 1 ounce shots of tart cherry juice, which we're going to circle back to. Juice also counts, right? Easy calories. Of course, we want to focus on getting carbs in. That's pretty easy for most people. But if we can also add some fats in there, we are going to get more bang for our buck, right? We're going to get more calories from fewer bites. So if your athlete is struggling with hunger, or if they're struggling with nausea, lean on things like mixing peanut butter into their oatmeal. Lean on full-fat dairy products. Lean on trail mix with some M&Ms in it, whatever it looks like. And then if anybody here is working with college athletes, a good thing to do is go on DoorDash with them. And what's a good option that they can DoorDash directly to their dorm? Or if they live with a roommate, can their roommate help them out and bring them something home? Oh, one thing I forgot to mention. So don't be scared to add protein powder to things. Your athlete probably doesn't want to eat chicken. So lean on dairy sources and whey protein. I worked with a strength coach one time. This is a very stereotypical strength coach lunch. He would add protein powder to his PB&J. So in a bowl, he'd put jelly, he'd put peanut butter, he'd mix it all together. I recommend chocolate protein powder for this. And he would put it between 2 sandwiches or 2 pieces of bread. And you know what? It was not that bad. So that is always an option that we can work with as well. Here is a simple menu for you guys that's gonna hit probably their protein goal, about 2,500 calories a day, which is probably pretty close to what most of your athletes should be aiming for, especially if you're in the high school setting. It doesn't have to look complicated. We just need them to eat simple stuff every few hours. The other thing I like to do whenever I'm talking to sports med is see what kind of messaging you guys are getting. I was super happy to look at the NATA position stand. It's the very last bullet point in there, but it's in there that it is important to have these nutrition conversations and just ask the question, are you eating? Are you hungry? How does your stomach feel? and just kind of remind those athletes in the subtle ways that nutrition is an important piece of this puzzle. The other thing that we see with these groups a lot is they don't feel good. They're laying in bed all day long. So they have this belief like, I'm not moving that much. I don't need to eat. I'm not earning it, right? Let's remind them again that their brain is a very important organ and their body is working really, really hard to repair it. And that takes energy, that takes calories. So yes, even though they're laying on the couch all day watching Netflix or trying to get a nap in, they absolutely need calories. I was not as happy to see the AM-SSM position stand, mostly because they are encouraging exogenous ketones as a post-concussion option and the ketogenic diet as a post-concussion option. I worked in a keto lab for my grad school experience, so I'm happy to talk about this and try to be as unbiased as possible. But my thought here is one of the biggest side effects of taking exogenous ketones is nausea. So why are we going to take an athlete who may already be nauseous, who's already in an energy crisis, and add more nausea on top of that? It's not worth it. The research that I showed you about omega-3s and about creatine is better, believe it or not, than the exogenous ketone research. So why the heck are we pushing this? I don't know. Also, a ketogenic diet takes about 6 weeks to fully get into. So again, why are we going to take a brain that's starving for carbohydrates and stop feeding it carbohydrates? So I want to throw this slide in here to make sure that we are not doing this. That's my professional opinion. And then if you remember way at the beginning, I said I want to set you guys up to have something very easy that you can take back to your setting with you. Something that I used to do for the athletic trainers that I work with when I wasn't on the road with them was put just a gallon Ziploc together. Usually they would give me a limit of what their kit could fit. And they'd say, okay, Emily, you can put something that's 3 pounds together. And I'd be like, bet, got it. So in that Ziploc, I would have some instructions. I'd have an example of those snack lists. I would parse out the omega-3s into each day. So we don't have to go through the brain power of calculating. It's already done for them. If I was really good, I would parse out the creatine as well. And sometimes I did that. I had little pouches that I would use an iron to seal shut so that they don't even have to travel with a full tub of creatine. They just get the little pouches that they need. And then usually carbs and color are pretty easy to find on the road, but traveling with a protein source that's not going to be chicken can be really helpful. So these dry dry soup packets can be kind of nice. They just have to add hot water to them, and that can be something comforting to an athlete that doesn't feel very well. The high calorie, protein shakes can be helpful if you're willing to throw it in your bag. And then again, I mentioned King Orchards has those 1 ounce shots basically of tart cherry juice. And I would encourage 2 of those a day as an antioxidant resource. And then just an example for you guys of what I would put on that note card for them. And usually I would include my phone number so that if the athlete has any questions, we don't even have to go through the athletic trainer. They can just call me directly. I'm trying to make things as easy for you as possible. I know that you guys already have a ton on your plate, and I'm not here to add more. Alrighty, that is what I have for you. This is my email if we have any questions. This is my Instagram if you want to follow along. I'll take some questions. Thank you. So clear, no questions. Love that.
All right, thank you, Emily, for that presentation. Our next presenter is Matthew Hutton. He is an assistant athletic trainer with the Houston Dynamo. He has his bachelor's from the University of Iowa and master's from Western Illinois University. He's a certified athletic trainer by the Board of Certification for Athletic Trainers and a licensed athletic trainer by the Texas Department of Licensing and Regulation. He is a certified strength and conditioning specialist by the National Strength and Conditioning Association. He was a former athletic trainer with the Houston Dynamo Academy, Indian Hills Community College in Iowa, Western Illinois University, and Davenport Central High School in Iowa. He holds certifications in dry needling and functional movement screening. Today, Matthew will be presenting on bridging the gap between rehab and reconditioning.
Everybody hear me okay? I can hear myself echo, so I think that means that it's going to work. Thank you all for having me here today. Special thank you to a few people who kind of helped me find my way to this event. I didn't know that it existed until a couple months ago. So Copa, who if anybody works with physical therapy department with Memorial Hermann, they should know her. She's awesome. Kevin, who then introduced me to the event, and then to Bob for getting me set up with it. My favorite part of hearing my introduction is hearing all the places I've been in the state of Iowa. Show of hands, does anybody know where Iowa is on a map? Awesome. That is a lot more than I expected. So good thing that you've all been there or seen it before, because my next slide for everybody who raised their hand is going to be a blank map, and you got to come pinpoint it on the map. This is just to get the elephant in the room addressed. This is my first presentation, so if it's great, tell me. If it's terrible, boos are appropriate, but please save the tomatoes. This suit was just cleaned. I have no financial disclosures, but I do want to address that all thoughts and opinions expressed are my own and not necessarily representative of the Houston Dynamo organization or Major League Soccer. And then I am the founder and owner of my own company, Spotlight Sports Solutions. There are no financial disclosures related to that business. So I like to start with kind of the direction and the overview. And one of my favorite quotes for this is from Yogi Berra. So if you don't know where you're going, you might not get there. Pretty comical quote, but I think it's relevant for rehab return to play. If you don't have a general sense of direction, you could run all over the place doing all kinds of different testing and using different devices to try to get yourself to that end stage. So important to have the right direction before you get started with anything in terms of the details and the nuances. From Simon Sinek's philosophy, I like to start with why. Why are we doing the things that we're doing? And again, it just helps to kind of lay the foundation for the direction that we're headed. So for the bridging of the gap between rehab and reconditioning, it's to minimize the time loss of the athlete that we're working with, or maximizing performance so that once they get back into their return to play, they are the best version of themselves. And then to ensure repeatability. So if you can return one athlete to sports successfully, that's awesome. But if you can only do it once and can never replicate it, then that's not a really good system. So creating a system that can be repeated over and over again. We'll go over a couple of complications and then kind of highlight some keys to success to counter those complications. And we'll do one case study at the end. So one of the first things in terms of the middle stage, obviously the bridging of the gap, the rehab and reconditioning, I think most of us are pretty well versed in the early stage rehab. And Brian gave a great presentation on hamstrings specifically. So obviously I'm coming from a soccer environment. A lot of this conversation is going to be based on my lens, which is soccer, and a lot of the injuries in soccer are hamstrings. So in alignment with Brian's presentation, the Askling-L protocol is great to get them early mobilized, get them moving, get them tolerating some form of exercise. The pain tolerance approach that he highlighted yesterday is definitely something that we put into practice in the professional soccer environment. And then from there, the graded and progressive approach here is really setting yourself up for success in that middle stage. If you haven't laid a successful foundation, the middle stage is always going to crumble. So the lead researchers on hamstring return to play, specifically within the soccer community, are all from Australia. I tried my best to find some Americans. There is precisely one that I can find, and he's at the University of Wisconsin. And so primarily this research is coming out of Australia, but what they were finding is that if you follow a pain threshold approach, you actually reduce the time loss. And so again, keeping with the time loss theme here in the middle stage, you can return them to sport successfully faster. And as Brian highlighted yesterday, this doesn't result in increased re-injury rates. The other thing highlighted here in the references is Tim Gabbett's work and another Australian, and he highlights the importance of the progression of exercise. And really, when you're quantifying that, there's a couple of different ways that you can do it, but there's a bit of disagreement in terms of the loading of athletes, load management. So some people have the approach that we are overloading the injury or the athletes, and that's why they're getting injured in the first place. There are other people that say that they're underloaded and they're not sufficiently loaded to protect themselves from the demands of their sport. So that is an interesting argument, but for the most part, so the one paper that came out from Gabbett was the injury prevention paradox, and this is basically they proved statistically, or their paper suggests that it was proven that the more we can load these athletes, the more we can prepare them for the demands of their sport, and it really does seem to protect them from injury in the long term. The other thing to pay attention to, and we can get into the details of this later, and then we'll really explore it a bit more in the breakout session, but the acute to chronic workload, if you're not familiar with those ratios, essentially there's a trailing load that they would have achieved over the past 3 to 5 weeks tends to be the gold standard. And you see what they achieved over those last 3 to 4 weeks, 3 to 5 weeks. And then you compare that to their current week of loading. And then effectively what that gives you is what that spike would look like. So if they haven't done anything, let's say they're coming off of the off season and they are just sitting around on a couch all summer, when they come back in, they have no chronic load, zero. And so if you have a big week of preseason, that's going to be a massive spike in their acute load. So in comparison of their acute to chronic load, that is a massive spike. That is an injury risk. That has been identified with several pieces of evidence. Getting into the performance side of things. So setting goals for strength, power, endurance. I think this is something that most of us do to some extent, but there's really ways you can get more and more specific. So if you're talking about strength, there's a few different ways you can measure it. Obviously, the cheapest and the most common is going to be a manual muscle test. Everybody does that, right? A slightly more expensive variation would be a handheld dynamometer, and a lot of us are doing this, especially PTs are famous for doing this. And then the most expensive is these specialized strength tests, such as the Nord board or the force frame. Show of hands, who knows what a Nord board is? Whoa. Show of hands, keep your hands up. Who's ever used a Nord board? Okay, so yeah, so clearly not as many people experienced with Nord board as manual muscle tests. So it's a rare device that if you have the luxury of using it, it's really accurate and it can help you kind of map out the strength a lot better of the hamstrings. But there are other workarounds. So I think it's important to distinguish that you have to know what you're testing for in order to accurately measure it. It's not just, oh, throw them on the Nord board and then it's all solved. For the endurance or the power side of things, again, there's more than one way to do it. You have to know what you're trying to measure. So the cheap way would be something like jump tests. This could be a vertical jump and you're just testing to see how much power they can put into the ground. The mid-tier would be something like a jump mat, force mats. A lot of strength and conditioning programs will use these. And then the most expensive version, which gives you a lot more information, is going to be the force decks. And so this is showing Vald's product, but any force plate where you're differentiating left from right will show you the asymmetries and the force time continuum. Another good way to measure the end stage with power is Kaiser products. I don't know if anybody's used those. There's different brands. I'm not partial to Kaiser, but they do make good products, and they put out a power output in wattage, and you can see how much power that is. So power is effectively force multiplied by the velocity. So the faster that you're doing something, then the more power it is. And I think that's something that gets missed in rehab. I think a lot of times we're trying to talk, we talk about increasing strength and we're adding weight to a bar, or we're just loading them up heavier and heavier, but we're not considering the speed aspect of the lift. And that's an important transition from rehab into the on-field return to play. So one of the things that's really helpful for that is the force speed curve and or the force velocity curve. And you can see there's different types of speed work, and effectively the heavier something is, the slower it moves. The faster something moves, the lighter it is. It's impossible to lift something max weight as fast as you would do it with no weight. So when you're starting to transition from rehab and you're loading them up with heavier weights, play around with some of those variables. And there's actually getting to be some pretty good technology in terms of measuring bar speed or measuring weight speed as they're lifting it. Some of those velocity-based trainers measure everything really precisely. They tell you how fast that bar is moving, and they tell you effectively like when fatigue starts to kick in. So you can measure sets, reps much more accurately. Consider the central nervous system demands. This is something that I think isn't discussed enough. I think that it's starting to become more of a mainstream concept, but I don't think it's quite there yet. And so the periodization and really how we load the central nervous system is a big aspect in fatigue and increasing performance. So you can't just go out and lift maximally every single day. Your body needs time to recover. Your muscles obviously need time to recover, but then your central nervous system does as well. So they might not be carrying any soreness in their muscles. So if you have them go out and sprint, for example, maybe their hamstrings are sore the next day, maybe they're not, but I promise you their central nervous system is depleted and they need rest to recover to be able to put out the same power that they had been doing the day before. The other concept is with the end stage rehab, what is our clearance criteria? And so sometimes people will say we need to return them to 90% of their baseline, or we need to return them to 90% of the contralateral side. Well, one, if they're right leg dominant, like they are in soccer most of the time, if you're comparing it to the contralateral side, you're comparing it to the weaker limb. So then 90% of the weaker limb is probably 70, 80% of their dominant limb. So I think that's an interesting aspect that we need to consider when we're clearing people from that exit criteria of these longer term rehabs. A lot of times what we will try to do in our longer term rehabs is actually try to improve their capacity, and we're trying to make them better athletes than they were before they got injured. So if we can, and depending on the time loss, if they're out for a week, we probably don't have enough time to stimulate that. But if they're going to be gone for 2, 3, or in the case of an ACL, maybe 9 to 12 months, why not try to improve their athleticism? Why not try to get them better than they were before injury? And again, this is just a couple of different ways to test it, but there's the important thing here is knowing what you're trying to test, and then knowing different ways that you can test it. So it's easy for me to stand up here and tell you about GPS metrics and say, oh, well, we have to progress this by 10% every week. But if you don't use GPS, then that's impossible to quantify. So how are we measuring things like endurance without the fancy GPS devices? And there's a million different ways that you can do it, but you have to know what you're trying to test. And it's also key to know the different energy systems that you're trying to test that are relevant for the sport. There's a bit of a hot take. There's a guy named Tony Holler, and he's got his Feed the Cat system. And he talks about American football players who are going out and running like around the stadium, or they're doing stairs, and they're doing these really long endurance type of running as punishment. But when do they ever have to run more than 5 minutes in American football? Never. So thinking about the energy demands and the energy systems of the sport and training them to that. So American football players, I'm going to be a lot more likely to use that phosphagen system and try to do short work, bursts of sprint or bursts of high power, something that's less than 10 seconds. And then for an for a soccer player, I'm going to be doing a lot more endurance work, things that are going to be maybe it's 2 to 4 minutes of work followed by a longer bout of rest. So for the repeatability aspect, the best thing to do is to create a system, and it won't be perfect at first. You have to continually go back and forth and try to manipulate these variables to get them dialed into the level that you want to get them to. The stage system seems to be really helpful for this because you can progress or regress according to where they are. This chart is probably too small to see for you, but you can access it online. This is Matt Taberner's Control to Chaos progression, and it basically lays out for professional soccer players, where are we starting this rehab and where are we going, and then how can we smooth that transition? And that it looks at all variables across the sport. So it's not just talking about running. Obviously, that's the easiest one to track, is how much total distance are they running every week, and just progress that safely over their return to play. But it's talking about different variables as well, things like high speed running, max velocity sprinting, change of direction work, things like accelerations, decelerations, and then it's not just measuring the quantity, the volume at which we're doing these different things. We're also looking at the intensity at which they're being done. So I can sit here and accelerate at a walking pace going forward. That would be a change of speed of 1 meter per second squared. Or I can go max effort and I'm getting to the end of the table after 1 second, and that's something like 3 or 4 meters per second squared. So the intensity is also progressed through this chart. This is soccer specific, and the research is really trying to be applicable to a host or a variety of different sports. So you have to take it with a bit of context and apply it to your own setting and your own sport for what makes sense. But the Control the Chaos continuum, things like contact versus non-contact, when are we introducing it and how many reps are we doing when we are doing it? Decision making is another key variable here for them. They talk about the central nervous system load and how stressful it is to be able to read. If you're in a rehab setting doing one-to-one with your athletic trainer, that's really easy to read. You're reading one person's movement. Versus if you're getting thrown back into team training after that, that's a huge spike in central nervous system, all the stimuli. So some of the complications that we will see in our return to play, especially in this middle stage, is what if they're asymptomatic before their tissue is healed? So a lot of times with hamstrings, they're pain-free after maybe 2 or 3 days, right? But the tissue we know is going to take a lot longer to heal. The scar formation is probably taking place up to 2 weeks, and scar remodeling is probably going to take place for another 2 years after the fact. So they are going to be pain-free, and they're going to want to return to their sport, but it's not safe for them to do that. So how do we navigate that? And again, we'll go over the keys to kind of navigate these challenges in the next slide with the keys to success. The other side of that is apprehension during rehab. Let's say timeline-wise, it makes sense that their hamstring is fully healed and they are still dragging their feet with rehab. Maybe they don't want to run. Maybe they don't want to sprint. Maybe they don't want to strike a ball. How are you navigating the apprehension on field? It's easy to just say, oh, you're healed, you're healthy, go out and do it. But in reality, they're going to do it sub-maximally. They're not going to check that box in terms of returning them safely. Compensations and asymmetries are always a problem. And I think, again, if you can eliminate some of these things in the early stages, then that sets you up for success in the middle stage. The biggest one that we will see is the knee extension, and they're not getting into a full knee extension as they're sprinting, that late swing phase that Brian was talking about yesterday. they're going to stay in a bent position to try to protect that hamstring. And this won't get teased out until you're getting into those max velocities. So he suggested 90% yesterday, but we'll go as far as 92, 95%. The closer to 100% you can get, the more activation of the biceps femoris long head. And so that becomes an important piece in the rehab, especially in those asymmetries. Deconditioning is another interesting variable, and this is what you'll see on the chart on the right, what I was alluding to earlier with the acute to chronic workload ratios. And you'll see, so the blue bar on the left of all of these charts, so these are different variables. This is total distance, high-speed running, explosive distance, and sprint distance. And this bar on the left, this tallest one, is what their normal week would look like. As they got injured, they missed a period of time, let's say 3 or 4 weeks. This is what their chronic or trailing load is. And then this is what the weekly load is. So in that first week, you can see they're doing nothing because they're just starting probably indoor rehab, table-based rehab. They start to get introduced to some of these variables, and it's a linear progression. It's a smooth progression up to that restoration somewhere in between that acute to chronic workload. And this is what we like to see. We like to see when it's a really smooth progression or gradient up to that restoring capacity. What we don't want to see is in this second week, it's jumped way back up here after having been down so low a couple of weeks prior. This spike here will result in an injury. It might not be that same week. It might be here, and it's a trailing effect. And there was a really good NATA education, one of the continuing education programs. It's a sports science series. I believe it's number 6 if anybody wants to look that up. They were talking about a wide receiver in the NFL who had a big spike in acute to chronic workload, and then 2 or 3 weeks later had a hamstring injury. And then the last piece, the biggest complication is going to be the re-injury risk. So paying attention to every detail that you can to try to prevent the re-injury. The re-injury throws a wrinkle in everything, and it skews the timelines. It obviously decreases the athlete's confidence in the return to play plan. There's a lot of complications, so avoid re-injury at all costs. Some of the keys to success, create a needs assessment. And I think this is, for me, the biggest piece that helped me kind of learn this return to play. You start with the timeline and you work backwards from there. So if you know that a grade 3 hamstring is going to take you somewhere 6 to 8 weeks, start with that 6 to 8 weeks and work backwards. What do you need to see at week 7? What do you need to see at week 6? What about 5, 4, 3? When do you expect them to be pain-free? When can they start to get on field? You start backwards, and then you'll have a smooth plan in place. Obviously, that can be adjusted depending on where they're at. If they are struggling, then you can shift that back a week. Otherwise, if they're flying, maybe you can move it forward a week. Consider the different adaptations and how long it takes you to achieve them. So we know that strength is probably going to take the longest, and that's going to take somewhere between 6 to 8 weeks at a minimum. Some of the other adaptations that we look at in the hamstring specifically are architectural changes. So things like fascicle length or pennation angle. And we think that those take somewhere between 2 to 4 weeks, minimum 2 weeks. So if you're trying to do a return to play in a week, you probably haven't given sufficient time for those architectural changes if you consider those variables to be important. Some of the other things that you can consider, obviously not every case needs this consideration, but some of the things you can look at: pain, range of motion, strength, power, architectural changes, neuromuscular capacity, cardiorespiratory fitness, and then lastly, the energy systems that we talked about earlier. Again, this is one example of just running, but the gradual progression of forces and volume. So it's not just the gym work, you're progressing everything. As they're going through their first introduction to the on-field work. Can they do ankling drills where they're not really utilizing their hamstrings as much? It's more of an ankle exercise with plantar flexion, dorsiflexion. They're getting into a jog. Again, low forces because it's such a low velocity. The biceps femoris long head specifically is not getting hardly any activation. Then you move into a march, and this could be done one of 2 ways. Either you're doing a really slow controlled march just to get the range of motion and the movement pattern, or you can be driving that leg down into the ground with force, and then you're going to get a lot more activation, and that would kind of bridge that gap. So maybe you start with a slower speed march and you work your way up into a faster march where you're driving force. Brings you into a skip where you get a lot more technical elements and a lot bigger range of motion and a lot more distance covered. and then working your way up into the stride, the sprints, and then one last piece that I wanted to emphasize was the curvilinear running. I think this is something that's underutilized, and there was a good paper that came out roughly 2 years ago talking about the importance of curvilinear running for hamstring specific rehab. So the change of direction is not just always a cut, it can be a curve, and you see the actions in the sport, they make a lot of curved runs. Collaboration is definitely a big piece in our world, keeping all of the key stakeholders involved. So this involves strength and conditioning staff, sports science staff, the technical staff, and the coaches, making sure that everybody has contribution to the return to play. They will see things that you won't. And so covering each other's blind spots is a really good approach. So to get into the case study, this is actually not the MRI from our athlete. I just found this on the internet. But we had a grade 3B. If anybody hasn't learned the BAMIC classifications for muscle strains, I would highly suggest looking into those because those will guide your timelines very accurately. So we had a grade 3B hamstring strain, and that involves semitendinosis as well as the biceps femoris long head conjoint tendon. This was a sprint mechanism. So in our needs assessment, this is kind of what we were considering early stage as we were mapping out the return to play. We wanted pain-free, full active and passive range of motion. We wanted to lengthen his fascicles. He had a history of hamstring injury in the past, and so we know he's prone to hamstring injuries in the future. So we wanted to really take the time to lengthen out those fascicles. The Nordic strength, he was really strong. He had a max, I believe it was close to 500, 492 or something along those lines. And we wanted less than 10% asymmetry. With that, we took into consideration both the absolute and the relative strength. So one, he's really strong, stronger than most of his teammates, but then also what was it relative to his baseline? The graded return to training. So one of the easiest ways you can map out a 4-week return to play is just to take 50% of the training week, 70% of the training week, 80%, 90%, and then ultimately that 5th week would be 100% back in with the team. And with GPS, this makes it way easier. But if you don't have it, you could use something like a time constraint where if it's a 10-minute drill, he's only in it for 5. Max velocity exposure was another important one for us. And again, we wanted to get at or equal to or above the 95% sprint exposure. And then we also wanted to revisit the repeat sprint ability that's position specific. This is a box-to-box winger, so playing both offensively and defensively. So we had to test both the offensive and defensive side of the game. Curved runs were big for us. Being on the wing, he has to make curved runs into the box and defensively. So checking off those curved runs, different hip positions, multiplanar movement while tracking a ball, things like that. Crossing and finishing would be the end product for him. This would be the rough timeline, obviously running short on time, but I'll just fly through this real quick. So injury was on 2/19, PRP injection on the 21st. The early stage rehab, so we calmed pain down after 3 or 4 days and then began that early mobilization on the 4th day. The on-field intro didn't begin until 3/11, and so the first 2 weeks were really the eccentric overloading and the mobilization, getting those fascicles lengthened out, and then ultimately getting into full team training on April 9th, and then getting first game minutes, got 33 minutes on that first game on April 23rd. This is a calendar that we use to monitor the different variables that we deem important. So things like high-speed running, sprint distance, accelerations, decelerations. And then this was his timeline, again, mapping out the importance of different testing dates, the high-low periodization, as well as his return to play. These are my references, and I don't think I saved enough time, so just give the booze now.
He's right up against it. For sake of time, he's going to be in a breakout, so you can get some of those questions in at that point.
Thank you, Matthew. Our next presenter is Lauren Ferrante. She is a physical therapist and pediatric orthopedic program coordinator at Memorial Hermann Sports Medicine and Rehabilitation. She received her bachelor's from Texas A&M University and her doctorate in physical therapy from Texas Tech University Health Sciences Center. She is a fellow with the American Academy of Orthopedic Manual Physical Therapy and board certified in orthopedic physical therapy. She holds certifications in Schroth and dry needling. She is also a member of the Pediatric Orthopedic and Scoliosis, Hip Preservation, and Spine programs with Memorial Hermann. She does community outreach with Baylor High School, Houston ISD, to evaluate and screen athletes. She also serves as a mentor to physical therapists on scoliosis and pediatric orthopedic diagnoses, as well as a PT residency faculty. Today, she'll be presenting on scoliosis-specific rehabilitation.
Howdy, y'all. My name is Lauren Ferrante. I am a physical therapist over at Memorial Hermann Baylor at the Memorial Hermann Rockets Orthopedic Hospital. I have been Schroth trained by probably two different type of Schroth certifications, and I've been treating it for over the past 5 years. So today we're going to do an overview of scoliosis, including also like how is the diagnosis of it, the risk of progression, and then also going through into like the typical examination that you could perform, and also some different phases of exercises that you could perform that is non-Schroth based. So these are going to be successful for treatment for all of us. So scoliosis is defined by a lateral spinal curvature of greater than 10 degrees, is accompanied by a three-dimensional deformity involving vertebral rotation, tilting, and a lateral shift from the vertical axis. Approximately 80% of scoliosis cases are classified as idiopathic, meaning that they have no identifiable underlying cause. Curve progression is going to be most common during periods of rapid growth, so typically in adolescents ages between 10 to 15-year-olds. Scoliosis may involve various regions of the spine, so including the thoracic, lumbar, thoracolumbar, or both a double curve of having the thoracic and the lumbar region. Notably, about 95% of idiopathic cases are going to have a right side thoracic curve, maybe due to the left positioning of the heart on the left side. Scoliosis may initially be suspected by a parent or a healthcare provider upon observing physical asymmetries, such as uneven hips or shoulders. Clinical screening often includes the Adam Forward Bend test, which can reveal a rib or a lumbar prominence indicative of a possible underlying spinal rotation. If scoliosis is suspected, a referral to the pediatrician or pediatric orthopedics is recommended. Optimal imaging is going to consist of full spine PA and lateral views. The PA is going to allow for accurate measurement of the Cobb angle, which quantifies the degree of the lateral curvature, while the lateral view is going to assess the sagittal plane alignment, including the kyphosis and the lordosis. The image right here is a EOS. It's a low dose radiation. Is very unique at very few places. So I think there's like in maybe 2 in Houston. Additional imaging or further neurological evaluation may be warranted in the presence of red flag symptoms. So in case if they have myotone weakness, numbness, tingling, or if they have the presence of the atypical left thoracic curve. The risk of scoliosis may be influenced by several factors, including the magnitude of the spinal curve, the patient's skeletal maturity, and the chronological age of the patient. One commonly used tool to assess skeletal maturity is the resource scale, which evaluates the percentage of ossification of the iliac crest. So the resource scale is going to range from 0 to 5. Resource 0 indicates that no ossification and corresponds to a high risk of a curve progression. A significant growth remains. Resource 3 signifies that the peak of growth has been completed. Resource 5 reflects that complete ossification and fusion of the iliac crest, indicating skeletal maturity and minimal risk of curve progression. We also know by research that typically if a curve maintains less than 40 degrees at skeletal maturity, they have less likelihood of that curve progression into adulthood. So for example, comparing two patients with a 25-degree curve, like an 11-year-old and a 15-year-old, the younger patient has significantly higher risk of curve progression due to remaining growth potential in the pubertal status. So early identification and monitoring are therefore critical in younger patients with moderate curves. Management of adolescent idiopathic scoliosis involves a range of treatment options based on key factors. So looking at the skeletal maturity, the Cobb angle, and the risk of curve progression. The most conservative approach is the physiotherapeutic scoliosis exercise, also known as PSSE. One of the most well-known PSSEs is the Schroth method. When the Cobb angle exceeds 25 degrees and the patient is relatively skeletally immature, then the gold standard is going to be non-surgical intervention, is going to be bracing. Bracing is intended to halt or slow down the progression of the curve during peak growth periods. In cases where the curve exceeds over 50 degrees, then surgical consultation may be recommended due to the likelihood of progression of that curve into adulthood that's going to cause long-term spinal and cardiopulmonary complications. So Schroth therapy is a scoliosis-specific exercise approach that's focused on active spinal auto correction through techniques such as self-elongation, posture correction, and 3D stabilization of the spine. The method is highly individualized with exercises tailored to the patient's specific curve pattern and integrated into the functional movements and activities of daily life. Some treatment options or positions that may be in supine, side-lying, prone, or standing, and it may use specialized equipment such as poles, belts, wedges to assist in achieving spinal elongation and promoting a more neutral alignment. A hallmark of Schroth therapy is also the emphasis on rotational angular breathing, where the patient is taught to breathe into the concavity of the thoracic spine, promoting expansion and improved symmetry of the thoracic cage. This method is most effective in an adolescent population with idiopathic scoliosis, as the spine remains relatively flexible and is not indicated for the older adults due to the reduced mobility available in the spine. It's also not indicated for patients with neuromuscular or congenital scoliosis. So the overall goals for Schroth method or even conservative therapy may include facilitate corrections to the posture or back symmetry and improve the aesthetic look, which enhances the patient's overall self-image and self-esteem. Another goal is to alleviate pain if they have any discomfort. Stabilize the spine to reduce the progression of the curvature through improved body awareness and 3D stabilization of the spine. Promote overall core stability in addition to the hip and shoulder strength and endurance to maintain the posture throughout the day. Improve the flexibility of the spine to allow optimal results for the brace and for the surgery. Also allows improved ability to achieve more symmetric posture the more flexible you are. It also improves respiratory function in those with a larger thoracic magnitude. And finally, patient or family-centric goals. So for example, ability to perform a task more efficiently. So I previously had a ballet dancer who had a difficulty lifting up their right leg because she kept collapsing into her curve. We worked on spinal elongation with appropriate core activation with co-activation of the hip, and taught her how to not collapse into that curve and allowed her to be able to lift that leg up a little bit higher and more efficiently. So these individualized goals are going to assist to drive the patient to participate in therapy and adhere to the home exercise program. So basically, you want to find what is their carrot, to dangle that carrot in front of them to be more likely to participate in therapy. So factor cap, I think that's what these kids call it nowadays. So I cannot swim or play in sports because I have scoliosis. So most research actually indicates that individuals with scoliosis can participate in a wide range of activities, and scoliosis itself does not impose restrictions or physical engagement. It's important to encourage individuals with scoliosis to engage in physical activities that they find enjoyable, as consistent activity plays a crucial role in supporting spinal health. For patients not currently participating in sports, it is beneficial to recommend exploring a variety of activities and allowing them to discover what resonates most to them to participate. Initially, starting with manageable goals, such as walking 20 minutes with their dog, like 5 days a week, is some sort of starting progress. As they initially ease into the regular exercise, they increase the duration and time with it. Over time, the intensity and duration can gradually increase. The overarching goal is to promote greater physical activity as stronger overall body strength and contributes to a more stable and resilient spine. So factor cap, I have back pain because I have scoliosis. So again, research has demonstrated that back pain is not typically associated with scoliosis unless the curve is greater magnitude, meaning over 50 degrees. If a patient reports back pain, a thorough examination should be conducted to identify the underlying cause. It's important to educate both the patient and the family that in most cases, the back pain is not a direct result of the scoliosis. So this can help alleviate the concerns and prevent the development of unnecessary fear, especially in response to preemptive or potentially misleading information found on the internet. Providing clear, evidence-based information can reduce the anxiety about future back pain and promote a more informed and confident approach to managing the condition. In a typical non-scoliosis posture, the body could be visualized as comprising 3 primary structural blocks, including the shoulder girdle, the thoracic segments, and the lumbopelvic complex. These blocks are generally aligned with minimal to no deviation. In contrast to a scoliosis posture, you can visualize the body having 3 to 4 different blocks, depending on the magnitude and where the curve is located. So each anatomical block is going to shift laterally away from the vertical midline. In addition to this lateral displacement, you're going to have a rotation opposite of the adjacent segments. Furthermore, these changes are going to be accompanied by a tilt of the affected blocks, which further alters the proper alignment. So typically also, most of these patients are going to have a right side thoracic curve, which is going to cause a rotation of the right vertebra to the right, contributing to that rib prominence on the right side. When examining the patient with scoliosis, the process may be similar to that of a typical low back evaluation, but we're going to place greater emphasis on some key aspects. So we're going to look for spinal asymmetries and compensatory patterns that these patients may have, may not be as evident as compared to other populations. So posture assessment is going to be a key. We're looking for spinal asymmetries and compensatory patterns. We're also going to evaluate the spinal range of motion in multiple planes and assess the flexibility of muscles commonly involved in postural dysfunction, including the hip flexors, the hamstrings, and even the pectoral muscles. Palpation and joint mobility testing also helps us to identify the areas of hypo or hypermobility of the spine. In addition, breathing mechanics should be assessed, particularly looking in the rib expansion. We want to pay close attention to the left thoracic cavity where expansion may be limited. And lastly, we want to assess strength with a focus on core stability. Plank times give us a snapshot of the core endurance. We also want to look at hip and shoulder strength, which is critical for postural support and for functional movement. During posture assessment, patients may be placed in front of a mirror. This allows both the clinician and the patient to visualize the postural asymmetries and provide real-time education and engagement. Assessment should be conducted from multiple angles, so from the posterior, anterior, and lateral, utilizing a systematic bottom-up approach. This method ensures a comprehensive evaluation of alignment and compensatory patterns. So some key elements to be observed is maybe the pelvic position and a weight shift. So we want to assess for the hip prominence. In the cases of the asymmetry, the patient will shift the weight opposite side of the hip prominence. The patient may also demonstrate an increased internal rotation of the leg and pes valgus on the side of the increased weight shift, which may alter the distal biomechanics chain when they're trying to perform activities such as single leg activities. Trunk to arm spacing, so observing the space between the arms and the torso on both sides. Asymmetries here may lead to indicate that they have a lateral curvature or increased trunk rotation right there. Looking at the spinal curvature, so looking at the lumbar lordosis or the thoracic kyphosis, most of these patients are actually going to have more of a thoracic flat back, unless they have what's called Schirmerman's disease, where they have more of the thoracic kyphosis. You can also look at the scapular positioning, so seeing if one scapula has more winging compared to the other. You also go look at the shoulder symmetry. Is one side a little bit higher or more elevated? Typically, if you have that right side thoracic curve, your right shoulder is actually going to be more forward and elevated. So these observations provides essential information to identifying the curve patterns and informing both clinical reasoning and treatment planning. During spinal range of motion assessment, we often incorporate the Adam forward bend test. This test involves having the patient bend forward at the waist, allowing us to observe the rib and lumbar prominence, which is a common clinical indicator for scoliosis. To quantify this, we could use a scoliometer, which is a non-invasive objective tool that is placed onto the apex of the curve. That's going to measure the angle of trunk rotation. This provides measurable data to help track the progression of the curvature and evaluate the effectiveness of treatment. It's also a useful screening tool, particularly used in a school-age population. An angle greater than 7 degrees is considered typically abnormal and may indicate the need to be evaluated for scoliosis. However, it's still important to note that while the clinical tools like the scoliometer are helpful, the gold standard still to diagnose and manage scoliosis is to be the spine x-rays. When working on posture control, we're going to continue using the bottom-up approach. We start by cueing for a more symmetric weight shift, encouraging the patient to find a base of support. Then we're going to cue core engagement and spinal elongation using cues like be tall, engage your core, and pull your ribs in. It's important to monitor for compensations such as rib flaring, which may occur when patients attempt to achieve elongation without proper core activation. So remember, a lot of these patients still have that thoracic flat back. So when they have those ribs flare out, it's going to cause more of that thoracic flat back. So by engaging that core, it's going to help them achieve a little bit more of that core activation and promote a more natural thoracic kyphosis. Once spinal elongation is well controlled, then we can introduce more targeted corrections, such as the thoracic shift. So again, for those patients with that right side thoracic curve, cueing them to pinch that right shoulder blade down is going to help them open up that left side thoracic concavity for improved symmetric trunk control. Practicing in front of a mirror also helps to reinforce the body awareness and motor learning. This progression allows patients to build the control and proprioception needed to maintain improved alignment throughout the activities in daily life. The progression of care for scoliosis can mimic the general rehab phases that we use for a patient with low back pain. So normal progression for a patient with low back pain may be to calm the pain and motor control and strengthening a neutral spine, followed by dynamic stabilization, and then progression into reactive training, followed by return to sport or high-level activities. The overarching goal is to optimize alignment, motor control, and functional movement in an elongated position with a context of scoliosis-specific exercises. So phase 1 will be posture awareness in a neutral spine. So focus on educating the patient to recognize and maintain a neutral spine in an elongated neutral position. Interventions may include posture cueing, foundational neuromuscular reeducation, and mirror feedback. Phase 2 is going to be strengthening and dynamic stabilization. Once approved alignment is consistently achieved, introducing targeted strengthening and dynamic stabilization within a corrected posture to reinforce the motor control patterns and build endurance. Phase 3 is going to be reactive control, so progress to reactive training that challenges the posture stability under dynamic or unpredictable conditions. So looking at balance activities and functional tasks. Phase 4 is going to be return to sport activity. If appropriate, integrating sport-specific or high-level functional training. That's going to maintain the focus on postural symmetry and movement quality. It's important to note that not all patients will move through all the phases. Their advancement is based on their individual goals, symptom behaviors, and their functional capacity. So in this initial phase of scoliosis rehab, the focus is on improving spinal mobility and introducing a posture awareness in a neutral spine. Improved mobility facilitates optimal spine alignment and establish a foundation for effective corrective movement. Examples of mobility may include the cat-cow, which is going to help immobilize that entire spine, or even thoracic rotation with cues to prevent collapsing into the concavities. From there, we're going to shift our focus to spinal elongation and core stabilization in a neutral alignment. The goal is to promote the more active postural correction while minimizing compensations such again as the rib flaring. So again, early stabilization exercises may include some supine marches with the tactile feedback from the mat for a more symmetrical spinal contact. Additional exercises may include the progressions into dead bug isometrics and also modified side planks or quadruped-based movements, such as primal push. And these, again, cue to elongate the spine, engage the core without flaring the ribs, and in the case of that right thoracic curve, pitching that right shoulder blade down to help promote the opening of the left side thoracic curve. This phase lays the groundwork for dynamic and reactive training, ensuring that the alignment and core control are integrated from the start. As the patient becomes more confident in maintaining a core engagement and neutral spine, we're going to transition to phase 2, where we focus on progressive strengthening, spinal loading, and dynamic stabilization, all while reinforcing the elongation and proper postural alignment. So some examples may include the quadruped progressions. So developing the core control through more advanced variations, including like resisted quadruped row, and then progress into more bird dogs with ongoing cueing for elongation, controlled breathing, and scapular stabilization. Additional exercises may include side planks on a BOSU or modified side planks with rotation. You can also perform like bent over rows. We're going to cue the patient to bend over at the hips, pull those ribs in, and pinch that right shoulder blade down to help promote that left side thoracic opening. You can see kind of the trend of here, working on elongation, core activation, and pinching that right shoulder blade down. You can also perform a pull-off press with the rotations with instructions to avoid collapsing into the curve. So again, at this stage, we're reinforcing posture correction through a more functional full body integration, building the strength and neuromuscular control that were needed to prepare the patient for more complex and sport-specific activities in the later phases. An additional layer within rehab progression involves introducing reactive training while maintaining the elongated spine position. At this stage, the patient should be able to demonstrate sufficient motor control, core strength, and endurance to sustain their upright alignment during dynamic movement. The objective is to challenge the postural control in underload or unpredictable conditions, reinforcing the neuromuscular strategies that was developed in earlier phases. Some examples of the reactive exercises may include medicine ball slams. You can also do like more of an explosive power press with the rotation. You can do tall kneeling chops while on the BOSU, working on dynamic stability. You can also work on overhead carries. That's going to with perturbation force. This phase bridges the foundational performance, preparing the patient for real life and sport-specific demands, while preserving the spinal alignment. In this final phase, the focus is going to shift into integrating postural control into sport-specific or higher-level activities. Training is going to be tailored into individual's activity with progression based on their ability to maintain the alignment under complex motor demands. For example, a ballet dancer, we may begin using PVC pipes to help with spinal elongation and working on the kicks. As the patient becomes more confident and be able to maintain the elongation, we could take away the external supports while still trying to challenge her to maintain that spinal elongation with the kicks. It is important to recognize again that the patients may move fluidly between phases, depending on the treatment goals, symptom presentation, and functional demands. This adaptability along for ongoing refinement of motor control and alignment of the as patient progresses. Scoliosis-specific exercises are just one of the treatment approaches available. Another valuable intervention may be manual therapy, which can include joint and soft tissue mobilizations to the ribs, thoracic spine, and the lumbar spine. The goal of the manual therapy is, in this context, is one, to reduce the pain, progress the spinal mobility, enhance muscle activation, and improve the better overall function. Ultimately, by improving the mobility and soft tissue flexibility, we're creating a more favorable environment for the patient to achieve and maintain an upright position. Initially, we may recommend these patients to come in twice a week to ensure that the patient becomes more comfortable with finding and maintaining the correct posture. As they become more independent in finding that posture and that neutral spine, we could start tapering down to maybe like once a week or every other week, depending on the patient's and family needs. It's important to be mindful of burnout for particularly younger patients because they may demonstrate decreased motivation and participation in the activities. Another thing that we encourage the patient is to correct the posture throughout the day. So anytime they see a mirror or they look at the phone or their watch, we're going to use that as a reminder to work on the posture. These small, consistent reminders throughout the day helps to build a new posture, become more sustainable in real-life activities. We have 9 great therapists at 8 different locations throughout Houston. We're looking to hopefully expand more strong therapists in our regions. So if you have any questions and concerns, you're always welcome to reach out to one of us. Yes. Okay.
Same thing's going to apply for the sake of time. Since she's in a breakout, we're going to keep those questions in that breakout session. And again, for on Zoom, they are being recorded, so you should be able to zoom in and ask some that they hopefully can get to as well.
Our next presenter is Dr. Robert Fillick. He is a director of shoulder reconstructive surgery and assistant professor with the Department of Orthopedic Surgery at the McGovern Medical School at the University of Texas Health Science Center at Houston. He is also affiliated with Memorial Hermann Rocket Sports Medicine Institute. He received his bachelor's degree from Texas A&M University. And from there, he's also an NCAA Baseball Academic All-American. He received his medical degree from University of Texas Medical School at Houston. He completed his surgical internship at Massachusetts General Hospital Department of Surgery, his residency with Harvard Combined Orthopedic Residency Program in Massachusetts. He completed a sports medicine fellowship at Union Memorial Hospital in Maryland, most notably with the Baltimore Ravens and Washington Nationals. He also completed a shoulder fellowship at Alps Surgery Institute in France, training in shoulder arthroscopy and arthroplasty with a focus on reconstructive and arthroscopic techniques. He's a team physician for the University of Houston's baseball team, as well as Texas A&M University Athletics. Today, Dr. Fillick will be presenting on shoulder injuries in the athlete.
All right. Thank you, everybody. It's a pleasure to be here. I think I was going to rename this talk, discuss everything in your practice in 20 to 30 minutes, but we'll try to get through as much of it as we can. Those of you who I haven't met, I think we'll get the chance to visit in the breakouts. So we'll cut the questions short at the end and then manage them during the session. So a lot to cover here. I think, we're in an interesting time of evolution with regard to management of the athlete, whether you're an athletic trainer, therapist, team physician, coach. NIL and other aspects are really causing a change in dynamics of care of the athlete. So sometimes I wonder, as it says, how did we get here? But I'm not sure we're going back anytime soon. So I think the first thing I would stress is how important communication is as the team taking care of these athletes. So we'll just start off there. Now, treatment of the athlete, being an orthopedic surgeon, to me, nothing is more important than anatomy. If you don't know what you're looking at, then it's hard to accurately diagnose it. We'll start with reviewing the rotator cuff. And so obviously this is a complex, layered environment, but Dr. Houston once said orthopedic surgery is 95% anatomy and the rest is a little bit of common sense. Unfortunately, in this world, there's not a lot of common sense out there. So, looking at general anatomy, see if the cursor works here. So, here we're looking at the shoulder from superiorly. Rotator cuff is probably the most common injury I see in general in my population. Now, today I'm focused more on the younger athlete, but we know in the throwing population, a lot of rotator cuff tears do indeed occur. We've got supraspinatus superiorly, which is the main elevator of the arm, infraspinatus posteriorly, your subscapularis, which is hard to see on this image, more anteriorly, and then teres minor in the back. All of these can be injured, but a majority of our injuries are going to be really in that supraspinatus. And when you get a throwing athlete, especially, that is constantly in that abducted external rotated position, you're going to get some internal impingement between the labrum and that articular surface of the cuff. That's where we see a lot of those injuries. Now, what is interesting is when I was in medical school, this was kind of the classic rotator cuff orientation or insertional anatomy, if you will. So this is the greater tuberosity looking from above. And so here you can see the supraspinatus insertional site and the infraspinatus seem to be kind of a 1-to-1 ratio. But Mochizuki et al. From Korea and Japan looked at the insertional site, and they did a lot of staining and a lot of very intricate dissections. And what we find is the supraspinatus insertion is actually much smaller. So these things are always, as we get more and more information and knowledge, our surgical repair techniques and evaluation are changing constantly. Looking at this insertional anatomy, again, this is an older model where you see the supraspinatus is a large insertion. Now, indeed, it looks like that insertion's much smaller and much more anterior. So I would say in general, I rarely see an isolated single tendon tear. Almost all of the tears that I see involve the supraspinatus and at least a portion of the infraspinatus as it swings from posterior to anterior where they overlap or become the conjoint tendon. So insertional, this is a female specimen. I would say in most females, their insertional anatomy from medial to lateral is about 13 millimeters or so, whereas males would be more like 15 or 16 millimeters. The reason that's important to know is if I've got a 6 millimeter tear in a female, that's almost 50%. That could be considered a moderate or high grade lesion, whereas in a male, you might call it more low grade. So some of these measurements do indeed matter. Now, if we're looking at the layered phenomenon, you see this bursal-sided layer of the rotator cuff followed by the articular side deep. Then you've got Sharpie's fibers inserting onto bone. So it's quite complex. And when we're repairing these structures, what is vexing for surgeons like myself is we can recreate scar and recreate insertional anatomy, but we cannot recreate those natural Sharpie's fibers. So I think the future is looking at biologics and other things. We've more or less maximized our ability to biomechanically repair things. Now it's about getting them to heal more back to normal. So I think that's really the holy grail of the future. I'm not going to beat you to death with classifications. There's more than I would care to talk about. Elman initially came up with a classification looking at, very low grade. Grade 2 is more than 50%, and then grade 3 strain of the rotator cuff would be a complete tear, similar to many of the others. There's the Pate classification by Dr. Pate in France, and then Dr. Snyder at Southern California Orthopedic Institute came up with another one. The point is not to know all of these, it's just to say when we're evaluating these structures, really size of tear is ultimately what matters. Now, when looking at rotator cuff tears, the etiology or really where do these come from? Now, intrinsic patterns happen. These happen in the aging population. Again, not necessarily what we're looking at today, but if they've got intrinsic spurring and also natural changes to the tendons. So naturally our cartilage structures and our tendons lose water content and the collagen changes over time. So you look at a 60-year-old patient, it may be normal for them to come in with a rotator cuff tear in the absence of any type of injury. Now that's opposed to the thrower or someone with extrinsic type issues. Now, most notably, I think all of you have heard of kind of different types of acromial morphology. So the shoulder blade or the anterior acromion can be flat, which is a type 1 acromion, slightly curved, which is a type 2. Neither of those have been shown to correlate with rotator cuff tearing. A type 3, where there's actually a large spur, does correlate with increased rates of rotator cuff tearing. So these are important things to look at. Looking at spurs from the AC joint that can impinge on the musculotendinous unit of the rotator cuff, these things become relevant. There's more and more attention being drawn to the coracoid and subcoracoid impingement on the subscapularis anteriorly. These are still ideas that are developing in the literature. So when we look at pathophysiology in our throwers, obviously this is a repetitive overuse type phenomenon. You get muscle fatigue, oftentimes, glenohumeral internal rotation deficit, posterior capsular tightness. This leads to a series of kind of dysfunctional movements in the shoulder, leading to tensile overload of the structures. Ultimately, labral tears and rotator cuff tears are a result. So if you look at the incidence of rotator cuff tears, this is just to show you it's all over the map. When I trained, my mentors said, hey, people under the age of 40 don't get rotator cuff tears. Maybe 2 or 3 years ago, I saw a free safety from Katy ISD. He had tackled someone as a free safety. He had supraspinatus and infraspinatus tendons torn, retracted to the mid-humeral head. So for a 17-year-old, that's a really large tear. So these things do happen. So you've got to keep them in the back of your mind. But under 40, we can say I think tears are relatively young outside of pretty significant trauma. I will say I think something's changing because I'm seeing more and more younger patients with significant rotator cuff pathology. Now, looking at this, I think especially in the thrower, we're looking at a younger patient population. Everyone here almost certainly is treating this younger population. They may have really very little dysfunction. Most of their activities overhead are exacerbating the problem. They may note a trauma, but in many cases they will not. A lot of them have such a strong deltoid that they're able to compensate fairly well. And so you're not going to see a 4 out of 5 jobs where it's, there's significant compensation unless you see them immediately after some kind of traumatic event. So you may say, well, their cuff's pretty strong, but they can compensate and fool you. Now, examination, which we'll go through a lot more in the breakout sessions. Obviously, impingement signs are important. Both Neer and Hawkins impingement signs tell you at least is on the spectrum of disease. Do they have bursitis? Could it be a partial thickness cuff tear? What's going on? But at least something in the subacromial space is a problem. Again, these athletes will usually have reasonable strength. Only in the chronic progression of disease will they have atrophy. So all these things you need to take a close look at. Now, looking at workup, this image you see here is a CT arthrogram in France where I did my shoulder fellowship. CT scans were kind of on every neighborhood corner. So many patients came in with CT arthrograms rather than MRIs. MRIs were less readily available. You can see here pretty clearly that this is a partial thickness articular-sided rotator cuff tear in a handball athlete. So, you can see these with CT scans, but here in the States, obviously MRI is the treatment of choice. If you've got someone with pain, sometimes we'll do a diagnostic injection, maybe AC joint, because they've got overlapping pathology that can help you hone in on what's going on. I think for all of you here, working with your athletes, how many people in here take care of football athletes? So I would guess a majority, but, repetitive contact athletes are going to be at a higher risk. We know that, but knowing your sport, knowing what kinds of injuries turn up on a consistent basis, and then really knowing your athletes. I think that's what it's really coming down to, is knowing how to talk to each specific athlete. Some of them are maybe a little more knowledgeable about their problem compared to others. Some are very tough. We know that the pain thresholds for different athletes are quite different. One will present with a very minor problem with severe pain. The other one will have a significant problem with essentially no pain. So a couple years ago, I worked the NFL Combine with the Baltimore Ravens, and a gentleman who ran, I think he ran a 4.27 40 in the Combine, had complete bone-on-bone arthritis of his left ankle with essentially 0 degrees of motion. Some people can push through some things and do pretty remarkable stuff despite significant injuries. Knowing who those gamers are who are probably likely to push through, whether it's a concussion or some other kind of injury like shoulder instability, it's important to know because they may be telling you a picture of I'm doing fine when in actuality they are not. So looking at the history, this is by far the most important anytime we're evaluating our athletes. Looking at their age, looking at their dominance. In the throwing situation, are they a everyday pitcher? What have their pitch counts been? All these things are extremely important. How long have they been throwing? I know Dr. Melhoff was a team physician for the Astros, and I think I lived in his office between the age of about 10 and 13 years of age. So I've thrown really since 8 years of age. I threw a curveball the whole time. Now I'm paying the price for that with regard to the health of my shoulder. But nonetheless, kids are playing on multiple teams. They're throwing constantly. These are the things you need to know when looking at these kids. Have they had problems in the past? Have they had treatment in the past? I saw a kid a few weeks ago. He had a letter jacket on that said 2015 Tommy John surgery when he was 13 years of age. So, these things are happening more and more commonly. Do our athletes have weakness? Are they complaining of fatigue? Do they have instability? Are there mechanical symptoms, catching, popping? All these things lead you down a pathway of that differential diagnosis that you can get a better idea of what's going on. Never forget the scapula. Probably the most common thing that I see in many, especially thin female athletes, is something called snapping scapula. They come in with repetitive popping. They've seen multiple doctors for 5 to 7 years, and it's actually their scapula that's popping rather than anything in the glenohumeral joint. So that's just something to throw out there. Now, looking at symptoms, when I see a pitcher specifically, is there pain in late cocking? Is it during acceleration? I find most of the problems are after release of the ball during deceleration. That's when a lot of traction is placed upon the labrum, the bicep, and the rotator cuff. In general, prognostically, when it's after release, those problems have been easier for me to deal with compared to those in late cocking and acceleration. These are little things to take into consideration. How much does it hurt? What's the quality? Is it sharp? That can tell you it may be labrum rather than, a dull achy tendonitis type problem. What makes it better? What makes it worse? Clearly, in this case, we're talking about throwing. And again, have they had previous surgery or treatment? Now, a few pearls to look at, like I said, I think location is pretty important. Anterior problems tend to be bicep, tend to be more tendonitis related, except for, that very posterior rotator cuff in the thrower. Those things usually get better with conservative management. Obviously, not all of them. If we're talking about micro instability over time, sometimes those things do not get better with a rotator cuff program. And then especially if they've got mechanical symptoms, then sometimes that says I may have to take, the level of treatment up a notch or two. Let me go back. Neurologic complaints are one thing you don't want to overlook. I always tell the fellows that I train on a daily basis that I think a lot of thoracic outlet syndrome sees me, but I don't necessarily see it. So I've got to be vigilant about really evaluating every patient for each of these problems and not cutting corners. Cutting corners, at least in my practice, is where you miss things. Now, on the exam, again, I'm going to just kind of run through this quickly, but you really need to be disciplined. You've got to go step by step. You've got to see everything. You've got to touch most things. Now, when you hear the history from the patient, you can be more focused in that examination. However, like I said, until you really know, you've got to test everything and then be consistent in doing that. Now, I like to do most of my examinations standing, except for stability and a couple other things, but I just feel more comfortable doing it that way. I find that I miss fewer things in doing it that way. I'm going to obviously inspect first, look at muscle development, look for any signs of atrophy, especially within the rotator cuff. What is their range of motion? You've got to be very careful because, many patients look like they have normal motion, but they may be compensating in a certain way, which may give you ideas of what's going on. Looking at the scapula, looking for scapular dyskinesis or winging is extremely important, especially in our repetitive overhead athletes. Now, the posterior shoulder, in any thrower, especially any bench presser, it takes a pretty significant beating. In the thrower, that kind of late cocking phase, there's significant compression of the labrum and the rotator cuff. And then, like I said before, in deceleration, there's significant traction as that arm is trying to decelerate, sometimes from 100 miles an hour to zero. I like to get patients prone. I think you can see the musculature really well. I can palpate everything. I think those posterior structures like teres major, long-headed tricep, and other structures get kind of a little bit left out of the examination. In some of these throwers, they can get repetitive traction on the axillary nerve and what's called quadrilateral space syndrome. We'll talk a little bit more about that, but these are things that you can see on in a common scenario. So, O'Brien's exam, we've all seen this. This is for superior labral pathology. I did basically a breakout session with Dr. O'Brien himself and found out I was doing O'Brien's examination completely wrong. So that was good. But, basically he said, bring the arm, both hands up in front. We'll talk about this in the breakout and push them to the contralateral pocket. That's how he did it. And obviously pain or weakness indicates a positive sign there. However, in the thrower, rotator cuff disease, rotator cuff tendonitis can be a little bit overlapping with that. That's when our imaging comes in. If they've got repetitive symptoms for significant amounts of time, then those are things you want to look at a little more closely by MRI. Now, posterior impingement maneuvers, obviously abduction, external rotation. I try to recreate the throwing athlete's slot. see if they have pain. A lot of times these respond really nicely to corticosteroid injections and physical therapy. Just a few things that I'm looking at daily. Now, as I said before, thoracic outlet, I don't want to beat a dead horse here, but these are things that you look at. Now there's more and more case studies looking at arterial dissection of the artery, the axillary artery in the thrower. There's thrombosis of the subclavian vein from the high tensile forces that these people are putting on their structures. So these are things you got to look at. I like the modified Adsons and modified Wright's maneuvers where you bring the arm in the abduction, external rotated position. I like for them to turn their head to the contralateral side and have them open. And I think on Monday, I saw two athletes where their pulse was completely obliterated through that maneuver. So it is consistent, at least with some form of thoracic outlet syndrome. Now, we'll skip through a little bit of this, but the quadrilateral space really is this governed by the teres major superiorly, the long head of the tricep laterally, and the humeral shaft on the medial side, but there can get those structures, the posterior circumflex artery and the axillary nerve can get impinged. This is going slower than I thought, so I'm going to move ahead. So again, looking at the throwing shoulder, this is really quintessentially what we're looking at. So I believe almost all throwers, their problems start with glenohumeral internal rotation deficit or GERD. And so really what we're looking at is a loss in the arc of motion of the athlete. So most athletes may go to slightly, so if I've got them supine, this is 0, this is 90. They go to probably 100 to 105 degrees on the throwing side, where their non-throwing side, they may get to 90. That's fine. So if they get 15 more here, if they lose 15 here, that's okay. But if they have 15 more here, but they've lost 60 of internal rotation, they've lost 45 degrees of their entire arc. Well, that's going to lead to chronic, pathologic changes in the shoulder, leading to rotator cuff and labral pathology in the future. These are things that we have to remedy, and we can talk about that a little bit later. But ultimately, the prevention of posterior capsular tightness through sleeper stretching and consistent physical therapy and consistent rotator cuff band work is the solution. So moving ahead, injury mechanism is extremely important. For all of you taking care of contact athletes, injuries to the AC joint are unbelievably common. There's been studies in the past, this mechanism here, obviously not common to what we'll see here in America, but this guy's likely landing on the top of his shoulder, and that can lead to AC joint injuries. On the physical exam, you've got to disrobe them. You've got to see the shoulder well. You want to look for tenderness at the AC joint. They're going to have cuff weakness. They're going to have weakness related to pain. Their O'Brien's is going to be positive in the acute setting if you're catching them within the first 1 to 2 weeks. These can be extremely painful injuries to evaluate, but unfortunately, they're extremely common. Physical exam, really inspection is number one. You're going to see some level of deformity or tenderness at that area. If they come off a bicycle or come down on the turf, they're not padded, then abrasions are quite common. I've had some abrasions so significant that we actually had to delay surgery because you can't make significant incisions through those abrasions because of the increased risk of infection. So looking at this, this is an AP, kind of a bastardized AP, and then an axillary lateral of an AC joint separation. And what I wanted to point out here is you can see significant superior elevation of the clavicle in relation to the acromion. What we really look for as surgeons is increase in the corticoclavicular distance. So this is the coracoid process here anteriorly. And this normal distance is 11 millimeters. In this case, this measures about 23 or 24 millimeters, showing it's over 100% displaced. So this would be more aptly called a type 5. Now, we'll talk about the classifications here in just a moment. But, there's type 1 through type 5. Type 6. As of this point in my practice, I've never seen a type 6. That's where the clavicle goes underneath the coracoid process. That's usually from very high level energy mechanisms, which I do see in the med center, but at this point, I've never seen a type 6. Now, the intra and inter observer reliability, meaning when they show surgeons these radiographs, we're not very good at telling what's a type 3 and what's a type 5. So basically, I go through with the patient, make an individualized treatment decision with that patient on is conservative management versus surgical management appropriate for that patient. It clearly depends on sport. It depends on time of the year. So it's a very complex situation. But I think with all of us making shared decision-making with our athletes is ideal. So looking at the x-rays, a standard AP is good. A Zanka view is where you shoot 10 degrees from inferior to superior at the AC joint. That shows the displacement a little bit better. Personally, I don't do stress views where they hold weights. That has not been beneficial in my practice. So here's the Zanka view. The anatomy is super important, especially if you're going to reconstruct it. But in the type 3 injuries, the corticoclavicular ligaments, this is the conoid and the trapezoid ligament you see here, and the AC joint ligaments and capsule are the most important. The AC ligaments here provide for anterior posterior stability, whereas the corticoclavicular ligaments provide for superior and inferior stabilization of the distal clavicle. So when you have a type 3 or more, all of those ligaments are injured. So that's what we're really interested in evaluating. There are, this is just Gus Mazaka out of UConn did some studies looking at the section of these ligaments, showing kind of what they did. Now, again, this is type 1 through type 6, as I said before. A type 5 is more than 100% increase in the corticoclavicular distance, which was consistent with the radiographs that we saw a minute ago. These things are really going to dictate. The classic kind of dictum has been if it's a type 5 or a type 6, then those need automatic surgery. Type 3s are in general treated conservatively. Now, we're getting into a little gray zone where we talk about 3As now. So 3As, if treated conservatively, become stable over time. They do not need surgery. They do quite well. And what the studies have shown is return to play and return to work are quicker with conservative measures. Those type 3s treated chronically that continue to be posteriorly unstable are called a 3B. Those oftentimes in my hands end up needing surgical reconstruction. So that's throwing out a little bit of nuance for you there. So again, usually fall into an abducted shoulder. Now, these are about 9% of shoulder girdle injuries that are sustained during sports. That's a pretty big number for the athletes that we take care of. And Gus Mazaka, again, showed about 40% of shoulder injuries in the athlete are indeed involving the AC joint. So you need to know that a lot of these, up to 20%, have a labral tear. So you've got to be aware and have a high index of suspicion to find these. Conservative treatment for the type 3s and lowers, usually between 2 and 6 weeks, that athlete can get back. Sometimes they need maybe a pain relieving injection before contact, but those are possible. And then we talk about reconstruction, and I won't belabor the point too much here. I'm now moving on to a technique. I make about a 3-centimeter incision over the distal clavicle. I then pass a semitendinosus allograft or autograft, depending on what the patient prefers, along with a cerclage device. The cerclage device is made out of polyester. It's basically a tape type structure that looks like a shoestring, but it's extremely strong. We pass that around the coracoid and then around the clavicle, and we have a tensioning device, which I'll show you here. That device puts about 60 newtons of force, and you can see under x-ray where the clavicle will slowly reduce. Then we tie the allograft over the top and then sew it together. Since I've been doing this, I've only had one failure. I've done quite a few of these, so it's really kind of reduced our failure rate. Some of the other constructs used to loosen over time, so you would reduce it in surgery, and over time you would see it just gradually creep back up. So you take a type 5, make it a 0, and then over time it would become a mild kind of type 2. So I think our techniques are getting better. I would be remiss not to mention the sternoclavicular joint. Anterior instability is the most common, but when you see these in your athletes, some of the bigger guys, you will not see a deformity. Some of the thinner, especially female athletes, you will see when it's posteriorly displaced. If you have the ability to get x-rays at your facilities, I understand like at A&M, that's pretty easy, but in some places you will not. What you will see actually is that on even an AP chest view, you'll see the collarbones or the clavicles are at different heights. So usually when the clavicle goes inferiorly, that's a posterior displacement. If it's more superior, then that's more of an anterior displacement. The posterior ones are really the ones you want to get to the doctor as quickly as you possibly can. That can impinge on the medial sternal structures and be a significant risk for the patient. So going finally, reconstructing these is actually a lot of fun. I usually have a thoracic surgeon there, more for medical, legal considerations. And, we use the semitendinosus allograft here and weave it through. We just have to make sure the structures underneath are well protected. So just one more minute here, I would be, remiss if I didn't talk about instability. Clearly, any of these topics, we could talk for, an entire 30 minutes or an hour about all of them. Clearly, anterior instability is going to be the most common form of instability, except in your linemen, and chronic pushers. The dynamic stabilizers, the anterior inferior glenohumeral ligament and posterior inferior glenohumeral ligament are really kind of the crux. And the way I like to look at the glenohumeral ligaments is the farther adducted the arm is, the more the superior ligaments become very important. So the superior ligament is really important for inferior stability when the arm is adducted, whereas the inferior ligaments become important as the athlete is in the position of abduction. That's a good way to break it down. So looking at this real quick, we know we can treat them with braces. One reason I don't like braces is it minimizes their range of motion, and it really depends on the type of athlete. Like that may be more tolerated by a linebacker compared to a thrower who cannot tolerate any loss of motion. So I've overrun my time by a minute. I apologize. We could continue talking, but look forward to visiting with you in the breakout session, and we can talk more about focused examination. Thank you.
Testing, 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 test. Mic check. Testing 1, 2, 3. 1, 2, 3. Testing 1, 2, 3. Test, test.
this on? Okay, great. Well, I think we're here basically to talk about my philosophy. If you get 100 surgeons, you're going to get 100 different types of shoulder examinations and what our preferences are. What was your name again? Sheldon. So Sheldon's been nice enough to kind of volunteer here, not to, body shame anyone, but it is good to get shirts off. And, I'm guilty of missing maybe a few diagnoses in my career, just cutting corners and not, because you're in everything now is see more patients, use your time more wisely. But in order to make appropriate diagnoses, you've got to be consistent, as I said during the presentation earlier. So, clearly we would have already talked about, okay, why is your shoulder hurting? What types, was there a one-time injury? Is this a chronic problem? Have you ever had surgery? All these things are very important with regard to your mental framework with which you're going to address the athlete or the patient that's there with you. Things that are important for me, obviously, are seeing the entire shoulder girdle, assessing for atrophy, watching their patterns of movement, watching the scapular shoulder blade, how does it track? All these things are very important because one may be leading to the other. And that's what you don't want to miss, okay? And so you mind taking your shirt off real quick, Sheldon? Thank you so much. Where would you like him? That's perfect. Okay, so what I'm usually going to do is just assess the athlete here and look and say, okay, he's already got incisions, so I know you've had something done before? Or are those not incisions? No.
I got it cut on a little bit.
Yep. So that's what we're seeing. And so you learn these little things and you say, okay, so far everything looks pretty good, good muscle mass. He's got a little bit of thoracic kyphosis. So he's a little, everyone's going to be morphologically a little bit different. That could indeed affect his shoulder, his scapular range of motion a little bit, leading to maybe not as full of motion as some of you thinner females in here. Those are just the types of things we're looking at. Now, first thing that I look at is, okay, I don't see any muscle wasting necessarily. We've seen the incisions. Spine overall looks relatively neutral. If I'm worried about it, I will have them kind of bend over and touch their toes, see if there's any significant scoliotic deformity, because you'll see the ribs being different height on one level or the other. I'm certainly not a spine specialist, but every day I get ridiculous symptoms from the neck into the shoulder, so I have to be at least somewhat adept at examining the cervical spine. So what I'll do is I'll compress the cervical spine first, and then I'll assess his motion. If they get pain, then that can indicate maybe a disc or another problem. Bring your chin down to your chest for me, and now look up to the ceiling, so all the way up. If I see some restriction in motion, many people with a cervical disc or a herniated disc, they'll kind of struggle to turn one way or the other. They may turn their shoulders because their neck is stiff, secondary to pain. Those are little things that I'm looking at. Now, I'm going to have you slowly, when we're talking about the shoulders, I have you slowly raise your arms up above, if you would. Go ahead. All right, so now come down even more slowly. So now I'm looking to say, okay, are the shoulder blades starting to wing, or are they, is there any tremor or anything else going on showing some subtle weakness? In this case, everything we would expect to be normal, and indeed it is. Now I'm going to have you shrug your shoulders straight up. And then I'm just looking at all little things, and so go ahead and relax your arms down. Now, sometimes people with cuff pathology, so if they have partial thickness cuffs, they'll go here, and what I call a painful arc of motion, when they get this little hitch, and they'll get a sharp pain, and then they have to kind of bring the arm in. That's the classic someone protecting from either severe bursitis or a partial thickness rotator cuff tear. These are subtle things I'm looking at that the patient doesn't even know that that's actually part of the examination. So it's not all pushing and touching. There are a lot of other subtleties, but when you guys are in the training room, take the time, the more I hated my fellowship because we went right from football. I'm joking when I say that, but we went right from football to lacrosse. And I'm like, I've got a newborn child at home, I'm never home. But I got to examine thousands of athletes, and I just got better and better and better. So the better you get, the more confidence you have, and so on. Go ahead and throw your shirt back on, and then we'll keep looking at strength and other things. But that's just one thing, talking about if you have an athlete that tackles someone, you've got to get their pads off, look at their AC joint, see if there's deformity. Those can be really painful. I remember my dad told me a story where Emmitt Smith had a grade 2 AC separation in one of the Super Bowls. Well, he came out, he continued to play, and everybody's like, man, he must have a really high pain tolerance. Those injuries hurt. And so you got to make sure they're not a type 3 or a type 5. That may be a bigger issue, so you can give the athlete a little more prognostic indication of how long they might be out. Okay. Now, real quick, raise your arm straight up. So this is just a basic way I go about it. So he's got, pretty symmetric motion. Do you feel like your motion in general is pretty good on this side, or do you have some limitations? Yep. Okay. Come on back down. And so someone with previous surgery, I don't know if he had at this point labral surgery, cuff surgery, or just, removal of a bone spur. I'm not sure. I'm not here to air but what I'm getting at is you'll see some people go here, and then you'll see just a subtle kind of thing here. And then what a lot of people do is they'll go here and they'll move the non-injured shoulder to the same extent that they move the injured shoulder. And I'm like, what's wrong with your left one? And then they go, oh, nothing. And so you've got to be clear, because I think our mindset gets into a level of protection if the athlete is significantly injured. Now, I like to pin the elbows in here, and I like to see. And so indeed, typical to most males, he may get to 45 or 50 degrees. So if this is 0, I'm assessing, and if I get a 40-year-old female that is markedly limited and their radiographs show no arthritis, then I'm thinking adhesive capsulitis and things. Not common in our athletes, but these are just the things that automatically come into my mindset, because I need to get in and out and get moving, but make the right diagnosis at the same time. Makes sense. Absolutely. Yep, absolutely. So what I'm looking at here is he's got symmetric motion, but I'm looking for real subtleties and kind of, hey, is this one tighter? Is the anterior capsule tight? What's going on? And then I can correlate that with any radiographic findings to say, okay, maybe this is early arthritis, because I'm seeing, 18 and 20-year-olds with severe arthritis. I have a 26-year-old in my practice that has the worst arthritis of anyone in my practice. I mean, that's a big life changer for a young athlete. He had a surgery that unfortunately didn't go well, and then comes to me with end-stage arthritis. That's somebody that's hard to treat. And when you see him go like this, you go, I really need to look at those x-rays and see what's going on. Okay, now give me both hands, please. So now I'm going to start my rotator cuff evaluation. I've already started it when I watch you move, so I can see, are there any, hitches, any mechanical symptoms. Now I bring them up in the scapular plane. So this would be Job's maneuver, and I'm going to have you push up to the ceiling. Okay, very good. So what I'm looking for, you can relax down. I'm looking not only for, does he have symmetric strength? I'm looking for, does the shoulder go down? But in a younger man like him, most will not drop, but they'll raise the shoulder. So they're compensating. I don't know if everyone can see that. They're compensating with the deltoid. And I imagine your deltoid is strong enough where I would say, oh, he's not focally weak. But if I see this maneuver, I don't know if you behind can see, that means you have subtle weakness. And I'm still, even though you don't have that drop arm sign, I'm still going to be concerned that you may have cuff pathology that's present. Now, we know things overlap. So superior labral pathology, if you've seen enough shoulders a few weeks ago, and I like to give examples, and if they work for you, great. If they don't, I'm sorry. But I had a gentleman who, he was focally weak, sent him for an MRI. He had fallen off a bicycle. He had a massive superior labral tear that really masqueraded as a cuff tear, because his abduction strength was markedly limited. But that shows you our exam is good. It's not perfect. And so I'm looking at a series of findings to say, okay, Job's is positive, their pain location. I'm looking at all of these things to then get to a diagnosis, not necessarily that just one is positive, because the way you react to a certain injury is going to be different than the next athlete. Does that make sense? And so now I've assessed the cuff and abduction. Now I'm going to, can you see me okay here? So now I'm going to have you push out to the side. So what they'll do, they'll try to abduct in order to cheat. So they'll try to use other muscles other than the rotator cuff. So I make them keep their elbows in at the side, push out against me here. And if they start to cheat, like if they're abducting, then what I'll do is I'll block their elbow in, now push against me. Good. So he's clearly strong. Push out against me here. Sorry, laterally. Good. Okay. And what you will see is it is important to look, if they give you one of these, then that means if they abduct the elbow, that means they have external rotation weakness that they're trying to compensate for. Okay. Now, probably one of the hardest examinations to learn is the subscapularis. So the rotator cuff in the front, very commonly injured in the young athlete. Now, the most common mechanism is falling down the stairs and catching yourself like on the banister. That's where I see it the most. But this is bear hugger's maneuver. And so you have them bring the elbow up in the frontal plane, have their hand at shoulder height, and I tell them to keep their elbow up, push down against my hand. And so he's doing a really good job of maintaining a neutral structure. What people will do with weakness is they will drop the elbow and they will flex the wrist. So they're trying to pull down. So they're using their latissimus and their wrist and digital flexors in order to create strength where the subscapularis is deficient. Okay. So that examines 85% of the force of the subscapularis comes from the upper part of the subscap. Everybody follow me? So that upper tendinous portion creates most of the force from that tendon. The bear hugger maneuver is evaluating that portion of the tendon. Excuse me, spit on me. Now, when we look at, this is called lift-off maneuver behind the back. So, yep, perfect. Now push your hands away. Very good, and I'll have them push against me. Very good. Another option for this is to pull their hand away and tell them to maintain it there. So go ahead and keep it there. And now if it were to fall back to the back, that's a positive, meaning they are weak in the bottom part of their subscapularis here, and they have a positive liftoff. If they cannot elevate it away or they cannot maintain that position, come back around. That one hurt. I know if I stay here for too long, it hurts me. I don't know about so long story short is if they have a positive bear hugger and a positive liftoff maneuver, that's someone who likely has a very large subscapularis tear. Okay. Last one is called the belly press test. So you put your hands here just below your belly button, and then I have them bring their elbows forward. All right. Same thing. This is kind of more mid subscapularis. He's doing a great job, has neutral position. And then again, I'll show you, but what happens when they're weak, you can relax. They will thrust the shoulder forward, and then they will start to bend. This is called Napoleon sign because he would kind of always stand around like this. But this is Napoleon sign. So when they're weak, they'll thrust the shoulder forward to cheat, and they'll flex the wrist in order to compensate. Okay, so that kind of takes care of most of the rotator cuff. And then lastly, if you want to bring your arm up here to the side, I will have them push against me here. Okay, good. And then I'll bring them here, and I will have you push up against me here. And so again, I'm looking for just any compensations. This is really more pertinent in the elderly population because some will get in, they have what's called a horn blower. So you bring them up here and they can't physically hold the arm in that position because their posterior rotator cuff is completely deficient. Now, where this becomes a little bit more relevant in our population is some athletes with a superior labral tear will develop a large paralabral cyst, which will then push on the suprascapular nerve. And that will occur kind of deep down in here. But what happens is it will negatively affect the neurologic supply to the supraspinatus muscle belly and the infraspinatus, depending on where that impingement occurs. You follow me? So you will be weak in external rotation or abduction external rotation. In the young athlete, you will find that. That's why it's really important to look at the musculature, because in a chronic situation, you're going to see an athlete with supraspinatus and or infraspinatus fossa atrophy. That's going to tell you that they may be weak in some of those maneuvers. So in the absence of a tear, they can be weak because of neurologic dysfunction. Okay. And in that case, that's kind of an emergency because the longer they have neuropathy or an abnormal suprascapular nerve, the longer it takes to recover and the more likely that it will never fully recover. Okay. So I had a woman, she was a little older, she was 40, but this is the one I remember. She had probably, a suprascapular neuropathy for about 5 years. And even though I went in and released the nerve, freed up the nerve and removed the cyst, she really got about 70% improvement because that muscle was already grade 4 in its fatty infiltration. So it had already been replaced with fat, so it's never going to function normally again. So those things are, the earlier you can pick them up, the better. Okay. Now we'll talk a little bit about labrum. So while I have the patient standing, I always look at, along with cuff strength, I'm going to look at O'Brien's active compression maneuver. So bring both hands up. So I have them bring them up in front, and that just puts them in the perfect position of about 15 or 20 degrees of adduction of the arm. Now on the right, I'm going to have you push straight up to the ceiling, and I'm pushing him towards his contralateral pocket. And a positive is going to be pain anteriorly, pain posteriorly, or significant weakness where they, oftentimes you'll see that wincing, and then you'll see the athlete kind of go, I can't really maintain that position, okay? I can, yeah, come over here. So again, backs of hands together. I'm going to have him push up on his right arm, and I'm pushing him towards his left pocket. And that's kind of I think the correct way of doing O'Brien's active compression maneuver. Again, I'm looking for pain both anteriorly and posteriorly, deep-seated within the joint, and for weakness, okay? Now, there's another maneuver for superior labrum we'll do when we do the kind of supine examination. Now what I want to look at is we're going to look at just, so this is Speeds and Jurgensen. So bicep and slat pathology also come hand in hand, okay? So on my Speeds test, I'm going to have you with palm up, push up against me here. And then what I'm looking for is pain kind of here. You can also do it while you're palpating. And if they've got pain here in the bicipital groove, so classically, he's got a big enough deltoid to where I can't feel your bicipital groove. You know what I mean? Or at least not 100%. I've just done it enough where I know where it is, whereas in some of you, I might be able to feel and actually run my finger over the long bicep tendon. That makes it a little easier. And then Jurgensen's is where I have you supinate. So I'm going to try to pronate, and then you're going to supinate as hard as you can. I'm going to twist against you, and then I'm going to palpate here. Pain referred to the bicipital groove would be a positive Jurgensen's maneuver for bicep tenosynovitis. Now, that could be a small subscap tear where your bicep is subluxed and now partially torn, or that could just be chronic inflammation from throwing too much and not doing appropriate arm care. Does that make sense? And then a couple things I left out as far as palpation. Clearly, after I inspect, I'm going to pretty much touch everything. In other words, I'm going to touch the AC joint. If you're a overhead lifter, if you do a lot of bench press, other things, those are going to put you at risk for pain in that joint. I'm going to assess that because I've had really bad AC joint issues for 20 years now. And there's times where I have thought, okay, my neck is really killing me. No, it's my scapula. And then you press on the AC joint, and you're like, whoa, okay, that's really the whole problem. So pain can be referred into various areas. That's why you've got to put your fingers on everything, okay? Now, in my talk, I didn't really get there, but we're talking more and more in throwers about musculocutaneous nerve issues. And so I always palpate the coracoid. One other important thing, so does everybody know, so coracoid process is here in the anterior shoulder, and off the lateral side is the coracoacromial ligament, but on the medial side is the pec minor. So a lot of our athletes, especially ones, now with phones, there's kind of become an epidemic, if you will, of just shoulder protraction. We're all on our phones. We're all, not stretching. The pec minor can actually get really tight, and that can be a source of anterior base shoulder pain in the athlete, where it's just they need to work on posture. They need to kind of make sure they're retracted, not protracted. These are little things that I'm looking at. But as I go from the coracoid more distally, I will start to palpate the conjoint tendon or the coracobrachialis in the short head of the bicep. And about 5 centimeters down is where the musculocutaneous nerve comes in. When repetitive throwers, some of them can get a musculocutaneous nerve palsy. And then those people will actually be weak when you're testing bicep and, that whole musculocutaneous innervation. They'll have some numbness over the lateral forearm in the most extensive cases, and then their bicep will be weak. Okay. Now, does everybody know why, if you tear your proximal bicep, why the elbow is not weak? Anybody know why that's the case? What's that? Yep, and? Yep, good. 5 minutes? Is that, okay. Yeah, exactly. So Coracobrachialis and short head are still intact, and the brachialis is the main flexor of the elbow. So that's why we can treat so many of our more elderly athletes. If they have a proximal bicep rupture, we just treat them conservatively, unless it's somebody who's thinner and they go, I don't like the deformity, it's cramping, then we go repair it. But that is a lesion. I know John Elway, maybe a couple other athletes who have been pretty good have played with that injury and done quite well. Okay, now come over here because I know we're a little short on time. So supine exam is really important for me and my throwers. So this is where, what this does for me is it stabilizes the scapula. So I don't have to be holding their scapula, watching their movements, okay? And so what I'm gonna do with the thrower and in the instability athlete, so this is called the position of apprehension. So if somebody says, oh, I have pain, or oh, doc, I think my shoulder is going to slip out of socket, then I've got to take that seriously. I don't want to dislocate someone in the clinic. But in the thrower, I'm going to say, okay, do they get to 90? So again, this is 0. This is 90. Make sure that you guys aren't getting confused. In the thrower, I will push them further back and say, okay, well, is that, he's getting to at least 93 to 95 degrees. Some throwers may get to 110, 115, 120. Then I'm going to keep his shoulder blade from moving, and I'm going to go into internal rotation. So he's getting to about 45, 50 degrees. I could probably go even further. And then watch this. Once you see the shoulder start to elevate, then they're done. So I'm going to hold it. But if the shoulder starts to come up, then that's basically the end of their range of motion. And in many throwers, you'll see 15 more here, as I said before, and then they'll be stuck here. I mean, you literally cannot push them. And so that's a 30-degree arc of loss of motion, whereas on this side, if you compared the two, I mean, look at that. So he has a little more, even you, were you a thrower? Yep, so he was a thrower. So even years later, you still throwing? Nope, neither. And so years later, he's still, got some internal rotation deficit. So those things are what we commonly see. Now, if I bring them into abduct and they say, oh, that feels unstable, that's painful, then I'm going to do a relocation maneuver where I push back on the shoulder. They should report that my pain is improved. In other words, I have less discomfort. That's a positive relocation maneuver, which is indicative of an anterior labral tear or anterior instability. Okay, come on back up. Sit down at the end for me. Now, one other thing, so when we talk about SLAP, we then go into posterior labrum. So a lot of times I'll do these kind of one after the other. Now, this is called Whipple's maneuver, where we bring them all the way across. I have you then push up against me here. A positive Whipple maneuver for posterior instability is going to be pain kind of in the back of the joint here. And then there's another maneuver where we bring them way up high and then have them push again. Pain and weakness even further back is a positive high Whipple's maneuver, because we know, a lot of athletes have torn posterior inferior labrum. Some the entire thing is off. If the whole thing's off, then all those maneuvers are likely to be positive. And O'Brien's active compression maneuver that we talked about is not just positive for SLAP tearing, it's positive for posterior instability and sometimes even slaps that extend anteriorly. So it's a sensitive maneuver. It's not very specific in what it provides for us. But, can I have you lay back one more time? This is important because these are the two main maneuvers for superior labral pathology. When I have them here, I bring them, can you see me here? So I bring them up, and this is a dynamic maneuver, but I'm basically going to shear them. So I bring them into maximum abduction, external rotation, and I basically shear the rotator cuff over the labrum. And reproduction of pain here, this is O'Driscoll's dynamic shear maneuver. That is another, come on up. That's another maneuver that I will do that is positive for superior labral tears. And so they've got a positive O'Brien's, they've got deep-seated pain, they know maybe mechanical symptoms, and their O'Brien's and their O'Driscoll's is positive. That's somebody that before I get the MRI, I'm going to be concerned they have a slap tear. Okay. Trying to think what else. I mean, obviously we can continue to go on forever. In the female athlete, it is really important. So I get them here. You can imagine if his shirt's up, I'm going to have them relax, maybe put their arm across so they can relax. I'm going to pull down on the humerus and see, do they have a sulcus sign? So does their humerus actually separate out of the socket? And, if you see a mild indention here, that's kind of a grade 1. You see significant indention, that's a grade 2. And if you feel almost like the shoulders coming out of socket, then I would call that kind of a grade 3 sulcus sign. And then one thing you can do in the multidirectionally unstable patient is bring them into external rotation. And when you pull down on them, if that sulcus sign goes away, then that's consistent with someone that might have multidirectional instability. Okay. I think that's probably, we can talk a lot more about other little things, but that's going to cover about 85% of what you're going to see. And then a lot of it just comes with doing it, thousands and thousands of times, and then it just becomes easy, and then you can do it in kind of 5 minutes rather than 15 or 20. Any questions? I'm happy to answer anything.
What was the youngest person that you've seen suffer rotator cuff tear?
Oof, okay. 15 years old after ejection from a motor vehicle at 100 miles an hour. So that was the youngest. The youngest athlete was the 17-year-old. I think it was. I might be missing one, but the guy, he literally had a receiver going across the middle, tackled him, and was like, my arm's dead. You're thinking stinger, whatever. He was not getting better. MRI shows supra and infra pulled all the way off, retracted like 2.5 centimeters. Like that's a wrong impact at the wrong angle, which would be extremely rare because that's really low on my differential in a 17-year-old athlete. Rotator cuff's just not going to be common. Thank you. All right. Thank you. Thank you. Appreciate it. Okay. Well, thank you. 2 more times. Thanks, sir.
Is it good? Ready to turn on? Okay. Hi, guys.
Ready to get started?
All right, howdy. My name is Lauren Ferrante. This is Jackie as well. We're both shock therapists. I'm over at the Bel Air location at Memorial Hermann Rockets Orthopedic Hospital.
I'm at the KDCCC location, so about 15 minutes from here.
So we're going to go through talking about like an exam for the scoliosis. And in addition, after this, we're going to also do some treatments that could be successfully to perform without doing the shot method. So quick overview of scoliosis. We talked about 95% of the time, you're going to have a right side thoracic curve because of the heart. And remember how we talked about like each block is going to be pulling away from the vertical midline, right? And also each block is going to be rotating away from each adjacent segment, okay? So the right side thoracic curve is going to be rotating posteriorly to that right side, meaning that shoulder complex is going to be rotating the opposite direction. So you're going to have that right thoracic rotating out, meaning that right shoulder is going to be rotating forward a little bit. Because of the right thoracic curve, if it's higher up, your body's not going to let you walk around like this. So you're going to have a compensatory curve. That's why you have that double curve sometimes. So typically it'll be that left lumbar to help compensate for the body to get more into upright position. So since you have this right rotation here, the left spine is going to rotate out this direction. Depending on the magnitude and the location of that curvature is going to help you to break down if you're going to have another block in the pelvis or if it's just one block. Some things that we're going to look at, remember how we talked about there is going to be increased risk of having a hip prominence and a weight shift. So you can see on her, she actually has an actual right hip prominence, so indicating that she has that left weight shift. That's just some things to kind of be mindful of. So especially some athletes, you notice if they're trying to do some single leg activities, they're collapsing more onto that side. Be mindful, like, okay, is this because of the curve or is this because of true weakness? You just want to be mindful of it. So we're going to show like how to do the Adam Ford bend test. So you're going to have them bend down at the waist, and it's going to be for the typical athlete screenings. If they have a rib prominence, you're going to see it typically on that right side. Few percentage, small percentage maybe on the left, but typically it'll be on that right side. And she actually has a small lumbar prominence, so that's indicative that she may have some scoliosis. Come on up. So if you're concerned that your patient or athlete has scoliosis, we recommend being referred to the pediatrician or to orthopedics, pediatric orthopedics to kind of be screened out. Any questions about any of this so far?
If they have a pediatrician, or they should already be being screened for this as they go through puberty?
Good question. Yes, they should be screening for this. Typically at the annual checkups, they'll do this. However, we also know that a lot of times the curve progression is going to happen during times of peak growth. So if they had that checkup and then all of a sudden they grew a lot in that 6 months, you have that possibility that they had this great curve progression. So having somebody else around them to be able to screen this throughout the year would be really beneficial. So this is where awesome ATs come in. If y'all seeing these patients more consistently, you might be able to visualize these changes pretty quickly and get them into the pediatrician quicker. It's a good question.
I was going to ask around what age does that curve progression stop? Does it end with like the typical people are stop growing at like 15 or 14, or does it go past that?
Typically, once they hit skeletal maturity, they're going to have that, hopefully the end of that progression of the curvature. So typically for females, it's going to be about 2 years after post-menarche. And then for guys, it's going to be about 2 years after divorce changes. If they're really concerned about it, when they do those PA views, you're going to see the iliac crest, and they're going to help determine what their skeletal maturity is. And that kind of helps drive to see like how much possibility they have for that curve progression. There is still a small risk of that curve progression into adulthood, but that's going to be typically for those curves are greater than 30 to 40 degrees. So they'll probably still be monitoring it every like 5-10 years at that point.
And if you do start seeing like the curvature when they're younger, is it recommended to, if they're athletes already and they don't have any pain, is it recommended to continue to be in sports so it can help like not, I guess, accelerate it or like grow?
I think it's still a really great idea for them still being athletes. That's one of the key information I always educate the patients and their family is that if you're active, stay active. The more active and stronger your body is, the more resilient your spine is going to be. So it's more challenging for those patients who are more gamers and not very active, trying to get ways to get them to be more active to help their back get a little bit stronger. Good questions.
I'm gonna add on that one. So according to the research, there is like, if you look at like scoliosis, this is how I describe it at the initial evaluation. Here, scoliosis is the term. And then there's a couple pillars we're gonna look at just to make sure we're hitting all those. And if we hit all these, then we have the best success in reducing your curve if possible, okay? So one of the things is gonna be like scoliosis-specific exercises, which is Schroth, which is what we're both trained to do. The other one's gonna be like core stabilization, so that's peer number 2. The other one's gonna be flexibility. A lot of your Schroth kiddos or your Scoli kiddos in general, they're growing a lot. They're very inflexible. So make sure you have good flexibility within the pelvis and then the spine. The other one I look for, depending on where their curve is brace wear. Are they wearing the brace or not? If they're supposed to, it's important that they wear what they were recommended to wear it for, whether it's just night brace or during the day. And the last one is just be active, sports specific. Just keep them going because they're going to use a lot more of their muscles and variety of different muscles in their sports versus like what we are doing in rehab. So we can't capture all that within an hour. They'll be able to, maintain a program by being active.
And with that too, so like if they're participating in sports, I still recommend like, hey, just do like these specific exercises, like 10 minutes, like 5 days a week to working on the mobility and just specific core strengthening to help elongate that spine a little bit more too. Good questions, y'all.
Yeah, a couple from Zoom from earlier.
Perfect.
So one is this person has a
9-year-old with pectus excavatum and hypermobility issues and is now developing mild scoliosis. Would you indicate the Schroth method for them to get started with?
Yeah, I think it's a great idea.
Repeat the question. They can't.
Oh, sorry. So they're saying that there was a 9-year-old with hypermobility in a pes excavatum, and wondering if they should start Schroth therapy. I think it's a great way to start doing some, at least some physical therapy and strengthening. The only challenge being in 9 is that doing actual specific Schroth may be challenging to get into those positions, but just do more general strengthening is great. You also want to be mindful of like a burnout. So maybe get them going for like 6 weeks and then do like a tune-ups as needed. But you just want to be cautious that you're not getting these kids too tired before they go through these major growth spurts.
Is there any benefit to the EOS X-ray besides the lower radiation as opposed to regular X-ray?
Great question. So they're asking about the EOS machine, if it's anything else more beneficial about having the low radiation compared to other X-rays. Yes, just having that low dose radiation, because typically these patients going to be X-rayed about every 3 to 6 months, depending on where their skeletal maturity is. So you can imagine how many X-rays they're having to take if they're not in the EOS. So it was with the EOS, you're going to be able to do multiple planes all at once with the lower radiation. Versus if you go to another imaging place, they're going to have to do multiple X-rays to getting that PA spine and that lateral spine. So if you do have access to the EOS machine, I would highly recommend it. All right, any other questions before we kind of jump into some more exercises? All right. All right, so some of the basic exercises we want to work on. Some of the very first few we always give is called the cat camel. So I'm sure everybody knows this one pretty well. So the idea is that you try to just mobilize that spine as much as possible. We know that in research that if the more flexible you have that spine, the more improved that brace is going to work. And if they're heading for surgery, the more flexible that spine is, the more optimal that surgery's outcome measures are. In addition, if you're not heading that way, just working on more of that flexibility is going to help you get into better alignment. So for the cat-cow, we're going to start with the head down, and she's going to pull up as much as possible. Typically, if you have that right side thoracic curve, you're going to be collapsing onto the left thoracic side. So giving them cues to pull that right side down, to pinch that right shoulder blade down, is going to help them promote that left side thoracic concavity. And then in addition, if they have that left lumbar prominence, they may have a concavity on this side. So giving them gentle cues just to open that up a little bit more helps to promote a little bit more that elongation. So they can hold this position for like 5 seconds, and then we're gonna have you go the opposite direction. A lot of times you're gonna be a little bit more stiff again, even in that lumbar spine. So giving them cues to really push that lumbar spine down towards the mat to really help a little bit more of that lordosis, especially in that lumbar prominence. So again, holding this for like 5-second holds, and then come back the opposite direction again. So you could do this one like 10 times each. I've even had some patients come here and I'd take them, have them like wag the tail. So basically moving that pelvis back and forth, trying to get a little bit more mobility in that hip. And you can also do it in the opposite direction. So you're gonna go down to the cow position, I guess, push this down. And now you could kind of move that tail, shaking that pelvis a little bit more too. Good. So that's one of the really good mobility exercises that's really simple to perform. Another exercise to perform is the thoracic rotation. You could do this in different directions or different ways. So one of the ways you could do it is in a quadruped position, or even child pose, and you go down, rocking it down, and then come on back up. So I know a lot of on the internet says don't do thoracic rotation. I think it's still a good idea to work on thoracic mobility because you're going to be stiff at the thoracic spine. In order to get optimal results with the brace, you want more mobility in that ready stiff region. Okay, and then you can do both directions. And then again, like if you're collapsing into that left side, you could give them cues to open up that left side. So she's coming down, and as she comes up, I could give her cues to kind of pull up right here. Good, beautiful. So those are a couple of simple mobility exercises. To start working on core strengthening in a neutral spine, one of my favorite ones is to start off on the supine position onto a mat. The benefits of this is having the tactile cues of the spine contact to the mat, so that way you can hopefully promote more spinal symmetry. So in this position, I could tell her to shimmy her hips down. That's gonna help elongate that spine that we're looking for. Next thing we're gonna try to do is gonna pull those ribs in. Beautiful. So she's gonna feel that working across those abs, and then ideally, hopefully below that belly button. If we're really trying to promote a little bit more of that symmetric, we can move like her arms around to help her open up a little bit more. So you could play around with it, but even just being in this position is really beneficial. From here, we could progress to doing marches. So she'll lift that knee up and then slowly come back down and lift the other knee up. Ideally, we're looking to not salsa dance into those hips. Good. If we want to challenge this a little bit more, or if they're having a hard time finding that core, you could add a little bit more external support. So you have like a band at the backside, and they're going to pull down. That's going to help them engage those abs a little bit more. So still giving them cues to pull those ribs down. Don't lift that back off the table. So that's going to be a little bit way different ways to engage that core. You can also use a weight overhead. From the progression of this, you could do dead bug isometrics. You could do various positions. You could get creative with this, okay? Another thing you could work on is a little bit more hip strengthening. So you could pull that core in and you do some bridges. You want to be mindful with some of these patients that they're going to be dropping that hip. So give them cues to keep that hips even will be beneficial. So they could kind of watch that as they come up and down. And you slowly go back down, making sure the hip is not the first one to come down. Good. So beautiful motor control and core and hip strengthening. Another good one to do is quadruped positions. So again, giving them cues for elongation of the spine. So making sure that knee is directly underneath those hips and the shoulders are directly, the hands are directly underneath shoulders. I'm going to probably tell you bring it up a little bit more too. So that's going to help them elongate the spine. So going to have them bring it down a little bit and give them cues. Okay, I'm going to have you pull tall, elongate that spine. Now pull those ribs in, making sure that they're going to have like a little bit of an arch in that back, right? So from here, if they have that right side thoracic curve, you give them cues to pinch that right side down. Now they should feel that across the abs. So pull that belly button in, pull the ribs in. You should feel that abs working across. It's going to be great to work a little bit more of that posterior side of the trunk muscles as well. If they're able to accomplish this position, then you can make it more challenging and have them do a primal push where they're pushing up by an inch. So then further engage those trunk muscles. Beautiful. If this is easier, you could progress to different ways. So you could do like quadruped rows by pulling it down. You could even do pushing up from there, putting the resistance from the leg. You could do fire hydrants to work a little bit more hip strengthening. Beautiful, beautiful. So you could get creative on what you're working for and challenging the patient. Another one you could work on is more of side planks. So working more on that sagittal control. Typically, we do planks and modified side plank, like in positions in modified position, because it's really challenging for these patients to maintain that sagittal control. So starting off more modified positions, it makes it a little bit easier for them to be successful. So we're going to have her place her hand onto her shoulder. That's going to help her open up that thoracic spine and pull those ribs in. And we're going to have her lift on up. Remember how we talked about that each segment is going to be rotating away from each other. So we're going to give her the cues from this pelvis and from this ribs to pull in together. So it's kind of like wringing out the towel. Now she's going to be able to hold that beautifully. Great job. As this gets easier, you can make this more challenging by like doing clams. Beautiful. You could do a hip abduction. You could do shoulder abduction. Get creative on how you're doing this. If this still gets easier, you can make it more dynamic, add in like rotations into it. You could do off the Bosu. Have fun, y'all. Yeah, beautiful. As we develop more of the strength, we get more functional. We will progress into more like standing exercises. So PVC pipes is a great way to help these patients work on elongation and core activation and standing. So in this position, we're gonna have our elbows up to help elongate the spine a little bit more. We're not going to worry as much about all the Schroth techniques that we use. We're going to focus more on elongation and core activation. So in this position, we're going to tell her to pull those ribs in. See how when she does that, her core is activation, and that's going to help promote a little bit more of that natural thoracic kyphosis that they usually lack. From this position, we can also get creative. So we'll focus just being in this position and breathing into her rib expansion, getting used to this. Or we can also make it more dynamic. So say for those patients that we have who are ballet dancers or soccer players, we can work on core and hip strengthening, right? So while she's maintaining that elongated position, working on the hip stability. As this gets easier, we could take away the external support and have her practice without the cues. Or what she just did too. She goes up on her toes and practices kicks. You could get very creative how you want to approach these. Know what your athlete is working for. Dangle that carrot in front of them and help them kind of achieve the goals and get them excited to be at therapy. I had a patient I had a volleyball player like a month ago who was not interested in doing shot therapy or scoliosis exercises. I told her, I was like, hey, give me a couple weeks to work on your hitting. So we worked on a little bit more core stability, incorporated a little bit more of power movement of the hitting the ball and things like that. She came back a couple weeks later and she's like, okay, I got the buy-in. I'm a little bit stronger. I'm doing better. So figuring out what their motivation is going to help you a lot.
And you don't really have to get too complicated with the exercises. Sometimes just as simple as like maybe if they're a volleyball player, like that's one of my players that I had, or patients, just focusing on like, what does her hitting look like? And then just making it like a single leg stance. And could she keep her blocks just standing on one leg, keep her block straight, and then just standing here with no equipment? Could she do this? And then we made it more fun and interactive, giving her a band, standing on like an Eric, standing on a Bosu, and then me tossing a ball to her. So it doesn't really take a lot of equipment. It's just the goals my kids always know is, can you stack your blocks? So getting the blocks straight and just giving them a mirror is like my best friend. I have a moving mirror. So if you have one in the gym or the clinic, move it with you and they will be able to quickly understand where they need to be. And then that obviously makes their progress a lot more quicker. They can get back to where they want to be.
So having that foundational of where you're teaching them how to engage that core initially is making it more successful for them to be engage that as they get more dynamic as well. Questions?
For like athletes who are more progressive, okay, that have more strength, would you recommend doing dead hangs?
Yes, I've done some of that.
Repeat the question.
She was asking for those athletes who are a little bit more powerful, can they still do dead hangs?
I've done it with some of mine. I've had two athletes, like, they've played multiple sports, school, and then also select. So there's 12 plus positions with Schroth. I kind of maxed out with her. So I was like, well, let's get creative. So we did some hangs, did some deep breathing. It's a little bit harder. I even do like HIIT workouts with them, because when you start doing like kettlebell swings and things like that, once they get to the top, you'll find that a lot of times they want to do this. So can you just stack your block at the top with just doing kettlebell swings, mountain climbers? So then they feel like they're actually working out. And the whole time there's a mirror there and I'm just like, let's correct. And then they try to get their block straight. So you could typically do a normal workout. And then you're just giving them more cues on their blocks. But again, once they have foundations.
Good question.
Just going here.
That you start seeing like progress for those that just like specifically in the
I think specifically in what? So she was asking what's the typical time frame of when you start seeing the progress in these patients. Sometimes it really depends on the patient and the motivation. So some of those who may not be as active, it may be challenging trying to get them to participate or finding activities that they want to perform, versus like those dancers who have great motor control, and you give them that feedback, like that visual feedback, like, hey, look how much better your posture is and how much more successful you are to be able to kick that leg up. They're gonna be a little bit more motivated to participate. So it just kind of depends on that aspect of things as well. So again, finding what the motivation is going to be helpful. So typically about 4 to 6 weeks is what we kind of think about strengthening. But you want to focus more on posture awareness with that strengthening too. And also a lot of these patients don't have discomfort. So they're coming into like, why am I here in therapy if I'm not hurting? I am playing everything okay. So again, giving that education and motivation why they're in therapy helps.
And one thing I like to add, for visual people, right? A lot of people like to see progress, like see more muscle gain. They want to say I fit better in my clothes. So with Scoli kiddos, I have a actual like diagram on the wall. And so I don't take the photos. The parents will take the photos at the initial evaluation. And I just do a 360 photo. So the kids there, the girls are in sports bra, boys shirts off, and they're standing there in their shorts. And we take a photo from the front, from the side, from the back, from the side. And then I also take a photo of them doing a forward bending test. And then every 6 to 12 weeks, we redo those photos again. And then the buy-in's there, because then they're like, wow, like I didn't realize like I was here. And then they see themselves, oh, my head was shifted to the left half an inch. Now I'm centered. I can see it on the grid. So even if you just did that in the gym, like if you're having difficulty with the buy-in, just give them that visual cue and they can have it on their phone. Hey, it's been a few weeks. Let's just do these photos again. Could you stand up straight and let's see what it looks like? And then they buy into what you're giving them.
Question.
tips for the students that are in class for so long and sitting and have back issues?
Great questions. So her question from Zoom is any tips on for these students who are sitting for a long time and having back pain? I think it also depends on what's causing that discomfort, right? So when you find out what's that examination of if they're having pain, so if it's more of like lack of mobility, okay, maybe you could sit down and you could do like some thoracic rotations. You bring the elbow up a little bit more to help expand that little bit more area as well. If it is more because of core activation strengthening, maybe having them put their hands onto the desk and they're going to gently push down as they pull the ribs in. So it's going to be like more of an isometric hold of the core activation, kind of helps as well.
I like to just do pelvic rocks. You can do this too. Like if you're traveling in the car for a while, back gets stiff, just kind of doing the pelvic rocks, kind of shifting side to side. And then exactly what Lauren said.
So good.
Do you guys recommend a certification for Stroth? Is that something that we can get as athletic trainers?
So Stroth training is pretty intense. It's like 5-6 days of training and it's pretty expensive. So I think that just understanding more of the scoliosis. I mean, yes, I think you could probably do a Stroth training, but it's pretty intensive solution. I don't know how often you'll be seeing scoliosis as well. But I think just reading up a little bit more about it and understanding the mechanics of it and how you still be successful to treat these will be beneficial. So think about more mobility, more core strengthening, hip strengthening, shoulder strengthening, anything that you could incorporate to make them stronger overall is going to be beneficial.
And Stroth isn't like the end all be all that solves scoliosis. It's just a tool to have.
Yeah.
Right. And then when we look at like what is successful treatment with physical therapy when we're doing this, if we can get their curve to reduce by at least 5 degrees, then that's winning. And it just depends on the buy-in with a kid. And then how are you getting them to do there? So it's just a tool. Yeah.
I guess it's like mine's a two-part, I think maybe. So say for the older population, if like they're a little bit over 50 or about closer, 50, and they have scoliosis and they're like known for getting back spasms a lot, and like they say they try to do those exercises and everything, and then it like flares up, and so they just feel like they're back at square one because they're hypertensive about getting a back spasm while doing those exercises. So how would you, I guess, modify or go about like that type of situation?
You said that for like a curve, like when they were 50 years old or?
Yeah.
Okay. So 50-year-old scoliosis is going to be a little bit more challenging or different from what we think of adolescent or younger adult, just because depending on what their curve is from, is it more because of degenerative scoliosis? Is it more because of the true idiopathic scoliosis that has been progressing? Because if they're over 40 degrees once they're scoliotically mature, they may have increased likelihood of that curve progressing more into adulthood. So it kind of depends on what that scoliosis, the reason for it, the underlying cause of it. And then also, we don't really work on Stroth in that specific way that we do from geriatrics compared to like adolescent, because the reduced mobility you have in the spine naturally. So our other focus is still going to be working on more like gentle mobility of the spine, working on what motion we can achieve, and it's still working on core strengthening, but we may not be elongating as much. We may not be focusing as much on the concavities because you have that increased risk that you may hurt them more. So just, again, still working on that general strengthening is going to be beneficial for them to build up more that resilient spine. So again, it goes back to doing that thorough back exam, trying to figure out what's their underlying cause. Good question. Yes.
They're also like in the weight room. How like contributing is like the weight they're lifting to what y'all are doing physical therapy? As a body trainer, should we be advising patients to like lighten the load, or what should we do?
Good question.
That's a really good question. Yeah. So she was asking about these kids in the weight room with scoliosis, and should we be modifying the workout or reducing the load for them or giving advice to the coaches? Honestly, if I'm the type that like, if they're able to do it correctly and safely, just like any other general population with scoliosis, non-scoliosis, I think they're fine to do it. Now, if they're doing it and they're collapsing so much and they're having a hard time, and you see them like trying to do like a bench press and they're like one side is shifting a lot, then maybe, yeah, I would definitely reduce the load. But that's probably the same concept that you give to any other kid who are having challenges where they can't do it symmetrically, right? So I think it just kind of goes back to the same application of like what your typical athlete will be. I don't like to cut back things on them. I like them just, if they seem motivated to go do something, please go have fun, go do it within safe reasons.
Thank you.
Thanks. Thank y'all. Thank y'all. Yes.
Thank you.
Good to go? All right. So the way that I want to kind of structure this breakout session is to be a little bit more interactive. I don't necessarily want it to be just me talk at all of you and tell you how to do a soccer specific return to play. I want it to be a little bit more dynamic, interactive, to make it specific to each of your individual settings. So the first thing that I do in any return to play is to start a brainstorm and create that needs assessment that I referred to in the presentation. And so just to give an example of how it's different from sport to sport, does anybody have a suggestion for a sport assignment that they want to talk through a grade 2 hamstring return to play? Track, we did track on the last one. Everybody wants to do track. Wrestling would be actually a really fun one, but I don't feel like wrestling is just such a unique beast. Let's do track, but the caveat is that you can't do short hurdles. So let's do track athlete. What event are we doing specifically within track? Long jump? Okay, that's a good one. Okay. So the first thing that I do within the sport assignment is consider the demands of the sport. So obviously there's going to be some sports where you have American football, for example, you have athletes that are doing very different actions. So you have a quarterback who's using a lot of shoulder when they're throwing the ball. You have a lineman who's pretty much stationary and they're just doing a lot of that pressing action. And then you've got your more dynamic players, your wide receivers, who are running 40 yards downfield trying to catch a ball. So the demands of the position are very different. Similarly, track and field, the demands of the event are very different. So you can have somebody like a long jump that's doing, what's the run up? I didn't run track and I didn't do long jump. What's the run up leading into a long jump? 20 meters, 30 meters? How far do they run before they jump? Yards? Okay, so yeah, roughly 30 meters. So a relatively short run up leading into a massive explosive action jumping into that sand pit. So when we think about the demands, what actions do they have to do to return to their sport? We know that they have to sprint and we know that they have to jump. What else? Okay, so landing mechanics could for sure influence something. So let's say sprint, jump, and land. Anything else that they need to do? What kind of a sprint is it? Is it running straight line? Are they running around the curve? Okay, so in a high jump, there you can start to tease out some of your differences. In a high jumper, I'm definitely going to clear curvilinear running, whereas in a long jumper, you probably get away with just doing linear sprinting. So let's say we want to clear off linear sprinting at some point. Jumping, is it off of 2 legs, off of 1 leg? Okay, so off of 1 leg, single leg jumping specifically is going to be a lot different demand on the body than a double leg jump like in a basketball game where they're jumping up to get a rebound. The other thing to consider is, are they doing a vertical jump up in the air, or are they doing a horizontal jump out into the pit? Okay, so we can start to get even more specific. So this is a horizontal force, if I can spell. And then the landing. How do you land in this is where I start to lose some of my expertise. I can't really contribute. Okay, so you get that max hip flexion moment, and so that would be a stretch for the hamstring. So that's a consideration for this rehab. So let's say hip flex. Okay, so then I start to work in, so these are the demands I know I have to get back to. Let's start to work into a timeline. When do we think that after a grade 2 hamstring strain, it's appropriate to return them back into their sport? What's a rough timeline? Again, it doesn't have to be perfect, but if you're in your setting, you should be able to apply this logic. And you should say, if I think it's a week, if I think it's 2 weeks, whatever you think it is, you have to work your calendar out based on that. And your progressions are all going to be based on that estimate of a timeline. So what do we think for a grade 2 hamstring of a long jumper? 6 to 8 weeks. Okay. Anybody think more? Anybody think less? 6 to 8? 4 to 6? Okay. So we could probably, just for the sake of demonstration, I'm going to call it 4 because I only mapped out 4 weeks on the calendar, but you could do 6. I just did it in the last one and it was really ugly and my handwriting is already bad enough. So we'll call it 4 just for the sake of demonstration. So 4 week. Thank you, whoever made that suggestion. You made my life easier. 4 week return to play. Of this 4 weeks, how long do we think after this grade 2 hamstring strain they need downtime where they're doing either table-based rehab or treatment only? How long do we think we need? 3 days? Okay. Anybody think more? Anybody think less? Okay. So 3 days down. And now you can start to think about your progression. So within that 3 days and 4 weeks, we need to have a linear progression of activity. Which of these 3 actions is going to be the harshest on the hamstring? The jump, okay? So that really explosive movement. So I would say let's rank this 3. What about between sprinting and landing? Sprinting is 2, and then landing is 1. So you take this information, you know, within 3 days and 4 weeks, I need to check off these 3 exercises in a return to play progression. So if I come over here to the backside, oh, we could do a 6 week. Somebody was nice enough to add another few weeks. Interesting because the date of the month is the 36th and the 43rd, but we'll make it work. So if this is our date of injury, and we said this is 3 days is down. So maybe you're doing treatment only, maybe it's active rest and you're just doing like an upper body lift, but you're letting your legs calm down. Whatever you decide is appropriate for these 3 down days. So if these are all just like treatment or table-based rehab where you're just really starting to do some gentle movement, but you're not actually going through loading of the hamstring. So this eliminates this time period from the rest of your return to play. So we said 6 weeks after my lying for 4 weeks. So from the date of injury, 1, 2, 3, 4, 5, 6. So this is our target return to play. From there, how long do we want to see them in a full practice setting before we feel comfortable putting them into a track meet? A week? Okay, so 1 full week. So then this needs to be full practice. Okay, so this whole week is going to be full practice. This would ideally be, depending on when your calendar matches up, this would be the first track meet that we're putting them in. And I would say probably for a long jumper, you're only putting them in for 1 event. But if you have like a short sprinter to consider, okay, are they doing the 1 and the 2? Because then you have to decide, is the volume of the sprinting in the 100 and the 200 too much for them at this first track meet? But for a long jumper, you probably don't have to worry about that. Maybe they're in the high jump. I don't know. What's common with long jumpers? Is it triple jump as well, right? Right. So you have to consider, are you going to put them in the 100 and the long jump, or maybe it's just one or the other? Maybe if we're deciding that the jump is the harshest movement, maybe we want to put them into the 100, but not into the long jump. So that'd be considerations to take on the back end of your track meet. from here, so we know that this is going to be the full week of practice. How many days do we need to clear, which our max is, what did we say? Jumping. So when do we want to have jump where we have like completed it in a rehab context and we said, yeah, they did great with jumping. They're ready to go back into full practice. At minimum, if this is a full practice day, it should be done here at the very latest. Because if you clear it here and there are no problems whatsoever, we feel confident putting them into practice this day. So this is long jump clearance. From there, how long do we think we need to practice the sprint technique before we can build into the long jump clearance? 2 weeks, okay. So we're working backwards from this clearance, 1, 2. So this would be our sprint clearance.
That we're doing jog, sprint, jog, or we're doing full sprint or workout at that one?
I would say typically when I'm looking to clear something, it should be the harshest demand that you need to put them into the next exercise. So for example, we know they have to sprint in a long jump. So I wouldn't want to have them do a sprint at, what'd you say it was, like a walk, jog, sprint? I wouldn't want them doing that this day and then tell them they're good to go into the full-blown long jump the next day. So if I want to see them sprint clearance here, that means they're doing sprint practice like individually all this week, and then they're starting to do the long jump. Maybe they do a modified version of it here, and then the full-blown long jump is here. That makes sense? Yeah. Yeah. Yeah, and so that's exactly what we'll get into. So again, this is not necessarily like a perfect calendar, but you can start to fill it in. So if this is our sprint clearance date, how long do we think that it's going to take somebody before we introduce them to sprinting where they're doing minimal? It's like a jog for most of it and then a tiny bit of a sprint. How long do we think that it's going to take to build into a sprint clearance? Okay, so 1 week would be here, and then 10 days would put us here. So we're already pushing, getting close if we're thinking sprint clearance here. So let's call it 7 days for ease of argument here. And so let's say sprint intro. So if they're getting their sprint introduction here, you're building up the volume to get into a full clearance where we feel 100% confident they are able to sprint at this date. From there, once we know they can sprint, they're getting a week's worth of sprint like practice individually still, you're not with the team, but then you're building into this long jump clearance. So maybe if you're doing a week's worth of sprint intro, maybe you do your jump intro on this one. So you do small variations of long jump. Oh, I can't. Yeah, jumps are fun. So you get your long jump intro there, and maybe you're just doing a stationary takeoff. I don't know track well enough to be able to progress these exercises. This is where I would rely on all of you. But if you're starting here, single leg, and you're just jumping into the pit, certainly that is submaximal. That is not the same as sprinting down a track and then jumping into the pit. So maybe you start there. Maybe you even start with 2 legs and then you progress to a single leg. Whatever that progression is that makes sense, you're doing it over the course of this week to lead up to hopefully a successful clearance on this day. Any questions so far? So what we would start to see is we can start to fill this in. Obviously, we have our clearances, our goals of when these need to be checked off. The last one that we had on our checklist was the landing mechanics. When is it safe to start landing mechanics for a track athlete after a hamstring strain?
It happens at the same time as doing their jump.
Okay, so obviously they're going to be doing it in the jump, but what about can you check that box sooner than sprinting?
Yeah.
Okay, so how are we going to do it safely? You start to think about some of these details. Maybe you're having them just falling. Maybe you're falling into like a backwards fall into the pit and they're getting up into that hip flexion moment that you would have as they're landing in the pit the other direction. Again, I don't know track and field well enough to be able to progress some of these things, but it should be enough of a kind of a conceptualization that you can start to apply them in the sporting setting that makes sense for you. Yeah.
Isn't it meeting like the current state?
It depends on where it happens. If, for example, they aren't ready to start until this day, and so we have an extra down day until the 5th instead of the 4th, this probably doesn't change this because we can still start the sprint intro one day later as opposed to sooner. That makes sense? If, for example, they can't sprint here and they don't even start the sprint clearance until maybe it's here, then you have to start to have the argument, if they clear sprint here, is it safe for them to progress into the long jump clearance or the long jump intro here? Or did you want to have that full week of sprinting before you start to introduce jumping? I can't answer that question for you. You have to think about that for yourself. But if you decide, okay, well, we only have 3 days until our original intro, maybe I'm okay with 3 days of sprint practice. And then as long as they do okay with that, we can still start our jump intro here. Or maybe you're not okay with it. Maybe you are like, I need to see a full week's worth of sprint practice before I'm putting them in the pit. And if that's the case, then your long jump intro can't start to here. And then you have to have the same exact conversation for the long jump clearance. Is 3 days enough to clear the long jump? I would say probably not. So if you're pushing your long jump intro to here, your long jump clearance has to come down here. Now, if you get your long jump clearance to here, you're still good to go. You've got 4 more days until your full practice week, right? So sometimes it derails your whole plan and everything gets shifted, in which case you have to start to talk to the coaches and say, look, we initially thought it was going to be 6 weeks. We thought maybe we could get them back sooner, but if this was our target track meet and they're a week behind, they won't make it until this next track meet the following week. So you start to have some of those conversations as it unfolds. But again, like it's just the logic of how much loading do you need to achieve the successful rehab and restoration of the hamstring. If it's a case of short fascicles, and again, it's going to take a minimum of 2 weeks, yeah, you probably you're probably not going to get there until you start your long jump intro. So maybe you start to take into consideration some of those adaptations as opposed to just the rehab progressions. That makes sense? Cool. So then the last piece that I would take into consideration is central nervous system training. And so if they're, let's say, sprint intro is this day, we probably want to give them this day off so that they can recover. And that's as important for the central nervous system as it is for the muscle. So if you put them into their first sprint workout, they're going to be sore, they're going to be tired, they need to recover. So if you give them a high day, you need to follow it up with a low day so they can recover. Then that allows us to come back in and rework some of this. Okay, so if we need a clear sprint, maybe this sprint intro was, let's say, 50%. They can then re-intro, so let's say a sprint progression. And what do we want to say, 75? As a progression, if we're trying to get to 100 here. So 75% here. Guess what? If you introduce a 75% sprint, probably need to follow up with a low day. That could be a core day, that could be a rehab day, but you're not going to have them sprint on back-to-back days. So that would be low day. If this is a sprint clearance, I want to have them have a work into it. I don't just want to have them come out cold after an off day and get into a max effort sprint. This probably needs to be a moderate day to then be allowed to progress from nothing, something, maximal. Does that make sense? So considering the CNS, we can really start to detail out some of this calendar. So if this is a sprint day and a low day, and this is a moderate day, maybe this is our off day, which gives us this day we can do a little bit more. If this is a low day, maybe we do a moderate day here. And you can start to work in some of those other variables like a high speed run. Maybe it's a heavy gym day where you're starting to push them in the gym, but you're not necessarily doing the same sprint motion because you've already got one exposure and a second exposure that week. Does that make sense? Yeah.
So instead of like having an off day, could you do like a low impact day instead? Like when they're doing hydro works and they're not putting as much load on their muscles, or like in the non-gravity track.
Yep. Yeah, so the question was, can you have, instead of having a true off day, can you have them do some kind of a low impact day where you're doing like an Alter G, or you're doing like a underwater treadmill, something along those lines? The answer to that is it depends. And especially if you're considering the central nervous system, if you add something, doesn't matter how low intensity it is, if you add something, their central nervous system is being fatigued. So if you want them to have a moderate day here, you could probably get away with doing some kind of a low impact day here, because you're going to be taxed here, you're going to be recovered here, and then you'll be okay for this moderate. If I had a sprint day here, then I would say, okay, well, we have a sprint day here. and a sprint day here, this day needs to be really low to allow them to be able to recharge their battery to get back into this sprint day here. Does that make sense? So the consideration for that, it's not that there's a hard rule where you have to have a true off day. It depends on what else is surrounding it. And that's the whole point of like the rehab calendars. You can see the context. You can rework some of these variables. Maybe you decide, okay, actually, I don't really like the off day here. I want them to do a little bit of a low day here, which then, okay, now we've got a sprint day, a low day, a low day, moderate, and a sprint day. That's a lot of back-to-back days. Where can I insert an off day to get away with it? Okay, probably it's this one here. So now I break that up a little bit. And this is the beauty of the calendars. You can rework this to make it make sense for all of the different variables of your sport. We were talking in the other group about high school. They aren't allowed to be in on Sundays. And so if you can't do a sprint clearance here, guess what? You have to do it here. So if this is a no-go, your sprint clearance moves here. And you have to rework the rest of your calendar to make sense. Again, does 5-day build into the long jump intro make sense? Maybe. What do you think? 5 days of doing the sprint work into the long jump make sense? Okay, so then for the demands of track and field long jump, that might make sense. But for the demands of an American football player, maybe it doesn't. So you have to consider what the demands of your sport, the position, and all the adaptations that you're trying to drive before you're mapping these kind of things out. Any other questions? Yeah. Either way.
Athletes who are guarding or like trying to be, or that are hesitant, how do you go about trying to progress them?
I think it depends on why they're guarding. Is it a fear and an apprehension, or is it? But is the fear just of opening up to the cause of the injury, the mechanism of injury? Because a lot of that can be teased out, I think, by progressing things along the way. If you introduce somebody to jogging and they do it successfully, you can probably progress them into moderate running. So you go from 50% to 60%. Are they going to be terrified from going 50 to 60? Not usually. But they're terrified to go from 50 to 100. So they're telling you, I haven't done enough work to feel confident and secure that what I'm about to do is going to go well. So if that's the case, if they're telling me I'm fearful, they need more work. And if that ruins your target return to play date, then so be it. Because if they're not ready, if they feel like they're going to go out and get injured, they're going to change their running mechanics. Their central nervous system is going to be firing differently. They're going to be tense. You're going to change all of their running mechanics, which is going to open them up to a re-injury anyway. So you might as well take an extra week to ensure that you're not missing 4 to 6 more. Yeah.
After each progression from like running, jumping, landing, all that, or and eventually like not take those things?
My answer is going to be okay, so the question was, is it important to do the central nervous system off days where you're periodizing high, low after you've already introduced some of these new exercises, or is there a point where you can have them doing back-to-back days? The golden answer is it depends. So what does it depend on? I think it depends on the rest of the context of what's around it. If you have, for example, 2 sprint days, 2 days apart, then that day becomes even more important to have a low day. If you have a sprint day and then you have the second day is a low day, a re-entry, moderate, high, then you could do either an off day or you could give a low day because it's just a progression of the low day. It depends on the rest of the week. How many practice sessions do you typically have in a week for track? 4. So if you've got 4 practices, you've already got 3 off days worked into that. So probably you can get away with doing more off days than less. But in a context like soccer, we might be training 5-6 days a week and then have a game on top of it. So if that's our context, then we probably need to find an off day or a low day to manipulate that variable around it. Cool. Any other questions? Got a minute left. I know this is a lot. 2 things. One, it's just meant to be a conceptualization or a framework that you can take back and apply. So if it doesn't make sense for your case, they were talking earlier on the other side about if you're 1 AT and you're providing treatment for 60 athletes, yeah, probably this much detail, probably too much for each individual athlete. But if you only have 10 people that you're working with, you should probably map out as much detail as you can. And then the other thing is for the return to play considerations, I made a cheat sheet. I'll send it to Bob and he can send it to you all of just the different variables to consider for the sport demands, the individual demands, and then the adaptations that we're trying to drive, whether that's strength, power, architectural, whether that's fascicle length, pennation angle, anything along those lines. So I made that cheat sheet so you can all refer to that and hopefully apply it to your own settings. Yep.
So taking into consideration having them come in and then doing modalities and stuff.
The question is, on the off days, are we still bringing them in to do modalities and treatments? Again, that depends. Do you have the time to work with the individual athlete? Do you have the hands available, or do you have 60 other people that you're trying to work with? If I have 60 people booked that day and I'm trying to get through all of them, I'm probably going to tell this athlete, hey, this treatment is probably not going to make that big of a difference for you. I'd rather you take the day off and then come back in and do something else. Or if it's really important for that athlete and they say, this is the only thing that makes me feel better, I need this to be able to start my sprint progression, then you probably have to squeeze that in somewhere and then you have to sacrifice something else. But so again, it depends on your context. It depends on who you're working with. Cool. Thank you all.
If you're gonna get food, if you haven't already.
Thank you.
The first is Jerry Palacio. Linda.
Okay, that makes sense.
And my mother-in-law. Joey Carrera.
Where was your bag? No problem.
Flavia Polani. Jackson Resurrection. Jerome Rogers. Kel Craft. Linus Watson.
Some people may be still grabbing lunch too.
Give me a name. I don't have the names with me up here. Actually, yeah. Andrew Moreno.
Oh, he would not be here.
Oh, okay. Donna Breingar.
What? All right, give me a number. Give me another. No. Yeah, give me a number. What? Oh crap! I didn't put numbers on this one. 2 and 20. What? 2 and 20. 13.
Eliza Berry.
Keep it for Linus.
He deserves it. He was here. I saw him this morning.
I didn't have
It may just be. It may just
I didn't see him
walk
out
out
there.
there. Caroline Hayes.
You gotta help me pick the next person. You ready? With your eyes closed, pick a random person on the. Perfect.
Brian Rainey.
Can we have all the University of Houston and Sam Houston Preceptor students that are in attendance? Can we meet on the steps so we can get a great picture of you all really quick? Leslie says, please chew your food really fast. So just on the entry steps, we would like to take a picture of you all so we can post it in our
Monthly.
Let me see if he's ready. Could be.
I think we're on.
Yeah.
Okay, welcome back, everybody. We are now moving on to our afternoon sessions. I am back on the mic, which means you get Bubba as well. So please welcome him as he does a presentation on why words matter.
So we're a package deal evidently in the afternoons for this. I don't know. So this talk I'm going to give is a bit of a soapbox moment for me. So I'm going to step on it here in a minute. And I'm going to make some people mad potentially, and not necessarily on purpose, but I'm old. I'm older than I've ever been. So some of the hills that younger people are willing to die on, I'm not. And that is what this has come out of, is those things. And so the title of this is Mind Matters, and we're going to distinguish between mental health care, psychological first aid, and self-care. And again, there's a reason I'm giving this talk. So my disclosures, I'm the past NATA D6 AT's care representative. I termed out last year, so I'm now just currently a team member. But by being on the NATA side, I was also the D6 or SWATA team leader for AT's care for 8 years. All mistakes are mine except for today. We'll go with Doug again because he had it on mute yesterday when I called him out. So he's back at it. So again, I talked about this yesterday. I don't really care about Bloom and their taxonomy, but you got to have some learning objectives. So I want you to understand the fundamental concepts of mental health care, psychological first aid, and self-care. It says including definitions and key characteristics. If you just basically know the differences, we're good. Okay. We're going to analyze them a little bit between the three, and it's going to be simple. I'm a simple guy. Okay. We're going to evaluate some of the effectiveness of various self-care practices. Okay. To reduce stress and create a good plan. And this is my learning objective, just like yesterday and all my talks. Take at least one thing away from this presentation. If you do, then my time putting it together was worth it, in my opinion. Okay, so one of the big things now with the BOC is these practice gaps. So where are we lacking in this area? I'm not going to read all this, but we play a critical role in the overall well-being of our athletes and others, right? But we need to understand the differences between mental health care, psychological first aid, and self-care. Not understanding those differences can affect the effectiveness. That works well. Can hinder the effectiveness of support provided to our athletes and others, especially every environment's high pressure, right? 7-year-old youth football player going to the NFL, baby. It's all high pressure. All right. See, there's Doug's first mistake because it's well-being. Okay. So we need to think about, what about us, right? How do we take care of ourselves and or support others in our profession? Okay. So what are those practice gaps in, more specifically? We have knowledge deficiencies in those three areas I talked about of mental health care, psychological first aid, and self-care. How do we apply them in practice? We're not real good at it. We're getting better. The integration of the concepts, it's kind of one of those, whatever, but it's in there. Okay. This is important in my opinion. We don't fully understand, many of us don't, the unique definitions, objectives, and approaches of mental health care, psychological first aid, and self-care. I'm beating that dead horse right now, and it's going to make more sense in a minute. Okay. But we do need to define the following. We've got to define mental health care. We've got to define psychological first aid, and we've got to define self-care. It matters. Okay. So I love this quote right here. Churchill was a funny dude. Okay. That's pretty good, right? If I were married to you, I'd poison your coffee, Lady Astor said. And he remarked, if I were married to you, I'd drink it. Pretty much sums up how I feel about this next definition. Okay. Mental health. This is where the mistakes begin in my mind. Mental health is, read it. I'm not going to read it to you. Read it. It is a global definition, right? It'd be like asking somebody, hey, what do you want to do? I want to be in sports medicine. What does that mean? It's a global definition. You want to be an athletic trainer, sports certified physical therapist. Do you want to be an orthopedic surgeon? Do you want to be a sports medicine trained primary care physician, musculoskeletal radiologist? I can go on and on. What is sports medicine? What is mental health? We need to know the differences in some of those buckets. All right, Bubba, so why this talk? All right, I've said it before. I hate social media. I think it's a cesspool, even though I have it and I follow people. I don't post. But athletic trainer versus trainer, not the hill I'm willing to die on. I don't care. Don't at me. I don't care. Okay? I've been called way worse. I guarantee you the physical therapist is considered a badge of honor if you call him a physical terrorist and not a physical therapist. They don't care. Okay? That doesn't matter to me. Again, I'm older than I've ever been. That hill, nah. But a lot of people get online on social media, Mr. or Mrs. Sportscaster, it's athletic trainer, and they are apoplectic if it's not used correctly. All right? What about these? Who has an asthma EAP? It's not an asthma EAP. It's a freaking EAP. So if you have an asthma EAP, which really is policies and procedures, what happens when the asthmatic can't be controlled with their rescue inhaler and it's now respiratory distress / arrest? Do you have an EAP for that? And what happens when they can't breathe and now their heart stops? Do you have one for CPR? When do you change? It's one EAP. I need more help than I can provide. Okay, soapbox moment. I would argue you need 2 EAPs. One for I need more help than I can provide, and one for suicidal intent. It's a different animal. The same emergent factors are there, but I'm not going to go on that. That's a whole nother 30-minute talk at some point. So again, if words matter, right, we need to look at this next concept or this next thing. Social media post again. And this is what got me thinking about this. I don't know who said it, and I'll paraphrase it. They posted something online to the effect of, I'm trying to be a good employee, a good spouse, a good parent, and I'm working on my mental health. What does that mean? Mental health, again, is a catch-all phrase. Are you suicidal? Do you need to seek professional care? Or do you just need to go have some wine and get a pedicure with your girls? Or go play golf or play poker with the boys? That's a big difference on this end of the spectrum than the other end of the spectrum. But if we're saying mental health, where is it fitting in there? Should I be worried or should I not be worried? Okay, so words matter, phrases matter. Okay, there it is right there. So, mental health care. Services and support provided to help individuals maintain or improve their mental well-being includes counseling, therapy, medication, other treatments aimed at managing mental health conditions, reducing stress, promoting overall emotional and psychological health. This is the professional side. Licensed social worker, psychologist, psychiatrist, I will argue clergy, pastor, those things, they're trained in this area. All right. But they may even say, you're beyond me. You need to go up the chain a little bit. Psychological first aid. This is my world for the last 9 years. Okay. It's not psychotherapy. It's a supportive response to help people cope with an emotional and psychological impact of a crisis or traumatic event. Again, I've said it. I've stood up in this podium and said it. My crisis is not your crisis. I talked about my wife yesterday. By the way, saw the doctor this morning, going to get an injection, ultrasound guided injection in her rib, end of the month. I won't keep you posted. Okay. But it's psychological first aid. We are trained, but we are short-term care. It's first aid, right? We provide initial first aid on someone. Does it need sutures? That's beyond us. Does it need a cast and an x-ray? We have to know when we're pushing them off. This is my world, okay? We're trying to make sure they're safe and taken care of in that initial response time. Short term, again, okay? It's an acute intervention, right? Just like they go down on the field, we go out there, okay? We're not providing psychotherapy. Self-care. We're going to spend some time in this realm. So practice or actions to improve or maintain your physical, mental, or emotional well-being. It involves, this is the best sentence of the whole deal, it involves activities that help you relax, recharge, stay healthy, and manage stress. Okay? We all think of self-care from work, but sometimes home is way more chaotic than work is. Work-life balance doesn't exist, people. Work-life integration. I could have a great day at work and go home and my two of the dogs are sick and my wife's not feeling good. I'd rather go back to work. Okay. Or you have a bad day at work and go home and it sucks too. Right. Or something along those lines. So work-life balance doesn't happen. Okay. So how do we apply some of this in practice? So a lot of confusion on when to appropriately apply psychological first aid in acute situations versus addressing ongoing mental health concerns. Now remember, psychological first aid is acute. Okay. Acute versus chronic. You typically don't have an acute, true mental health emergency, typically. It usually manifests itself over time. All right. But we want to offer some self-care strategies. So how are we going to do that? Okay. So us in the athletic training world, and I'll argue physical therapy as well, this isn't our wheelhouse. Okay. We struggle to integrate these concepts into our daily activities, our practices, okay, which gives inefficient support to those athletes or patients dealing with the stress, anxiety, or other mental health concerns. You know, how many times have you had somebody that, let's just say, tore their ACL and dad's mad because they can't finish the season and scouts were looking at them and they lose a scholarship. Ain't nobody losing a scholarship over an ACL tear anymore, right? Unless they dislocate the knee and there's a whole lot more going on, right? But the stress maybe of dad's mad at me or just the anxiety, they've never been hurt before. We deal with those and we deal with those pretty well. That's a light version of psychological first aid. But what if they still can't cope? Are we in a mental health crisis? No, but we need to know when maybe it's time to help them out and say, you're beyond me. We do it all the time. Look, it's your first ACL. We see them all the time. You're going to be fine. We'll get through it. Blah, 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 blah. Okay. We got to be able to help them out. And then we also got to know when we're veering out of our lane and we can no longer take care of them. But what are some implications? So for the athletes, misunderstanding the concepts can result in inadequate mental health support and potentially exacerbating any issues for them. So suck it up, buttercup is not always the appropriate phrasing, but sometimes it's necessary. And sometimes maybe we need to dig a little deeper to make sure this is not problematic. For athletic trainers, a lack of clarity can lead to burnout among athletic trainers. Yep, Doug's got another one there, right? Because I didn't say athletic trainer. As they may not effectively implement self-care strategies for themselves or their athletes, right? The best self-care strategy you can do is not live on concession stand food in the spring, okay? But it's hard not to do. So I look at this as kind of three pillars or three silos as to where these things fit, okay? So you've got one, let's just say the one on the far left, that silo is mental health care, the professional side. That middle one is psychological first aid. And that one on the far right is self-care. All of us should be living on the self-care side, okay? Because a friend can provide self-care to someone that needs self-care. Can you just sit in the room and be with them? You can, and I'll talk more about that, okay? But I'd be remiss if I didn't remind you that the Suicide Crisis Lifeline, the suicide hotline, can now be accessed via text message at 988. Okay, so put it in your phone. You can now do it that way. So let's just go through some aspects of mental health care. We all think of it as inpatient care, right? I saw something on the news this morning and I was drinking my first cup of coffee of the day. I won't tell you how many I've had. Talking about I can't remember where it was, but there was a mental health care crisis somewhere. And I think it was after a natural disaster. That makes sense. Okay. You've got your outpatient mental health care clinics. And so, we know a lot of people maybe that can be, therapist or whatever. Obviously that's outpatient, but they're seeing somebody, talking to someone. That can be talking, that can be medication, that can be a combo of them. There are other treatments that they can do. So we really think about these in like depression, PTSD. Just for understanding, PTSD used to be, you had to be struggling for at least 6 months. Now it's 6 weeks. They've dropped that really since the late part of the war on terror and a lot of the natural disasters. So that's down now. They can officially diagnose PTSD at about 6 weeks. Used to be, you have to go a lot longer. Okay, and again, I talked about suicide. Those people need true professional care. Our job in any crisis is to make sure they're safe, keep them safe, and get them to the next level of care if necessary, intact, especially in that suicide world. Psychological first aid. I've talked about this in the past in versions of multiple times. All right. CISM, that's Critical Incident Stress Management. Again, that's my world that I've lived in. It's through something called the International Critical Incident Stress Foundation. Okay. That our umbrella is under that. That's our training, goes through ICISF. Their model is what we follow. That's AT's care. Okay, that's our peer-to-peer support for athletic trainers following a crisis. Again, my crisis is not your crisis. I failed to mention earlier when I gave the update on my wife. I could go home today. Hey, Bubba, I want a divorce. Okay. Good luck on that shot, but I'll find somewhere to live. Let me get some clothes. I'll take the dog and I'm gone. But I lose the dog. I need some help. Okay. I'm joking mostly. Okay. So, but my crisis is not yours. Okay. So we have multiple levels of training for that. We have individuals in crisis, groups in crisis. Okay. And there's some shoot offs of that we've done. But we're there to deal with your reaction or response to that critical incident. Be that a cardiac event that somebody had to deal with, be that a C-spine issue, a medical diagnosis on yourself or a loved one, whatever it is. It's your crisis that you're struggling with. So we're there to help you mitigate that and get through it. And again, we are not psychotherapy. I'm beating that horse too to just remind everybody. Okay. So again, we have a model and rules to follow, and we have rules to follow on how many times I can make contact with an individual. So if I contact them a certain number of times and they're not improving, I am required to refer them for a higher level of care. Okay. I have to stay in my lane. Okay. And I'm in that middle silo. So we're not going down to self-care. We're going to professional. I've got to help get them there. All right, self-care. Where do we start? It could be 40 slides on self-care. So buckle up, all right? Just going to scratch the surface on it. Show of hands, who struggled with social distancing and being locked in during the pandemic? I did. It sucked. I'm a social guy. My daughter's built for it. She's an introvert. She's like, this is great. Okay. I didn't like it. And so some of us would meet, get some fast food, sit on our tailgates and eat so we could talk to human beings. Okay. I needed that interaction. I love being here for this, not because I'm presenting. That sucks for y'all. Okay. I like being here for the socialization and the interaction. So I hate the lockdown. Okay. So what are some of our options? The first one is not for me. Look at me. You can tell. I don't exercise. I don't enjoy it. I've tried it. Only way I'm running is somebody's chasing me. I've never had a runner's high. It's not going to happen. Okay. Healthy eating. No. Next, good sleep hygiene. Good sleep hygiene is important. A lot of bad things happen. A lot of bad decisions are made when you are tired. Don't make big decisions until you've slept on them. Okay. I'm going to end it. Well, that's a little different than I might quit my job. Let me sleep on that anyway and go, I just had a bad day. I'm not going to quit my job, especially because I don't have another one. Okay. So don't make big decisions on a knee-jerk reaction. Try to sleep on it. Hydration / alcohol. We need to stay hydrated, especially this time of year. Right? It's not going to be water. It's not alcohol. But if you like a glass of whiskey at night when you get home, keep having it. Doesn't matter. Now you're having 3 or 4, you might want to talk to somebody. Okay. But if you're having it, keep going with it. But you got to know that maybe you're over consuming. Get a massage. Okay. Never had one, but yeah, I hear they're good. All right. Get a massage. Soak in a bath. My wife almost every night goes in there, listens to an audiobook, sits in the tub for an hour. The dog will get mad, open the door and be like, are you coming out? Because we got to play ball. But she's in there. That's her self-care. Does it almost every night. And if she doesn't get to take a bath, she is crankier than normal. So it's, you want her to do that. Some people do mindfulness or meditation. I couldn't tell you how to do it. I don't know. I hear it's good. So try it. Journaling, mind dump, just write. Some people, I know somebody that just wrote one time, woke up at 4 o'clock in the morning, started writing, wrote 8 pages and go, I went back to bed, slept for 3 hours and have been sleeping all night since. They just needed to empty their brain of whatever was cluttering it. I've never journaled, so I don't know, but it's an option. Okay. What about setting boundaries? That's a little tough in our profession, but you can set boundaries in your professional life and your personal life. Okay. You can say no. It is okay to say no. Sometimes you can't avoid it. I can't help that we got rained out and now I got to cover the game tonight. That's life. That's athletic training, but you can say, no, I can't do that for you today. I'd love to help you, but no, screw you. It's not happening. I don't care. Right. Set some boundaries. Okay. Taking breaks. Now we got to define breaks. A break is not necessarily that I'm going to go on vacation during football season. That's not a break. That's stupidity. But give yourself some time to rest and recharge. What kind of hobbies do you have? Okay. I love to read. I've said it. Right now, I like fiction. I've always liked fiction, and fiction is way more sane than reality right now. Okay. And I'm horrible at golf, but I do enjoy it. And so I am looking for a swing coach. You have to teach me for free. So that, right? I just talked about reading. Try to limit your social media. I do not respond on social media other than happy birthday because I will get into a fight with somebody. Again, I just don't like it. I like following people. I want to know that you're a grandparent or your kid graduated high school or college. That's cool. Okay. But I don't care about the other stuff. Connect with loved ones if possible, if you like them. Okay. Go see grandma if you can, or hang out with mom or dad. Mine are old. They're cranky. It's short times when we go hang out with them. Laughing is the best medicine. That is not just a tagline. Laughing is phenomenal. When you laugh and your stomach hurts, how good do you feel after that happens, right? You've had a good time. You feel a lot better. Spend time in nature. Okay. Hang out outside if you can. It's hard to hang out outside in June, July, August, and nowadays September, October, November, etc. But spend some time in nature if you can. It does relax you. Some people like to pray. Some people like to go for walks. Music, right? Crank it up. Let's go. If it's too loud, you're too old. Doesn't matter. As long as the bass isn't thumping when you're next to me on the street, it's all good. Yoga, I can't touch my toes. I'm not doing yoga. Cooking, I love to cook. That's my relaxation. Okay, I enjoy it a lot. Art, not for me. Decluttering a space, that is my wife and daughter's happy place. They'll be in the pantry doing something. I will literally leave the house and come back and you can't find anything, but they're so happy about what they did. So, hey, good for them. Treat yourself. Treat yourself. A massage, something, okay? Mani-pedi, whatever it is. Do it every now and then. Almost done, okay? Resiliency, we got to have that connection. If we have connection, we're more resilient. Friends, family, laughter again, okay? How can you help someone? I talked about it earlier. Be present, okay? Hang out with them. Get off your phone and hang out with them. You may sit right next to them on the couch and not say a word for an hour with the TV on, but if you're off your phone and you're hanging out there, it may do more for them than anything that you can imagine. Be a friend. Listen to them. And when you listen, truly listen, most of us listen to respond, not listen to understand. Offer to help, but if you offer to help, you got to do it. Okay? All right. How do we live in these? We got to know what we don't know, right? Young athletic trainers don't really realize what we don't know. Old athletic trainers know we don't know a lot. Okay. And so we got to know what we don't know and not try to get out of our lane and go somewhere where we're not trained. You're going to create problems. On some of this stuff, if you think suicide and maybe even some of the other just talking to your athletes, what's your employer's position on some of this? They may tell you, look, if they're struggling, you can say, I'm sorry you're going through that, but you need to send them up and see so-and-so. So I don't know what your employer says. Find out because you don't want to overstep and get in trouble. What are you comfortable handling depending on your training and what your employer allows you to do? They may let you do more than you're comfortable with, so why are we going to try to do it? Self-care and be present again. And remember, connection is the best predictor of resiliency. Okay, if you have connections with people, you're way more resilient. A lot of these things that bother some people will not bother you, and you can go get over some things that happen quicker. Okay, if you want to do it, go get trained through the ICISF. We have something in Memorial Hermann called Code Lilac. That is ICISF Lite. They took all of our guys' stuff that he did and basically plagiarized it, not really, and made it simpler. Maybe take some suicide intervention training. We've got it at ICISF. There's mental health first aid. There's QPR. I don't care which one you use. Keep them from killing themselves. That's all that matters. Does everybody think theirs are the best? Of course they do. So as you've learned, mental health is multifaceted, and it's important to understand the 3 silos and utilize appropriately. So after this, how might you hear or interpret this statement now? Does it change how you listen to and think about what that individual's saying? And the answer should be yes, it's changed from the beginning to now how I think about my mental health and where my concerns would be. Thank you.
We have one question on Zoom. Somebody wants to know if you're aware of any studies being conducted or have already been conducted on PTSD or other mental health commonalities in athletic trainers.
In athletic training, I am not aware on that. That's really that emerging market, so to speak. Remember, we started AT's Care in 2016, didn't get rolling until 2017. And so I don't know of anybody that is doing that. But that would be interesting to see some data on. Cool, just one? All right.
Next up, we have Brett Singer. Brett serves as a sports dietitian coordinator for a team of 5 sports dietitians at Memorial Hermann Rocket Sports Medicine Institute in Houston, Texas. Within his role, Brett provides nutrition counseling for individual athletes while also providing contract nutrition services for several local high schools within the community. Brett helps lead the Memorial Hermann Sports Nutrition Residency Program, but outside his role with Memorial Hermann, Brett serves as the conference planning chair on the board of directors for the American Sports and Performance Dietitians Association. He currently serves as a consulting sports dietitian with the Seattle Sounders FC and has previously served as a counseling sports dietitian for Houston Dynamo FC, Austin FC, and Atlanta United FC. He previously served as an adjunct professor within the University of Houston's Master of Athletic Training program. Please help me in welcoming Brett Singer as he presents Are We Worrying Too Much About Electrolytes?
All right, to start off with, can I get a show of hands if you use these specific products, just so I can get a feel for it? All right, who uses Gatorlights typically or is aware of Gatorlights? Okay, what about Drip Drop? All right, Liquid IV. All right, and then Right Stuff. All right, we're gonna go with Liquid IV then, okay. Liquid IV is 500 milligrams of sodium, 520. All right, so we're gonna talk through some scenarios today and highlight some specific studies, and you can see kind of how Drip Drop fits within that narrative a little bit. All right, so I found over the years that a lot of my colleagues in sports dietetics really heavily use electrolytes and depend on it. And as I've kind of learned more about them, working in Houston, thinking it's a pretty significant issue, I've started to realize more and more that I don't know that electrolytes are maybe quite as impactful as we think they are. And so I'm going to try to make the case today through some of the research that perhaps electrolytes can play a role at times, but for the most part, oftentimes are kind of a waste of time and waste of money. Speaking to some of my colleagues in the collegiate landscape, one of them was spending $70,000 annually just for a Power 4 football team, just on supplemental electrolytes. Right? We're spending a heavy amount of time and finances on these particular products, and I don't know that the evidence necessarily lines up with their efficacy. All right, so why do we typically use electrolytes? Common phrases you'll hear: sodium's the primary electrolyte lost in sweat, which is totally accurate. Increases thirst and drives fluid intake, improves hydration, prevents cramping, prevents hyponatremia, and ultimately improves performance. All right, so before we get to the studies, let's just talk through hydration in general to start with. Okay, so when we talk through fluid balance, we're looking at 2 sides of the equation. So we have fluid loss, which is going to come in the form of respiratory loss, urine, feces, and sweat. And we have fluid gain, which is going to come obviously through fluids consumed, food, and metabolism. Okay, if we're losing more fluids than we gain, then obviously we become dehydrated. And as dehydration occurs, you'll start to see signs such as increased core temperature, increased heart rate, increased RPE, and a decline in performance, right? So if electrolytes are going to make an impact on hydration and therefore performance, they have to make an impact on this equation somehow. Okay, so we need them to tip the scales in favor of water gained in some form or fashion. So first we need to think through what could electrolytes potentially help, okay, versus what do they not really make a big impact on. So we're not going to change respiratory fluid losses with electrolytes, and we're not going to change fecal fluid losses through electrolytes either. Obviously, it's not going to have an impact on foods or metabolism. Okay, some people might think sweat. That's obviously the biggest culprit for the amount of fluid we lose during exercise, but no, electrolytes don't impact sweat, and nor would we want it to. Remember, that's the whole purpose of sweat, is to evaporate and cool. And so anything that would impair our ability to sweat would actually be more detrimental, not helpful. Okay, so electrolytes are going to have no impact on sweat. So the 2 most likely culprits for how it might impact fluid balance would be urine or fluids gained by driving thirst and increased fluid intake. All right, so as we look through these studies, we need to see an impact on these factors, and then we should see a downstream effect where if electrolytes are really going to make an impact, then we should see reduced core temperature or reduced RPEs, or we should see an improvement in performance or other factors such as those. So why do we consider electrolytes to be helpful? A lot of times when we look at papers or review studies that will suggest we need electrolytes, they'll oftentimes reference papers such as this one. Okay, in this particular paper, what they did is they had participants exercise and lose a set amount of fluid. So they go from baseline to we've lost 1.5 liters of fluid. And then they give them a set volume of fluid. So they either replaced it with 50%, 100%, 150, or 200% of fluid lost. And they did that in the form of an electrolyte-containing beverage or a low electrolyte beverage. Now what they did is they had those participants sit there and basically sit in an isolated room for 6 hours and just monitored how much they peed out during that time. Sounds super fun. But what they see here with this particular study is that with the high sodium intake, we're able to hold on to a higher percentage of fluid versus the lower sodium beverage. Okay, so that would tell us in this case, at rest, sodium makes an impact. Okay, but you and I both know that resting is not the same thing as during exercise. We don't make recommendations for rest and then apply it for exercise in the form of carbs, proteins, or supplements. So why would we do that for electrolytes? So what happens when we actually look at electrolyte studies during physical activity? Okay, so this particular study, they had participants cycle for 6 hours. They either gave them no fluids at all, or they gave them enough fluid to replace 100% of their sweat loss. And that fluid came in the form of either water or a saline solution containing containing 500 milligrams of sodium per liter. So in other words, a liquid IV per liter of fluid. Okay, then what they did is they monitored how much fluid they lost through sweat, respiratory, urine, etc. And what you'll notice is that there was no difference in terms of the amount of fluid that they had to consume to maintain fluid balance. There was also no difference in terms of fluid loss through sweat or urine or respiratory loss. Okay, so because we see no difference between the two drinks in those factors, we also see no difference in terms of heart rate, nor do we see any difference in rectal temperature. So despite containing or consuming an extra 3,400 milligrams of sodium, okay, which is a lot, right? That's 6 to 7 liquid IVs over the course of 6 hours. No difference in heart rate or core temperature or hydration whatsoever. So what if we up it? What if we go much higher with that? Okay, so this was 4 hours of cycling at 55% VO2 max. This is at a much lower temperature, so 68 degrees Fahrenheit. Here they either replaced 115 milligrams of sodium per liter, 1,100 milligrams of sodium per liter, so 2 liquid IVs, or 2,300. So roughly the 6 to 7 liquid IVs, 4 to 5 liquid IVs per liter of fluid. Okay, with this we see a slight difference in terms of urine loss. Okay, 500 milliliter difference between the very high sodium drink and the low sodium drink. We see no difference whatsoever when it comes to sweat loss. But because the urine output difference was so marginal, so 500 mils over the course of 4 hours, we still see no difference in terms of heart rate, rectal temp, or plasma osmolality. Now, the last 2 studies I highlighted are replacing 100% of fluids, which is neither really necessary nor recommended in most cases. So what happens when we actually replace a more reasonable amount? So in this particular case, they did 90 minutes of cycling, 65% VO2 max, and 90-degree heat. Here they replaced either 50% of sweat loss with either just water alone or 2,300 milligrams of sodium. Okay, that's a hell of a lot of sodium in 1 liter of fluid. Okay, again, that's 5 to 6 drip drops, 5 to 6 liquid IVs in the case of 1 liter of fluid. Here we see sweat loss, no difference. Urine loss, no difference. Fluid loss overall, no difference between the two. And because we see no difference in any of those circumstances, we also see no difference in terms of plasma volume or heart rate between these 2 drinks. All right, so maybe those studies, first off, those were all older. So I've been like faced backlash on that when I brought those up because those are all from the 90s and 80s. Okay, what if we need a more recent study? Those were all done in cycling. Maybe we need something that's done in running. So let me pose this one to you. An athlete runs 2 hours in 86-degree environment. They drink a sports drink that either has no sodium, 414 milligrams of sodium, or 690 milligrams of sodium per liter. Which do you think hydrates them best? Which do you think actually improves performance? All right, so here, this is 2 hours of running in 86-degree environment. And then after the 2 hours of steady state running, they did then a time to exhaustion trial, running as long as they could at 85% of their VO2 max. This particular trial had 12 separate arms. Okay, so what they did is they gave them enough fluid to either lose 2% of their body weight, lose 4% of their body weight, lose no body weight, or gain 2% of their body weight. And then within each of those categories, they either gave them a drink that had no sodium, marginal sodium, or high sodium. Basically, this was Gatorade with no sodium, Gatorade, or Gatorade Endurance is what the drinks are actually made out. This study is actually done by Gatorade. Okay, so when we look at, we're going to look at these two categories. So the 0 to 2% range, because that's the amount of fluid we should drink when we're exercising. And what you'll see is between the high sodium and the low sodium, that's a difference of 1,800 milligrams of sodium in this group, or 650 milligrams of sodium in this group, between the high versus the low. Okay, so what are the effects that we see? Again, no difference in terms of urine volume between the two drinks, no difference in terms of sweat volume. So it didn't change anything in terms of fluid balance. And because we don't see any change in fluid balance, again, we see no difference in our core temperature. We see no difference in heart rate, and we see no difference in RPE. So despite consuming an extra 1,800 milligrams over the course of 2 hours, no difference in any factor. Well, what about performance? They did a time trial or time to exhaustion trial at the end. No difference there. And they also did subjective measurements in terms of lightheadedness, total body fatigue, cramping. Again, no difference there. The only way they saw a difference was simply depending on the amount of fluid they lost. So whether it had a lot of electrolytes or none, it didn't matter. It was just simply how much fluid they consumed. All right, so maybe that's still not enough. Maybe we need to go even higher. Maybe we need to go even longer. Okay, so what if we did a longer trial with even more sodium? So this one came out about a year or so ago, and I think this one's pretty fascinating. Here they had participants run on a treadmill for 5 hours and at 60% VO2 max in an 86-degree environment. This study was a crossover design, so that means participants had to run on a treadmill for 5 hours, twice on 2 separate occasions. Okay, in the trial or leading up to the trial, they measured sweat sodium concentrations to identify exactly how much sodium each participant was losing. Then during the trial itself, they replaced 100% of the sodium they typically lose in sweat or no sodium whatsoever. And they did this in the form of pills. So it was either a pill in the placebo form or pill in the form of sodium. I should also note that they also controlled the diet of participants for the 4 days leading up to the trial and for the day after. And why that's important is because sodium intake leading up to exercise can actually change sweat sodium concentrations. So they controlled for that. So this equated to that the average participant consumed 1,200 milligrams of sodium per hour during this run. Okay. Now, what does that mean? How much does that compare to, let's say, other sports? So this is normative sweat sodium concentration data in different athletes. So the average football player loses roughly 1,286 milligrams of sodium per hour. Okay, versus soccer was almost 800, basketball is almost 800, baseball was roughly 600. Okay, so this equates to roughly what you would see in the typical sweat loss of a football player. Now, during the trial, they gave participants a set amount or a fixed amount of a carbohydrate solution. So a little bit of liquid carbohydrate in order to allow them to continue to run for 5 hours. And then they also gave them an opaque bottle of water and monitored how much fluid they were taking up over the course of the 5-hour run. Now they're replacing the bottle consistently so that way participants can't tell how much they're drinking, so they can't kind of control for that. And so this way they can monitor realistically how much fluid that the participants are consuming during this time. Right, so this is an extra 6,000 milligrams of sodium versus no sodium whatsoever. So what does it do in terms of fluid balance and any of the other factors? Okay, so I referenced we've got fixed fluid intake was the same because it was fixed, but our ad libitum water intake, no significant difference between the two groups or the two trials. So whether you consumed a ton of sodium or no sodium at all, there was no significant difference in terms of fluid intake. In terms of sweat loss, almost identical between the two trials. Okay. In terms of respiratory loss, again, almost identical. And then here, urine loss, 299 milliliters of fluid lost or 240. Now, remember earlier, I pointed out that if electrolytes are going to make an impact on hydration status during exercise, they've got to impact one of two things. They've got to impact urine loss or they've got to impact fluid intake. Okay, over the course of this 5-hour run, they peed out less than 300 milliliters of fluid. How much opportunity is there for electrolytes to really impact urine output during exercise? Most of our athletes don't pee a whole lot during exercise because blood flow is shunted away from the kidneys, it's going towards the muscle. We're not excreting much fluid during exercise in the form of urine, it's mostly coming in the form of sweat. Okay? So it didn't make any impact on fluid balance during this exercise. What about on any of the downstream effects? Do we see any difference on things like heart rate? No, we don't. We don't see anything or impact on core temperature either. They measured thermal comfort and rate of perceived exertion and no difference in between those either. And the all too common phrase that I hear athletes say, well, I was craving salt, so that must mean I needed more salt. So they measured salt craving over the course of the 5-hour run. Every 30 minutes, they asked them how much they were craving salt. And whether they consumed 6,000 milligrams of sodium or no sodium whatsoever, their craving for salt was identical between the two trials. Telling us again, that's not necessarily the best metric for yes, you need salt or no. So was there any difference at all in this 5-hour trial? Not during the exercise, but finally afterwards. Yes, at rest, it finally made a difference. So then they monitored fluid intake for the 24 hours following the activity, and there was a slight increase or difference between fluid intake for the 24 hours after, so it may have driven thirst a little bit afterwards. And they also retained fluid a little bit less or better because they excreted less fluid out through urine. Okay, so where we saw a difference was, again, at rest, not so much during the activity itself. All right, so that's all fine and good, but what about performance? We know it helps performance, right? Well, actually, no, we don't. This review paper came out several years ago and basically looked at all the papers we have that look at electrolyte use during exercise and performance outcomes. And out of the 5 studies that we have, or actually 6 now that we have, there's no difference on performance out of the 5 out of the 6 papers. Okay, so we really don't see much of an impact on performance. Now, the next question is, well, what about cramping? We definitely know it plays a role there. And I would argue that you're right. It's definitely plausible that cramping can be associated with electrolyte losses in some cases. But I'd also argue there's a heck of a lot of information that shows that at times electrolytes may have no impact on cramping whatsoever. And so I think we need to be aware that it's a plausible possibility that electrolytes could be impacting cramping, but I don't think we should say it's the tell-all or the absolute end-all solution for cramping. If we look at this recent paper out of the Journal of the American Athletic Training Association, we've got this particular kind of schematic showing us all the different plausible causes of cramping and factors within cramping. And I think this is a great review paper to kind of look at. And even further in this, where I really like this paper, is they've got 16 questions that you can ask the athlete to try to identify what some of the potential causes of that cramping might be coming from. Okay, and you'll notice out of the 16 questions, there's only 2 that actually relate to hydration or electrolytes. A lot are more related to other circumstances like fatigue or illness or medications or caffeine or sleep or any other factor. So yes, we need to look at electrolytes as a factor, but they're not the only potential cause there. So when do I need sodium intake? So this was a mathematical modeling paper where they basically looked at how much sweat are we losing, how much sodium are we typically losing, and how much fluid would we consume to drive sodium or serum electrolyte levels down low enough to where it's problematic. And basically what they're suggesting is that if we're exercising less than 4 hours, which is going to be almost all team sport scenarios, that you can simply salt to taste so that they can use as much or as little salt as they want, but salt's not going to be required, nor is it going to be really impactful in that scenario. Only when we're exercising for longer than 4 hours is it going to potentially play a factor in terms of maybe related to hyponatremia or anything along those lines. Okay. Now, if we're exercising more than 4 hours, then it depends on sweat rate. So if we don't have a very high sweat rate, that would be a scenario where we may want more sodium. Okay. And if our replacement of fluid is more than 70%, so in other words, we're drinking enough fluid that we're potentially driving down serum sodium levels, that would be a scenario where we might need to consume some level of electrolytes. Okay, but that would be the only kind of scenario where mathematically we're going to see a drop in serum sodium levels that would play a factor into why we might need electrolytes during activity. When we look at the body of evidence in terms of electrolyte use, there's a little bit before exercise that shows some potential benefit. So you can load with salt and fluid ahead of exercise and potentially hyperhydrate, but this requires a lot of sodium. And it also requires a whole lot of fluid, which I think is oftentimes going to probably be pretty uncomfortable for the athlete to be carrying that much excess fluid when they're running. But it is plausible and can be done. During exercise, we have little to no evidence at this point that electrolyte use has any impact whatsoever. Post-exercise, at rest, if we are not consuming food, then we have evidence to show that electrolytes can help with fluid retention and improve hydration status. Once we incorporate food into the meal, okay, then electrolytes seem to have not much of an impact, right? Because the food itself is playing the role in terms of helping with slowing down the absorption and improving the retention of fluids. So when do I use electrolytes? When the athlete believes it's important for their performance. So if the athlete's adamant that they need to take in electrolytes, then I'm game. Then I'll go for it. When the athlete prefers that particular drink and may want to consume more of it because of the flavor of it, then absolutely. Immediately following training sessions before a meal. So if I have training and then there's maybe a 2-hour gap between when they're actually going to eat and when training finished, that might be a time where I could utilize it. Or maybe between meals when rehydration is a priority. So if they've lost a ton of fluid and they're not consuming meals, then we can incorporate electrolytes there. But in my 6 years of pro soccer and in Houston Heat and Austin Heat, we almost do not use electrolytes whatsoever at this point. So am I saying that you need to avoid electrolytes or that they're harmful? No. Am I saying that we need to get rid of them altogether or that there's no place for them? No. But I don't think that they're a catch-all or a fix-all for every scenario when it comes to hydration or performance. And I think if we look at the evidence objectively, more often than not, you'll see that electrolytes probably aren't a good use of time or money. We're better off focusing on carbohydrate intake and fluid intake during the exercise itself and worrying a lot less about supplemental electrolytes. And with that, I'll leave this is my contact information. You're welcome to reach out to me here, anywhere, or on social media, and then happy to answer any questions or argue on the topic. I love debating this topic, so happy to go that route too if you want to. Thank you.
We have one question on Zoom for you. This person asks, in the general populace, it's advised to not overconsume sodium because of possible impact on blood pressure. Did these studies that you were talking about check blood pressure at all? Any thoughts?
No, these studies were done on healthy population. They weren't on, I don't believe there was hypertension in any of these particular cases. For general population, like we are being sold on, we have to have electrolytes for hydration. Like you're seeing it marketed rampantly. And for the average Joe, we definitely do not need these. In the case of maybe some exercise scenarios, it's plausible we might, but yeah, if someone's struggling with hypertension and they're not doing much activity at all, or activities moderate at most, then there would be no rationale for spending money on these or using these.
Yeah. What are your thoughts on like the commercial pickle juice or like consuming mustard for cramps?
Yeah, so that goes to cramps, and the same author that that co-authored this paper, so Kevin Miller, is out of Texas State, I believe, and so he is one of the lead researchers on pickle juice and on all that sort of stuff related to cramping. What they've shown with pickle juice is that it basically, once you ingest it, it sits in the gut for an incredibly long time. So pickle juice, when it relieves cramps, is related to the taste of it. It has nothing to do with the electrolyte content of it because it basically sits in the stomach for so long. And obviously, as we've seen for those anecdotal cases where it does seem to relieve cramps, it seems like it's in an instant, right? So it's at a point where it's not the electrolyte concentration, it's the taste. So this is why mustard, which has a strong taste, pickle juice, or we've seen Hot Shot as another brand that people will use. For some reason, there's the taste seems to help relieve the cramp in some cases. So I'd say if it works for your athletes or they like it, you know, obviously there's a lot of factors that could cause a cramp, but when it's in the middle of the game, you can't ask your kid about how much they slept the night before, or did they load too much on caffeine before the game, or did they train enough? Like those aren't things you can fix in the moment. In the moment, all you can do is stretch it, hydrate, and you can throw pickle juice at it and hope like heck that it's going to work. And it's certainly, there's cases where it does and some cases where it might not. So I'm all for it if they can handle it, but it's not the electrolyte, it's the taste itself if that's going to do it. Yeah, so potassium and magnesium. So here's the argument I would make. One, no. Two, potassium and magnesium are lost in much lower amounts to sodium. And so if we replace 6,000 milligrams of sodium and see no benefit, then there's no way we're seeing a benefit with magnesium. The amount of magnesium that you lose in sweat is ultimately like the equivalent of like 3 pumpkin seeds. Like we don't lose much. So brands will sell you on magnesium's really, really imperative to have in there, but that's total BS. Like I will call BS on that 100% of the time. I don't think sodium does much of anything. I know potassium and magnesium don't either. Awesome. Thank you.
Tell him I said hello. All right, y'all are live.
Next up, we have Natalie Bennett. She is a nurse practitioner in practice management for Dr. Walter Lowe in the Department of Orthopedic Surgery at UT Health. She earned her BSN from the University of Texas Medical Branch in Galveston and an MSNP from the University of Texas Health Science Center in Houston. She's a certified nurse practitioner by the American Academy of Nurse Practitioner Certification Board and was a previously operating room nurse at Kirby Surgical Center. Please help me in welcoming as she will be presenting on preparing the athlete for surgery.
Thank y'all so much. I am, okay, sorry. Okay. So I've been working with Dr. Lowe as an NP since March of 2014. He also did my ACL surgery in 1995. And so I want to say this is a little bit out of my comfort zone. I'm usually the assistant behind the scenes and not the performer. So, all right. So I don't have any financial disclosures or conflicts of interest to address, but I would like to just plug a little disclosure that I will be looking at my notes as I go through, because as I was preparing this, I had a lot of things I wanted to say with the slides, but my toddler mom brain was kicking in. So I am going to be using my notes some. All right. So we're going to be talking a little bit today. These are my objectives for this talk. And understanding the who, what, and why for preoperative rehab before ACL surgery. Recognizing the need to introduce sports psychology even before surgery, and how to help with setting expectations for after surgery. I've added a little bonus content called Low-isms, learning from the legend, and so I'll talk a little bit more about that as I get there. But first, I want to put in a plug for the Walter Lowe Knee Data Registry. So this is an entity that began in February of 2024 and comprises about 7 sports medicine surgeons within our group, UT Orthopedics. It's a database of consented patients with surgical knee injuries that covers everything related to the injury from even the surface that the injury occurred on, all the way through to their final return to play testing and then beyond. It's going to be really actually amazing to see how this data evolves into helping athletes in the field of sports medicine and possibly even creating new standards of care. And all of you today are going to be the first ever audience to hear some data generated from the WRL Knee Data Registry. All right, so who needs pre-op rehab in the training room? Well, our answer is everyone. How many of you have actually been nervous to initiate pre-op rehab in the training room or unsure if you should? Can you raise your hand? Oh, wow, okay. So everybody's very confident in when they should start rehab. That's good to hear. So we actually do see patients all the time because we get a lot of patients that have already been seen by a physician, had imaging performed, and then come to Dr. Lowe to discuss surgery treatment. And I would say that, we actually ask all the patients when they come, and most of my talk today is regarding high school and collegiate athletes. And so we always ask them, have they started rehab in the training room before coming to see us? And we can actually tell the answer before we ask the question, but we do ask it. And so it's probably about 50% that say that they have. But the ones that haven't are usually generally much more fearful. They're unsure of what's okay to do. They're also just kind of feeling lost about the whole process. And so this is where we really want you guys engaged to help us and help the athlete and really start this as soon as possible. But what about bucket handle meniscus tears? Do you think that you can start rehab in the training room with a bucket handle meniscus tear? Yes.
So the only difference is we don't really want them. We're not looking for the full extension like we normally would, especially if it's not coming easy. We don't want to force their knee through an uncomfortable range of motion, but it is okay to still go through the comfortable ranges of motion that they have. And we still want to get their quad activated. So those, it's really important to start it with everyone. All right. So what can we do in the training room? So this is just a list that I created. It's not all encompassing. You can do less, you can do more. Stationary bike is actually okay. We've even had patients before surgery that were planning to run a marathon and they still did that just because they're, going in a single plane and they were comfortable to do so. And so there's much more of a list that's okay than this. I just wanted to give you guys some things that are easy to work on in the training room. If you ask me to pick the most important, far and away, the two key components that Dr. Lowe is looking for to determine their readiness for surgery is full extension and good quad activation. You will actually be a rock star in our eyes if they come to us with a heel pop already. So these are actual, this picture and this video are actual examples of patients that came to us in their surgery consult lacking about 5 to 10 degrees of extension and couldn't activate their quad well. So we made an SOS call down to our 16th floor PT clinic and asked them to spend a little time with them. And this is about after 15 to 20 minutes of the PT working with them in the training room. In the therapy clinic. And if it's not this easy to get it to come back, and sometimes, the longer that they've been waiting to have surgery, the harder it is to get these things to happen. So we will actually postpone surgery if we think that they are not going to be able to get their full extension and get that heel pop. So we are really looking for that heel pop. Okay, why do we need pre-op rehab before ACL surgery? Well, one, we want to start getting them engaged in the rehab process. So a lot of times this has been their first injury. They're not really sure what rehab is or what it looks like. But the scarring process also starts very quickly after the injury. So if we aren't getting them moving, their chances for post-op complications really increases, such as arthrofibrosis. This is a real problem that we see, and the chances of this occurring can be reduced if we get started with the rehab early. So here's your first piece of knee registry data. We have found that arthrofibrosis is occurring in about 10 to 11% of patients. And so this was a group that was pulled from the data of ages 14 to 22 so that we were making sure to capture the high school and collegiate athlete range. And this is also where the arthrofibrosis complication required a knee scope within about 6 months after surgery. And from a clinician's perspective, there really isn't anything more frustrating to watch a patient go through. So arthrofibrosis is very frustrating for us. It's very frustrating for Dr. Lowe. It's very frustrating for the people treating the patient and especially for the patient and their families. It's a very difficult problem and we just really, really want to try to capture those patients early on so that we can help prevent this. All right, sports psychology. So sports psychology has been a part of our post-op assessments for many, many years. Dr. Lowe has worked with Robert Andrews with the Institute of Sports Performance, who's amazing. And they've worked together a long time. And I think it's most commonly used in the post-operative course and with return to play and return to the field.
But Robert recently started talking to me about how important and how effective it's been for him to start working with athletes even before surgery. Like I said before, this is likely their first surgery. It's likely their first time going to go under anesthesia. And these are very anxiety provoking for grown adults and especially kids. So here comes your second piece of WRL knee registry data. So this data is suggesting that preoperative psychological distress is a precursor for post-op complications. You all know these athletes better than we do. So you guys have built a rapport, you've built a relationship with them. You're able to see changes in their mood, changes in their appetite, changes with academics. Maybe the teachers are reaching out to y'all about noticing changes. So we want to start really assessing these things ahead of time and helping get them treated even before surgery. All right, so just a little plug about my injury as well. So my first ACL injury occurred in 1994, which was over 30 years ago. I can actually still tell you how it happened, where I was on the basketball court, what I was doing when it happened. And it's been really fixed in me and has created a trauma in my brain. And it's not, there's many differences of trauma, but this is considered a traumatic experience. So Robert actually has talked to me recently about starting to work with him a little bit just to kind of reduce some of the impact that the injury, even 30 years ago, has had on me. How many of you, by a show of hands, have noticed psychological changes in your athletes the first week or two after an injury and before surgery? Yeah, so most of you. Anyone want to tell me some of the changes that they've noticed in them? Anyone? Okay. More reserved? Quieter? Yeah. Yeah, for sure. So these are all things that we can be picking up on early on and help get them treated. And it helps create a much calmer experience, helps them be more confident going into surgery, and just really actually reduces their post-op complications as we're seeing with the data. Okay, setting up post-op expectations. So we're all on the same team. We all have the same goal. We all want to see the athlete thrive and conquer this journey with ease and confidence. Dr. Lowe's always been a strong advocate for athletic trainers. I'm sure that Bob, Bubba, Keith, all the guys that drive the Memorial Hermann trucks outside can vouch for that. But we want you engaged. We want you working with the athlete for sure. And we want to be communicating with you along the way. But we also will have them in formal physical therapy as well. And so it's really a continuum of communication. And it starts with, my goal is always to try to reach out to the trainer specifically right after a surgery and go over surgery updates, talk about the early post-op restrictions and goals. Sometimes I don't make that phone call right away, and so I apologize, but it is my goal. But you guys are also always welcome to reach out to me. We have a very open door policy with trainers. We want that communication. And so anytime that you have a question, please reach out. Text is usually the best way to get a hold of us. And we won't just have that conversation right after surgery. We're going to be discussing this along the way. We'll have our physical therapists. We have a core group of physical therapists that work with our patients, and they also communicate with the trainers and vice versa. So my morning and evening drives to and from work are usually involved with talking on the phone to therapists and trainers. And I love that part of my job. It's awesome. So we like the frequent updates. A lot of times Dr. Lowe will be like, how's Fernando, the running back from Katy High School? And I'm like, how do you know that? Like it's crazy the things that he says and wants to stay abreast of. So another post-op expectation that can be set ahead of time is if they are our patient, our post-op clinics on Tuesdays are a little chaotic. And so just setting them up to let them know that they will be there for a couple hours. There's the return to play testing that happens on the 16th floor before they see Dr. Lowe. And it's more of an experience in clinic. It's not necessary. We don't like to just use the word appointment. We have a lot of people involved and it's a production for sure. All right, so low-isms. What in the world is a low-ism? So when I was hired as his NP, I was really kind of stepping into an uncharted position. So I wasn't really replacing anybody. They didn't really know exactly how they were going to use me. And so our department administrator at the time just said, I want you to go follow him and learn all of the low-isms. And I'm like, what in the heck is he talking about? So, but here I am 11 and a half years later, and I'm still following him around everywhere. And I've learned that low-isms are a real thing for sure. So here's some examples that were applicable to this talk. But what I think a low-ism is a phrase representing his ability to capture the athlete's attention with humor or emphasis, but always with positivity that creates an impact on them. It worked even 30 years ago, and here I am. So, but these are all things that he says all the time. So I am a rehab snob. He's a self-reported rehab snob for sure. I want you to do 25,000 straight leg raises every day. And typically the response from the athlete is, what, 25,000? And then they kind of laugh, but he's actually kind of serious. So it's his way of saying you can't do too many. I will never tell you that you are strong enough. So that's a common thing that he says on their last visit when he's releasing them to return to play, just to make sure that they stay engaged with the rehab of their knee even after we're not seeing them anymore, but just making sure that they know that they can continue to get stronger. As soon as I see you have full extension and can do a good straight leg raise, I know you will get well. That's how easy this is. So he says that to almost every surgery patient, just because he even wants them to start with straight leg raises in the recovery room. He often says to them, make the nurses tell you to put your leg down. But he also knows that once we get that full extension, once we get that heel pop, and if they can do a straight leg raise, then they've already really eliminated a lot of the post-op complications that can come along with this surgery. If you do big things for big problems, you get well. So you've probably heard a lot of stuff lately coming out about posterior tibial slope, osteotomies, things of that nature, meniscus transplants, osteochondral transplants. Those are never fun conversations to have with families, but if they need them, they need them. And if you do them, they will get well. And then we see them returning to our clinic for another injury much less frequently. Tell the trainer PT you want to sweat more. So every now and then they'll come to our post-op clinic and be sweating. Some of them have thrown up downstairs and they're just not, it's a harder workout than what they have been used to. And so he'll tell them that, hey, make sure that the trainer knows you want to sweat more. So I just want to give a shout out to not only the physicians behind the knee registry, which the list is in front of you, but also the physical therapists, the data collectors, research assistants, et cetera. This is going to be something special. And it's just getting started. So, and you guys were the first ones to hear some data from it. Thank you. Are there any questions? Yes, ma'am.
We've got one from Zoom. Basically, I think just any tips you have with being ATs, how we can effectively communicate and collaborate with our physical therapists that are working with a common patient.
Yeah, so most are very, well, for sure email. They all give out their email addresses. Most of them will give their cell phones. I give my cell phone. Dr. Lowe frequently gives his cell phone. So yeah, just reaching out, and usually that establishes a conversation that lasts for several months as they're continuing to go through the course.
And is there a specific brand of surface EMG that y'all like to use in your clinics?
No, not really.
Thank you, ma'am. Sam's going to take you in to see Jerry. Mark Knoblauch. Was that quick enough for you?
You can leave that up. I was afraid it would show up with the presenter view. It's fine.
Okay, I'm going to give you, it's okay. I'm going to give you laser pointer just in case.
Yep.
So whatever you see here, laser pointer show up on all three screens. I'm just going to pull it down here. So your cursor's
Oh,
there.
the cursor is the laser.
Yeah, what is that? All right.
And then how do I just advance through the?
Advance it with the arrow. Okay. So I'm going to make the mic. So stay here, right? Yeah, they'll give you a 5 minute. In the back, if you go over, they'll give you an upside down 5, and I'll come with the shepherd's crook and yank you off the thing. All right, I'm going to make it hot again. I thought I turned it in. Oh. I never changed the batteries up. Okay, we're good.
Up next is Dr. Mark Knoblauch. He's a program director and clinical associate professor for the Master of Athletic Training program in the Department of Health and Human Performance at the University of Houston. He received his BA from Wichita State University, MS from the University of Nevada, Las Vegas, PhD from the University of Houston, and postdoctoral fellowship at Baylor College of Medicine. He is a certified and licensed athletic trainer, a certified strength and conditioning specialist by the National Strength and Conditioning Association, and has been the former head athletic trainer at Lamar University and Pratt Community College, very accomplished with several book and peer-reviewed publications. Please welcome him as he will be presenting the generational gap, finding common ground in the athletic training room.
Thank you. I know it's getting late, but how about we shift from treatment protocols and range of motion to making fun of each other? Okay, so we're talking about the generational gap. I want you to pay kind of close attention to this title because we're going to come back to it in a little bit. But I don't have any disclosures, and I completely forgot to post my learning objectives, but we're going to learn about generations. So what we're talking about, first of all, are the generational categories. And this is going to be a somewhat audience participation type presentation. So I need to read the room here a little bit. When I show these categories, I'll go through them. I want you to raise your hand when you see your category here. So I don't think we have any silent generation. That's the birth year. How many baby boomers? Raise your hands really high, please, so I can see. Baby boomers. All right, Gen X, where are we at? Gen Xers. Okay. Millennials, where are you at? Raising. And then Gen Z. I know we have a lot of Gen Z in the middle. Okay. So, and then we shouldn't have any generation alpha, but they are going to be, as you see here, they're going to be the people that we're treating at the middle school level. Gen Z are going to be your high school athletes, some of your college level, but millennials, these are going to be your actual athletic training peers, young professionals. Gen X, your older athletic trainers, kind of approaching the old timers, but also maybe in some leadership roles along with the baby boomers. Now, not everybody likes the category they're in, so they do have some subcategories. Okay, I've heard this before. Well, I was born in 1982, but I am not a millennial. And I said, that's great. You can actually be classified as a zennial. Okay, so you don't have to necessarily like what you're in. They have some subcategories, and that's great. Gen Z has their own type of zennial, and that's the person that says, well, I use Facebook. And then here comes a later Gen Z, and he's like, who in the world uses Facebook anymore? So they have these categories. So some characteristics, largely communication preferences. Your baby boomers, they're the ones that, read the newspaper in the morning. Now they've kind of started to switch over to social media, maybe read the newspaper on their phone. Gen X, we communicate, we like phone calls. The baby boomers may still be a face-to-face type person. Millennials, they use email. They're really into Facebook, maybe instant message, communicate over Facebook, a little bit of social media as well. Gen Z is pretty much all social media, Instagram, Snapchat, etc. And then Generation Alpha, they really get a lot of information, it's been shown, from influencers, okay? And they are really into this concept of AI. So when it comes to AI, we've all heard of it. A lot of us are familiar with it. Some are less familiar. Some don't want to be familiar with it. Baby boomers generally do not have, the studies have shown, generally do not use AI in any form, knowingly use it in any form. I'll explain that in a minute. Gen X sees it as kind of assistance. I'll type up my email, but I'm going to stick it through Grammarly, have them proofread it, make sure it's okay. Gen Y, they kind of use it, but don't want people to know they use it. And then Gen Z with AI, that's the standard, that's what we do, okay? Tell a program what you need to say, and it'll say it for you, okay? So 60% of Gen Z uses Chat GPT daily, okay? So, question everybody asks, well, isn't it cheating, okay? Is AI use cheating? And that's a valid question. So I ask you, is Microsoft Word, when the little blue line comes under and you're like, oh, I got to fix that grammar, is that cheating? Because that is AI, okay? When you text, how many of you hit the button on autocorrect? Hit the word so it fixes it for you. That's AI. Is that cheating, okay? I'm going to specifically talk to the boomers and Gen Xers. Remember your fourth grade teacher. What did he or she say? You're never going to have a calculator in your pocket at all times. You need to learn long division. How many of you have done long division the last 30 years by hand? Well, charge your phones. You're lying, or you charge your phones, one or the other. Okay? We all do it, right? We don't do, things evolve. And so one of those, we're using AI, we're using our phones as calculators, etc. So with AI, as a Gen Xer, I fought it forever. I was not going to use Chat GPT. I heard about it. I knew it was out there. We have our quote unquote official policy on its use in the universities. And so one day, February 12th, I got a really nasty email, and it said, hey, I really need your topic for the sports medicine update. And I said, oh, crap. So I was sitting at my daughter's track meet. It was 55 degrees outside, so it was cold, because when you get older, 55 degrees is cold. So I was sitting in my truck, and I'm on my computer typing it out. No, I didn't like it, redid it. Like, it's for athletic trainers, it's generations, but I don't want to be just the generation gap, because that's just, I'm typing it. And then I started thinking, So we'll have a colleague that actually gave a talk. I won't say her name. It rhymes with Garrison, but I'm not going to say her name. But she gave a talk in an AI conference about AI technology in the classroom. And so she was saying it was really cool. We actually kind of plugged in some info into the AI chat GPT, and it spit out an abstract for us. And we used that abstract. I'm like, oh, that's really cool. That's cheating, but it's cool. So I'm sitting there and I said, for the first time, February 12th, I said, I'm just going to go to chat GPT and I'm going to see what it looks like. And I knew it was going to be one of those where you got to pay or you got to give your credit card. And if you don't cancel in time, you'll be getting, $30 a month, because I'd never been there before. And so I like sweating and nervous. I'm typing in chat GPT see, I'm talking about chat GPT and there's a message. I shouldn't have did it. And so I typed it in, or I went to the website, and it literally was a search box. I had no idea. I'd never been there before. I heard about it, and this was, 3 months ago. So I nervously typed in title for a talk to athletic trainers about generations. Within 3 seconds, it spit out 15 titles, one of which I used. Am I cheating? Am I less qualified as a presenter? It depends on what your generation is. Some of the younger generations, why would you not have done that? Why did it take you until 2025? Some of the older ones are saying, well, you must don't want to use your brain. So I started thinking, well, to the older generations of athletic trainers, raise your hand if you have never used ChatGPT before. This is what I want to see. This is great. And looks like most of us are going to be in the same generation gap. So I thought, if you haven't used it, could you benefit from it? So once I got all of a sudden addicted to it because I realized how powerful it was, and actually learned, I just heard on the radio the other day, they don't Google anymore, they chat GPT. So that's kind of becoming the new thing. So I just said, just for an athletic training, I really need a new golf cart, for example. What if I just asked chat GPT to write me an email? It took me that long to write that. Within 3 seconds, I had an email. Pretty dang professional. But at the bottom of it, what makes it really addicting is it says, would you like me to make it more convincing? Would you like it more professional? So directly underneath this response, I typed, make it more convincing. ChatGPT says, you got it. And within 3 seconds, we had an email. Okay? So I thought, well, what else could athletic trainers do? Oh, I know it. I have not done it, but I know what we could use it for. Write a 300-word letter of recommendation for my student aide, Anna Smith, who's trying to get into the University of Houston to study exercise science. She's always on time, has a great work ethic, and I trust her to get the job done. As a Gen Xer, I need to carve out 30 minutes to write that. But to a chat GPTer, within 3 seconds, I had this. Okay? Now, it looks pretty good, and some people will say there's no way you'll know who wrote that. I can tell you there is a little trick when you write long enough. Those little dashes in ChatGPT fill up the whole space. In emails and Microsoft Word, there's always a space and then a dash, so you can there's one little kind of giveaway there, but it's a really powerful tool. If you have 13 letters of recommendation to write, is it cheating to have something write? I won't say someone else, I'll say something, write it for you. But you've just saved yourself 3-4 hours of time, okay? So generationally, this is kind of making fun of us older ones. This is a powerful tool that's there. Whether you choose or not to use it or not is up to you, but it's there, okay? There's some other things we have problems with. Emojis, communication, because a lot of students will text you emojis or text you and throw in an emoji and it gets a little confusing. So raise your hand. How many of you know what this emoji means? What is it? Somebody say, what does it mean? Prayer, thank God, right? Did you know that some people argue that that's actually a hand slap, high five? Well, so I did some looking and I said, what is it? And the actual answer is it really is a prayer emoji. This is the original, okay? But some people say, oh, no, they mean high five. And somebody says, no, they're praying. That means please, right? There's some other ones out there. What does this emoji mean? Great job. Gotcha. Raise your hand if you're in there is research on this. Raise your hand if you know why that emoji is annoying or offensive to some people. Does anybody kind of like, okay. So some people, when you click the thumbs up, that's offensive to them. Not like they're like, oh, I can't believe you did it. It's like, they did the thumbs up because they think you're like being like snide about it. Like, okay, got you. All right. There's some confusing ones out there too. All right. It's the upside down smiley. It has so many meanings. It's silly. It's sarcasm. Some people say it's a kegger. What do you call it? Upside down. Now I forgot the term. Upside down with the keg. What's it called? Keg stand. Yeah. So really, very weird. So when you're texting these trying to be funny, they can be taken out of context. All right. This is kind of funny. I actually realized I was doing something before I learned that my generation does this. Okay. What is that called? It's not an emoji. What's it called? Ellipse. How many of you have heard of the Gen X ellipse before? Anybody? I was doing that at the end of my texts before I learned that that's called the Gen X. It's kind of like almost like the straight face, like, yeah, we were doing that. And there's a name for it. It's called the Gen X ellipse. So I was doing, it's not really offensive. It's just tied in. Some people do the 3 exclamation marks after every sentence. It's crazy. Okay. So, I mean, there's a lot. There's some emojis that I don't understand and never will. I get strangers for some reason. You can explain this to me. I get strangers that they really want me to go and buy a bunch of eggplant. I don't know what the heck. So if you got, I don't know. Am I wrong? I don't know. I still haven't figured it out. Okay, but in 2024, there were 118 new emojis out there. So when you're just randomly sending them, you got to know, is this offensive? Is this going to be interpreted the wrong way? Whether it's a younger generation to an older to a younger, you got to be careful. Okay. So this was a punch in the gut about generational talk. About 6 months ago, I was talking to my class. And I was telling them about this tennis player who we're talking about performance anxiety and things like that and stress and how it can affect your performance. And I was telling him a story like, oh, there was this tennis player and he was kind of a really well-known, almost like a sex symbol in the 80s or in the 90s. And he had this great hair. And one tennis match, he actually lost because his hair, he was losing his hair, but had a wig on during his match. Okay, so I want everybody, I'm gonna show his picture, but when I said his name, every student of mine was like, who is that? So what I'm gonna do, so you know the story, everybody raise your hand, please. If you know who this is, go ahead and raise your hand. Everybody just go ahead and raise them now. If you know who this is, keep them up. So everybody raise your hand. When I show you his picture, if you know who it is, keep your hand up and everybody watch. I want everybody to look around, okay? We all know who that is what I thought. Everybody knows who that is, right? Not a single student in my class knew who it was. And that is, of course, who? In unison. So I thought, well, is it a me problem? Is it like maybe I don't know. So I just went and I took a name from current popularity, I guess, and I typed it into Google and I got the image and I said, I wouldn't know this individual if they sat next to me. So everybody raise your hand one more time. If you know who this person is, keep it up, because I would not know this person if they sat next to me. Ready? You know who that is? Keep your hand up. So you see that, do we see what happens to be where the students are at? Here and here, generational thing, mostly. Who is it? Kendrick Lamar. I would have known him if he sat next to me. So it's not just me being annoyed they didn't know who Andre Agassi was. It's also works both ways. Okay. All right. So slang words. All right. When I was growing up, we had our slang words. You got clocked. It meant this very clearly. You got plastered right in the face. Okay. Gen Alpha, when I heard the word clocked, I said, what does that mean? And the answer was, you got called out. She totally clocked you, meaning you got burned. Okay. Sweet. Pretty awesome. Great to hear. Current generation, it's yeet. All right. Now we have some dumb ones too. Okay. There's dumb ones that exist amongst our generation. For me, I was toast. I got toasted. Okay. You got burned. It was, you did poorly. Okay. Gen Alpha, really dumb one. Skibidi toilet. Come on. Seriously. All right. So it works both ways. Now, understand, it's not just generational, it exists out in society. There are differences in athletic training as well. Okay. One of the most famous ones is we had the internship athletic trainers. Where are you at? Raise your hands. Okay. And then everybody else will be obviously the accredited program. Okay. So internship, you showed up and they sent you out somewhere. You went to some high school. It was just kind of see what happened every day. Okay. Accredited program, it's very structured, but we've also had some other changes as well. Okay. Certification exam. Raise your hand if you took the 3-part exam, right? Okay. Everybody else, it was the end of the profession. One was the end of the internship, the end of internship was the end of athletic training. And then in 2007, they had the 175 question. It was the end of the profession. If you are certified and took the 175 question written computerized exam, could you stand up for just a second? Those of you that are not standing, look at these individuals. Does anybody see any bad athletic trainers there that are just terrible? I don't think so. I'm betting at some point, some of you said, oh my gosh, great athletic trainer. All right. So it was if you remember, it was the end of the profession. Like, how can you not test their practical skills? And here we are. And we have some great athletic trainers out there. So again, not just generational differences amongst the societal part, but also even within our profession. And we seem to be doing just fine. All right. So within healthcare, there are some generational differences as well. Okay. There's the cohort theory, including in healthcare. We're really going to be focusing on this bottom part. Okay, about some difference. I know you can't read it, but we'll break it down a little bit more. That you have to take into account with your patients as well. Okay, so just viewing healthcare alone, there are major differences. All right, silent generation. All they cared about is, are they healthy or not? If they're fine, that's all that matters. We don't care about prevention. I need to know, can I go to my work every day? Okay, baby boomers. Very famous for what their physician, what their health provider tells them is gold. Okay. I don't care what I read on the internet. My doctor said we need to do this. This is what we're doing. Gen X, there was a trend moving towards preventative health care and also the introduction of accepting mental health care. Okay. So you're seeing a transition there. Millennials are considered the most health conscious generation. They have a more holistic view, okay? Mental health, physical health, preventative health, et cetera, eating well, sleep emphasis, nutrition, mindfulness, et cetera. Gen Z and Gen Alpha, another very strong holistic. They really implement the mental health side rather than just the physical. They're more willing to talk about mental health. I ask my students all the time, how many of you would be willing to tell me that, hey, you won't be here tomorrow, I've got to go to the doctor? They all raise their hand. And I say, how many of you would be willing to tell me you can't come to class tomorrow, you got to go see your psychologist? And none of them do. So there's still a stigma, but that stigma is slowly getting broken down, and we need to keep breaking it down. All right, decision making, okay? A silent generation, again, those are the individuals going to be, currently 85, 90 years old. Okay, again, doctors with the silent generation, much like the boomers, they really rely on what their provider says. In this case, that provider is going to be you. So if you tell them they need to do something, they're most likely going to do it. They need to sit out, if they need to take medication, do rehab, etc. So expect that what you say with them is really going to be adhered to. They typically have long-term associations, so they might come back and see you 6 months after a vacation or something. They come back to you rather than just like, I'll go here and I'll go here and etc. Boomers seek information on medications, practical health care, nutrition, or exercise from providers. So they expand a little bit more than just what do I need right now, but it's more about prevention. Okay, that's about how can I sleep better rather than just I'm not sleeping good, but I'm not worried about it. I still feel okay. More likely again to follow their provider's advice. They start to introduce internet searches about what other opinions are out there, but I'm still going to listen to my physician. Gen X tend to be skeptical of large institutions. So your health insurance, for example, they think health insurance is out to get me. They're not going to let me do what I want to do. They seek health information from a variety of sources. So their provider, they'll also check the internet and adhere to what the internet says. They check with their family. What did you have done for this? And they tend to form an opinion rather than just doing what their provider says. But they still do adhere to their provider predominantly, okay, but not as strong as the boomers and silent generation. Millennials, actually only about half of them will see their primary care physician per year, okay? So they're not really wanting to go in if they don't have to. They really look at reviews, patient testimonials, peer input, okay? Who did you go to? Well, that's maybe who I'll go to, okay? And then Gen Z, they're actually more likely to trust information from the internet than from the provider. Okay, so what that means for you, this is Gen Z, this is your high school athlete into college. You're going to tell them something, they're going to go home and find what they can on the internet, and they're going to come back and say, well, what about this? So be prepared that the younger generation is going to challenge you. Sometimes that's good, make sure you know your stuff. Other time it's frustrating because now you got to go and try and prove an influencer wrong, okay? All right, digital technology. So, using the phone, okay? Using MyChart, okay? A lot of us do that for your own healthcare. Well, how does that influence what your patients will see, okay? Boomers are more willing to engage with digital technology than the silent generation who just didn't do it. But they're more reluctant or less likely than the younger generations to do it. Gen X is comfortable with using digital technology. So if you tell them, I'll put your notes on MyChart, they're going to probably read them. Okay, boomers are less likely to read them. They'd rather just, tell me what I need to do. Millennials heavily relying on digital information. Okay, social media is a good source for them. Not always bad, but it's hard to verify on social media. Gen Z, Gen Alpha, they're very tech savvy, so they're going to heavily rely on what they see and hear on the internet. So you have to be aware. You're going to be fighting a lot more with your younger generation's input about their healthcare than you will with the older generations, okay? Because they're going to see, somebody said, all I need to do is, sprinkle cinnamon on it. And then you're going to have to fight that and say, let me tell you why that doesn't work, instead of saying, no, they're wrong. So, because they're going to say, well, that's what everybody's saying. There's this new trend out there. And so just be prepared for that. And they're going to be on their phones and they'll probably find it and you can watch it and be able to contradict it. All right. With understanding the digital technology, there is something to be very keen on, okay? It can broaden the reach of health information, but it can also create a divide. All right, individuals with higher levels of digital literacy, those that understand digital technology better, are better able to coordinate healthcare. They're have better involvement in their medical decision making, and they have improved health outcomes. So those that are digitally savvy have better health outcomes. That's important to understand. So you might have to fight that and help the older population that doesn't, know how to log into MyChart, for example. Okay. Explain to them, this is where I'm going to put your information, your treatment plans, et cetera. Or you might have to actually give them, print off a plan for them, whereas everybody else has it electronically, because it actually improves their outcomes. More tech savvy individuals, more improved healthcare options. Okay, so it creates an unwillingness of some individuals to use or access health information that's available via digital health tools. Okay, so if it's not available online, they may not use it. For some, if it's only available online, older population, if it's only available online, they may not do it. So you have to have that backup paper copy in many cases, depending on the age of your population. All right, so when you're doing things like posting jobs, there's a new kind of bit of research about how you post your job can attract certain candidates, okay? And you see here, this is a boomer type job because it doesn't mention some of the things that the millennial or the Gen Y, the millennial is very interested in, okay? Things like mental health, access to culture. Boomers just don't care about culture. They care about salary. They care about what's their patient load going to be. Whereas, as you'll see in a minute, the Gen Z, the millennial, they care about work-life balance. They care about family time, okay? So posting that may attract certain individuals that you may or may not want. When it comes to benefits, okay? Boomers, they're looking for salary level. They're looking for bonuses. Are they covered in health insurance? What about retirement planning, okay? Gen X, 401k matching. That's what we care about. Job security. Am I going to have to move? Is this a solid job? Any opportunity for advancement? Millennials, there you see, flexible schedules, benefit choices, PTO, parental leave, okay? Wellness benefits. These are all things that you have to think about when you're even looking for candidates. Some of you say, I'll just take what I can get. And I understand that, but these are the things that might come up when they're on site. Like what time do you get off in the evening? You're like, well, we have a game. Like, why can't we schedule rotating schedules? Those might be the things if you just hire someone versus somebody that actually understands what you're looking for. So this was kind of funny. It's not just athletic training. Reddit, what's some of the biggest differences between boomers and millennials millennial attending physicians as it comes to approach to medicine? Okay, this is copied and pasted. My group split down the middle, dinosaurs and the younger millennials. Our meetings are hilarity. Boomers are fine with seeing 1 billion patients a day, all money, 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 while millennial colleagues value work-life balance. This is kind of funny. One of my boomer attendings said MD Calc will be the end of Western civilization as we know it. MD Calc is basically like a little algorithm calculator. If I have a patient with this, this, and this, what's the best treatment? And older physicians expect you to know that. Younger physicians I'll plug it in. They literally putting it into a calculator the same way we're doing that with math, okay? Boomers do things they've always done. Millennials change their plans with every new study that comes out. How many of us are like that? How many of you say, this is the way I've always done it, so I like it? How many of you actually read the literature and say, I've seen 3 studies that say this is a little bit different, and I'm going to do it this way? Boomers tend to find and criticize an individual instead of looking at the layers of issues surrounding an error or a problem, especially when it comes to addressing overall culture. So this person was late, is a boomer. Boomer says. A millennial, Gen Z, would say, hey, is there anything I can help you with? I see you're late for the second day. So it's happening everywhere, not just in athletic training. All right, understand too, generational differences. There's the old school model that I grew up on. You're there an hour before everybody. You're there an hour after everybody. You're the first one to get there, last one to leave. Okay, you may have been the only athletic trainer there. You got to be available at all times to help your patients. Cell phone. I knew of an athletic trainer that their house was across the football field, so he would just have his coaches walk kids over there any time of the day or weekend and just have them be evaluated at the house. How many of you would do that? A couple. Are you a bad athletic trainer if you do? Or are you a bad athletic trainer if you don't do that? Don't allow that. Like I'm setting my boundary, okay? There's the new school medical model, okay? You set patient appointment times. If coach moves practice, the coach doesn't have an athletic trainer because you told me this was our practice time, okay? So this is all coming from research about burnout, about salary, about hiring options. So we have to accept that this is what's happening in our profession, okay? So can we get along? Well, there are characteristics for every generation, okay? Boomers, they know deep institutional aspects about the school district, about the state, how it works. So use them as resources, okay? Gen X, they can see both sides. They kind of know old school, but they understand the younger generation. Millennials, highly tech driven. They're very energy efficient or efficiency driven, okay? There's a new app out there. Have you thought about using this app to help manage your schedule about recording injuries or recording mental health, et cetera? Okay, Gen Z, your AI people. Can you implement that in your athletic training room, in your policies, et cetera, with your students? All kinds of things you can use to find their characteristics and take advantage of them rather than just criticizing them, okay? So veterans, okay, we call them boomers and Gen X. They've been there a while. Again, their strengths, they have hands-on experience. They know injury patterns that happen at the school or the youth. They know the emergency care. They have contacts to get that EAP set up, et cetera. Your younger athletic trainers, they're fluent in research. They're fluent in evidence-based practice, technology like wearable sensors. They have a holistic view of healthcare rather than just treat this issue and be done. They can connect with the athletes pretty well as well. And then the last one, this is why it's beneficial for individuals to get along. It's not just criticize, they don't do it. Younger kids don't know what it's like. When you have something that works because you actually adapt, then you have things like seasoned athletic trainers bringing wisdom and crisis management and expertise, younger ATs contributing cutting edge science and technology fluency, okay? Multi-generational teams offer both traditional trust building methods and modern wellness tools to better serve diverse athlete needs, okay? So there's a lot of things we can do if we just get along, if we adapt, okay? And we accept that maybe some of my characteristics are not the best fit, but if I just take a step over here into theirs, I understand their point of view, okay? So hopefully it just opened your eyes a little bit. There are generational differences. You have to accept that their differences are there, but instead of setting up a brick wall and not letting them in or not letting yours out, work together. It's going to influence the athletic training room, okay? All right. Anybody have any questions? Yeah. By the way, I'm going to say, side note, since I had 3 seconds left, I actually stepped out of mine because I'm going to give a talk on telling you need to do it. So out of my car is my suit jacket and tie. And I said at 10:45 this morning, I said, you know what, I'm going to get up there and I'm not going to wear a suit and tie. Because my generation, if you're giving a talk, you talk in a suit and tie. So hopefully it's a practice what you preach. And I didn't come across as unprofessional because I wasn't wearing a tie. Maybe one of my emojis was a little unprofessional, but was the upside down face was unprofessional? Sorry. Anybody having questions? All right.
Mark. Right, there you go.
Up next, we have Denise Nichols, who has served for the past 24 years as a prosecutor in the Harris County District Attorney's Office. Recently promoted to Bureau Chief of Intake, Denise formerly served as a Division Chief of the District Attorney's Crimes Against Children's Division, where she spent over a decade persecuting child abuse offenders. Denise received her undergraduate degree from the Texas Christian University and her law degree from the University of Houston. She has been a member of the Texas Bar since 1998. Please direct your attention to Denise Coles as she presents on legal insights into youth medical care in Texas.
Thank you. So when you hear that I've been doing anything for 24 years, you know that I'm at least Gen X, right? I'm here to talk to you today just about some of the legal issues that might come up in treating youth and working with youth. As she mentioned, I have a long history of working with child abuse survivors, whether that's physical abuse or sexual abuse through the district attorney's office. And so I know that a lot of times there are issues about how you are going to interact with youth, with children. And so that's what I'm here to talk to you about today. I can't give you legal advice. I'm going to tell you right now, I always get the person who raises their hand and says, hey, can I just do this? Yes or no? I won't be able to do that because every situation is different. But what I can do is talk to you about what I, as a prosecutor and other prosecutors like me, would be looking at and thinking about when we're making a decision about whether somebody's behavior has reached into a point where it's abusive or potentially a crime. I'm also not talking about civil prosecution. I don't do civil law. Criminal law is, could you go to jail for this? Civil law is, could I take your money? Can I take your money takes like 6 hours of training, and I don't think you guys want to be here that long, right? So criminal law is much more simple. We can do it in 30 minutes. So let's get to it. One of the questions that I've heard folks ask me as a prosecutor is, can I get in trouble or charged with a crime for a medical treatment that causes a child injury? Under the criminal laws of Texas, we have injury to a child. It's basically the most common injury case that we have with kids. It's only available for kids who are 14 and under. And basically any injury that constitutes bodily injury is this offense. And it's a felony. We don't have any misdemeanor offenses for injury to a child. So what is injury to a child? Like all lawyers, we give a really clear definition that bodily injury means bodily injury. Very helpful, I know. But it really means, did it cause pain? Did it cause any bodily injury whatsoever? A cut, a bruise, a contusion, all those kinds of things. Can you guys imagine situations when you might be giving medical treatment to a child and they might suffer bodily injury? Right? I mean, I have 2 kids. I put a Band-Aid on one of my kids and then I have to take it off. Good Lord. She's going to scream for 20 minutes, right? Technically, under the law, that's bodily injury. I have just caused my child bodily injury. Now, I don't want to freak you out. This is not something that I see a lot. I will say I've been practicing for 24 years at the district attorney's office. I've only seen a handful of cases where we've had somebody who has been prosecuted for causing bodily injury in a medical treatment setting. And I will say all of them were situations that, quite frankly, we didn't believe it was medical treatment. Does that make sense? Because what we'll have is sometimes a situation where a parent, a stepdad, or somebody is giving treatment to a child and they say, no, this was for medical treatment. And then we as prosecutors have to decide whether we believe that's the case. Because sometimes people say they're doing something for one reason, but they're actually doing it for another. Does that make sense to everybody? So there is specifically a medical defense for the offense of injury to a child. It's right in the statute. As soon as they make it a crime, they go back at the bottom and say, and these are things that mean it's not a crime. It's basically a defense to prosecution of injury to a child if the act consists of reasonable medical care occurring under the care of a licensed physician. So if a doctor take somebody's Band-Aid off, and that's part of the reasonable treatment for the child, that's perfectly fine. It's not illegal. Does that make sense? Okay. The other section, and this is probably the one that's a little bit more important and the one that is used more often, is for emergency medical care that is administered in good faith and with reasonable care by a person who's not a licensed doctor. So that's kind of the catch-all for everybody else. For anybody who's giving a child medical care, but isn't actually a licensed doctor. So the issue there is the treatment reasonable, and does it fall under established medical standards? I'm going to go back. So when we talk about whether something falls under established medical standards, what do y'all think lawyers like me would be looking at to decide whether something is something that is appropriate under medical standards? What might I do? What? CPR? Absolutely. We can all agree that CPR is a good thing, right? I might talk to legal experts. I might talk to doctors. I might do research on the internet to see what is the accepted general practice. Things like stretching after an injury. Might that hurt? Might that cause a child bodily injury? If we're saying injury is pain, right? I've got a kid with a torn hamstring. She's complaining that it hurts. I'm telling her she's got to stretch it. Could that cause her bodily injury? Could it cause her pain? Sure. But as long as what I'm doing is reasonable, and as long as it falls within established medical standards, that's perfectly fine. Now, if I take that same kid who's complaining of has a sore hamstring, and I take her leg and I push it back past her ear and try to see if I can get her to touch the middle of her back with it. Is that the established medical practice? No. So I've probably gone too far. And now as a prosecutor, I have to determine where those lines are, okay? Now, that is just for kids who are 14 years old or younger. You guys are also going to deal with our older kids who are 15 and older. So they have a different standard. For kids over 14, the two offenses that you guys will probably or potentially could be engaging with would be assault, a regular old assault, or an aggravated assault. Aggravated assault is anything that causes serious bodily injury. And then assault is just like injury to a child, anything that causes pain, but is to somebody 15 years old or older. Does that make sense? So you've got a 16-year-old who is, let's say, still complaining of that hamstring injury, and you're helping that 16-year-old stretch. Now you have a different analysis because you're not still using the injury to a child standard. Now you're using a different one. Now you're going to use the medical defense for that. In that one, the medical defense is, did the conduct threaten or inflict serious bodily injury? Or two, did the victim know the conduct was a risk of either their occupation, recognized medical treatment, or a scientific experiment? Okay. So obviously the most important for you guys is number two, right? Recognize medical treatment. So if a 16-year-old knows that what's going on, the treatment that's being provided is a risk of their medical treatment, then it's fine and there's no crime. Does that make sense? Now, you can't cause serious bodily injury. So serious bodily injury is more than just pain or cuts and scratches. Serious bodily injury is anything that creates a substantial risk of death or protracted loss of use of any part of the body. Best example I can give is cutting an arm off. The person, you've amputated an arm. Now that person no longer has the normal use of that arm. There are things that we can do to modify and to work with that, prosthetics, things like that. But still, that injury is serious bodily injury. Does that make sense? So what you can't do in this scenario is cause serious bodily injury. I doubt that I have to tell anybody in this room that you shouldn't go around cutting people's limbs off, right? You guys know that on your own, right? Some of you aren't sure. Some of you are scaring me a little bit. No, I'm just kidding. Okay. So let's talk about kind of the analysis that I, as a prosecutor, or prosecutors like me, would go through when we see an injury. My first question, is the child under the age of 14? Because what is the difference? It's a different kind of crime, right? If the child's under 14, then my question is it an injury to a child? If the kid is 16 or above, then my question is it an assault or potentially an aggravated assault? So let's work with a kid under the age of 14. Then my question, if the kid is under 14, then my issue is, did the injury inflict bodily injury or serious bodily injury? And then I decide right there, was the treatment reasonable and was it accepted medical procedures? Any questions about that? Are there any procedures that you guys engage in that you are concerned about or that you think would be concerning as far as criminal law for physical abuse? Anybody? Well, that's good. Then I feel good about you guys doing your jobs. Yes, sir. So my question would be, are you talking about a child over the age of 14 or under the age of 14? So if it all goes down to, at least from a criminal perspective, it all comes down to the age of the child and which standard we're under. So if I'm looking at something like dry needling, it's going to be, can you establish that your treatment was reasonable and that it followed established medical procedures? Sorry, I'm supposed to repeat the question and I didn't do that. But so the question is going to be, what can you demonstrate? So let's talk about a situation where maybe somebody has accused you of dry needling and that they're trying to say this is an assault. As a prosecutor, we're going to come and we're going to talk to you and we're going to say, hey, what was going on? And then as long as you can explain, this is what we were doing, this is why, it was a completely reasonable medical treatment and it's accepted in our community, in our profession, then you're probably not going to have a problem with somebody like me. Because I'm going to tell you, at the end of the day, prosecutors don't want to prosecute folks like you. We don't want to prosecute folks who are out there helping kids, helping them stay healthy, helping them, engage in sports and activities and things like that. Really what we're trying to prosecute is the folks who are using medicine as an excuse to do other things. And we're going to talk about that in a few minutes. Did that answer your question about dry needling and whether that would be something that we might discuss in this area? That was my repeating the question. Thank you. So parent consent forms are helpful. They're certainly helpful in a civil situation because remember, in addition to criminal liability, there's always the risk of civil liability, like somebody's going to sue you. I will tell you, you can sue anybody for just about anything. It doesn't mean that you'll be successful, but it means that you can do that. So I think that anytime you can get a parent consent form, you're in a better position than you are without it. It's never going to hurt you. It is never going to hurt you to have a parent consent form. Okay. So let's talk then about whether, okay, we talked about those two things, sorry. Now let's talk about whether or not somebody can be prosecuted for medical treatment under child sexual abuse standards. Who knows who this guy is? Yeah, somebody shout it out. Larry Nassar. Wonderful fella. Larry Nassar, for those of you who might not know, managed to sexually abuse American gymnast through USA Gymnastics for about 20 years, over and over and over again, sometimes in front of their parents. And his justification when he was caught was, no, I'm doing justifiable medical treatments on these kids. He was like something, I will say as a prosecutor, I had never seen before. You don't want to be that guy for lots of reasons. So let's talk a little bit about this, the statutes that are involved when you're dealing with kids and sexual abuse in Texas. Unfortunately, this is kind of my wheelhouse. I'm weird. I've been doing this a lot, but we have indecency with a child. Basically, indecency with a child is touching a child on their private areas. We're talking breasts, genitals, and anus, okay? It also is exposing their genitals or their anus. So can you imagine a situation when somebody might engage in that kind of activity with the child as part of reasonable medical care, right? Sure, it happens a lot. I mean, as a parent, you're dealing with your kids, you're gonna have to probably, depending on how old they are, help them go to the bathroom, wipe, clean, all those kinds of things. So the law actually recognizes that this is the kind of contact that can be perfectly normal. So for these cases, the issue is always, was the touching sexual? Was there an intent to arouse or gratify somebody's sexual desire when that touching occurred? Because, right, there's a difference between me as a parent helping my kid go to the bathroom when she's 3, or somebody touching the vagina of a 16-year-old girl, you know, in the back of a, I don't know, van or something, right? So the issue here is it sexual? If it's not sexual, you're fine. If it is sexual, that's when you start having to deal with somebody like me. So what kind of things do you think as prosecutors or as people that we would look at to determine whether a touching is sexual? I'll tell you, we look at everything. What was said during the touching? How did the touching happen? Let's talk about from a medical perspective, okay? Let's talk about Mr. Nasser. Let's talk about some of the stuff that we looked at as prosecutors to determine that what he was doing was not medically appropriate, that he wasn't wearing gloves when he was examining the girls, that when asked about it, sometimes he would lie about it and say, no, I didn't do that. Sometimes he would change his answers about what was going on or what he was doing. He would sometimes do stuff without other people present. Those are all the things that I look at as a prosecutor when I'm deciding whether a touching is appropriate, right? Because if it's something that you're willing to do in front of people and without hiding it or lying about it, then I'm going to be much more comfortable that your intent was actual medical. Can y'all think of something that you guys deal with on a fairly regular basis or that can be pretty controversial that might get into this area where we're talking about indecency with a child and sexual abuse, things like that? How about rectal temperatures? Right? Okay. Well, let's talk a little bit more about that. Oh, wait, I went the wrong way, y'all. Okay, so sexual assault of a child is basically any contact or penetration of their sexual organs. So contact or penetration of the anus or vagina or the anus or male genitalia, okay? That's what a sexual assault is. It's contact or penetration. So let's assume, now it's also age-based. So if you're 14 or under, it's an aggravated sexual assault. If you're 15 or over, it's a regular sexual assault. That doesn't mean anything to you, except that age does matter. You do have different standards for littler kids than older kids. But it is a defense to prosecution if the conduct consisted of medical care for the child. So again, the law recognizes that there are going to be situations when you have to engage in this kind of treatments that might cause penetration of a body part of a child, an anus, genitals, something like that. And the question is then just, is this medical care? So if you're in a situation where you have a kid who is engaging in, some track meet, something like that after school, and you're seeing signs that they are in distress, maybe experiencing heat stroke, what are you going to do? What are the things that are going through your mind? Anybody? Y'all know this better than me because I've never been in your position. I've only been in this one. What kind of things are you thinking about? Would you be worried if somebody said, let's say your supervisor comes to you and says, you need to do a rectal temperature on this athlete. Athlete's 13. Would you be worried about that? Yeah? Why? Come on. Exposure, because you're worried about what's going to happen, right? This might be the best thing. This might be what the child needs. This might be the best way for you to treat and handle what's going on and diagnose the situation. But there's a concern, right? Where is this going to go? Well, I can tell you, if you can prove that it's medical care, then it is not a crime. So now, what kind of things should you guys do as professionals to make sure that somebody like me agrees that what you're doing is medical care? Can y'all think of some ideas? Have someone else present. I think that's really important. What else? I heard document. Yes. One of the things that I see a lot of times as a prosecutor is when people are nervous about something that they're doing, they document it less. Don't do that. If you have something that you're doing that you know or that you are concerned somebody might question, document the heck out of it. Like every step, document it. The more you document, the more somebody like me is going to look at it and say, oh yeah, clearly that was medical treatment because look how well this is documented. It's in every part of the person's records. Anything else? Wear gloves. If you can wear gloves, wear gloves. The other thing I would say is be honest about it. Sometimes I've seen people where they come in and maybe somebody's asking them questions about a situation that they're in, and not for any other reason than they're nervous, they start doing I didn't do that. I didn't do that. Right? And then a week later, they want to come back and be like, okay, no, I did. Be honest about it. If that's what you did, be honest about it because I'm going to tell you as a prosecutor, that's something I'm looking at too. If you walk in and the first thing you say is, yes, this child was in distress. This child needed, I had to do an examination and this is what I did. I had to take a rectal temperature. That's the standard of our profession. And that's what you've been documenting and you've been consistent about it from the beginning. I'm going to have a really hard time saying it's something else, right? Especially if you can add, it's well documented, you wore gloves, everybody was around. Maybe you had previously sent out a consent form to all of the parents of the track team that if something happens and we think that your child is in heat stroke or in a situation where we need to take that kind of temperature, that we're going to do that. Everything that you guys can do to show that this is valid medical practice and that this is what you were doing, this is all for medical care, will all benefit you if and when you have to deal with somebody like me. Does anybody have questions about that? I'm going to tell you that one of the things that you have, if you're talking about specifically the rectal temperatures, you guys can point to all of the literature that says that this is the gold standard on how you would determine body temperature, especially in a kid who's having heat stroke. Probably said the wrong term, but you know what I mean. Like the fact that that is the gold standard and that several respected bodies have said that, your attorney probably not you, but your attorney is going to tell me that, and I'm going to go, okay, yeah, you're right. Because all of that information, it's one big picture. When we make determinations about whether or not a contact, especially sexual contact with part of a child's body that is considered a sexual organ, whether that's a sexual touching or not, we're looking at the entire picture. Now, what you shouldn't do, and I think you guys are going to know this, is take them into a dark room, don't wear any gloves, tell nobody that you're going there, lie about it when somebody asks you what happened, and then don't document it in any reports, right? You're going to have a hard time with me then. Now, you might still be able to, talk about this stuff, but at the end of the day, the goal is to show how reasonable you acted and that everything that you did was in accordance with accepted medical standards. Does that make sense? Okay. Does anybody have any questions? Yes. So the question was, so the question that I'm answering is that there are sometimes competing issues, especially when we're talking about consent forms. What happens if you have people who do sign consent forms and don't sign consent forms, and how would you kind of navigate that space? Would that be accurate? Well, so here's what I'll say. Consent forms are not perfect. If you look at the statutes, there is nothing that says that having a consent form would prevent you from being prosecuted. That's not the standard. The standard is this medical care? And we're specifically talking about rectal temperatures at this point. The standard is it medical care? I think from a practical perspective, if you are giving parents more information, that is always better as I am analyzing what you're doing. Because I think the more transparent and the more obvious and the more direct and clear that you are being, I think that's better. Like, you are not going to be in a situation from a criminal standpoint if a parent says, no, you can't do a rectal, I didn't turn in the permission slip, so you can't do it. That's not part of my analysis for criminal law. To analyze whether it's a crime is just, was it medical treatment? And the fact that you, as a professional, sent to all of the parents, this is what could happen if your kid is in a medical emergency, just FYI, that I am going to use that to suggest that was actually valid medical care, right? Because you're not going to send out a permission that slips that says, hey, just so you know, I might sexually abuse your kids because I'm gross, because I'm Larry Nassar, right? The fact that anything that you're doing that's being clear and above board and saying, this is what it is, I'm informing parents of what the situation is and what might happen, is something that you can use and that would benefit you if and when you come to court, but you won't come to court. Did that answer the question? I certainly think that with or without a consent form, you are protected. In fact, maybe instead of sending something out that says I need your permission. Maybe you send something out that says, this is the accepted response in this situation with these symptoms, and this might happen. Not, are you okay with it? Just, hey, FYI, this might happen. But the thing that's difficult about criminal law is there are no bright line rules. Like it's all about gray area. It's about what you can prove and what you can do under the standards. Yeah. Well, I think at the end of the day, every organization is probably going to come up with their own standards and their own feelings, especially when it comes to consent forms. I don't think there's kind of the magic answer. Yes, you should do it, or no, you don't. Yes, you should word it this way, or no, you shouldn't. It really does depend on everything. I will say you could be prosecuted with one, you could be prosecuted without one. And I think I'm out of time now. So thank you guys so much. It's been really exciting talking to you guys.
You want your phone?
All right, to wrap things up, we have two speakers. We have Lequita Williams-Golden and Melanie Buckner. First, we have Lequita, who is a board-certified sports-trained physical therapist at Memorial Hermann Rocket Sports Medicine Institute. She received her BS from West Virginia University, her MED from University of Houston, and MBA from Texas Southern University, her DPT from the Temple University, and is a board-certified clinical specialist in the sports physical therapy, certified in functional dry needling. She was a former NCAA D1 gymnast and formerly trained dancer that has allowed her to transfer her experience in this sports to then her knowledge to being a lead for gymnastics medicine program at Memorial Hermann and involved in the hip preservation program and a pediatric orthopedic program. She is a PT lead at Rise Gymnastics and involved in event coverage for UCA gymnastics sanctioned events. And then we have Melanie, who is a physical therapist at Memorial Hermann Rocket Sports Medicine Institute as well. She received her DPT from Northwestern University and is board certified clinical specialist in sports physical therapy, certified in functional dry needling. She's a clinic instructor in Memorial Hermann Sports and Orthopedic Physical Therapy residency programs and involved in research surrounding sports-related knee injuries. She also has previous background as a gymnast, in which she collaborates now with Houston Christian University, Stratford High School, Rise Gymnastics, Open Dance Project, and USA Gymnastics. Together, they will be presenting Rehab to round off gymnastics medicine case studies.
Awesome. All right. Can y'all hear me? Great. Thanks, Alina Sophia. All right. I'm Melanie and that's Lequita. We're going to get going. We have two case studies for y'all today. And we're also just going to talk to you a little bit about the gymnastics medicine program that Lequita has started and we've developed. All right. Here we are. Lequita and myself, Alina Sophia, did a great job introducing. And Lequita is the team lead for our gymnastics medicine program. Okay, so our program, what is gymnastics medicine? So we began this program about 4 years ago, started developing it then, and then it has made its way to a program. So we are aiming to serve gymnasts, dancers, and cheerleaders with specialty care using evidence-based practice and clinicians that either have personal experience like Lequita and I or are highly trained. And we treat all ages. And we think a comprehensive interdisciplinary approach is super important. So this focuses on using both ourselves, the PTs, we use PTA as part of our program, we have OT as part of our program, and then of course collaborating with all of the MDs. We've roped in sports dietitians, coaches, and then of course the parents and the athletes as well. Okay, so why is our program important? We are spread throughout the greater Houston area. So we currently have 4 of us at Memorial City, since that's where Lequita and I are at, the Rocket Sports Medicine Institute. And then we also have therapists at the Woodlands and Pearland, as well as Greater Heights for our occupational therapist. We are considering all aspects, including the athlete's individual strengths and differences. And then our big focus is, of course, on a safe skill progression and return to sport. And we believe that there hasn't been enough evidence out there, so we're trying to create that and and we are hopeful to get into research eventually. But ultimately, what it looks like currently is, of course, just using our expertise and previous experience to help guide our patients through their rehab in terms of integrating some of their conditioning and some of their skills early on, so they can be they can participate with the team in any way that they can safely, and then of course just progressing them appropriately back depending on which injury they're dealing with.
So about 5 years ago, a gymnastics team came to Memorial Hermann and asked if there was anyone that could help them with injury screening and things like that with their athletes. So we developed an injury screening, and then we started implementing it about, I think it was September of 2020. And basically the injury screening is to help them See if there's anything that they're doing within their general conditioning that is not working, seeing if there's any deficits that are across the board within their program. And we try and work hard with them to try and set up programs that are beneficial not only to the athlete, but also to their general health. So basically, on the physical therapy side of it, we check for range of motion. Our biggest thing that we look for is any deficits from side to side. There are going to be general things that we see in terms of flexibility. So hamstring on the dominant side is probably more likely to be more flexible, but hip flexor is probably less flexible on the dominant side, and the dominant side is just the leg that they lead with when they cartwheel. They should have a general baseline of core strength. There is a common theme that if they get, as they develop, there's a period in time where their dominant side may be stronger in a side plank, and then it starts to level out again once they get to the higher level. So we kind of watch that dip happen and then also come back. And then we look at landing quality and then upper extremity and lower extremity Y balance. And then on the sport specific side, we look at the body position. So like a hollow hold, handstand, pull up, leg lift, splits, and hanging. And the handstand, it has its own other screening, which I'll talk about a little bit later within the case study, which kind of helps us now guide us with our back pain athletes.
Awesome. Okay, so I'm going to jump into the first case. All right, so this athlete came to our clinic and I co-treated her. So if I say the word we, that's just me and the other therapist that I was working with. She came in status post right knee ACL reconstruction with her patellar tendon. She had a medial meniscus repair with 5 stitches, and they also performed an LET. She was a high school sophomore cheerleader at the time, and her positions were both the base for cheerleading and then tumbling. She also stunted as well. And how the injury happened, she was performing a round off during practice, and she felt like she landed awkwardly, caused the knee to shift, and then she knew right away that she wasn't able to stand, felt unstable. Okay, so the early part of her rehab was pretty unremarkable until about the 16-week mark. She was playing pickleball with some friends. Of course, this was not warranted by the physical therapist quite yet, and came into PT complaining of instability, pain, and locking. And I say unremarkable in quotes because at this point, we hadn't gotten to the jogging progression quite yet. So she was just a tiny bit behind due to some like range of motion deficits she was struggling with on that early phase. So we just weren't quite there yet. So yeah, ultimately we weren't jogging yet. She definitely wasn't ready to play pickleball. So in session, we did an objective assessment. She was presenting with some joint line tenderness. She had some pain with the McMurray's test, which tests for like a meniscus derangement. There was no audible click, just pain. And then she also had pain with hyperextension and knee flexion. So because of this, we were a little bit nervous that she did something to that meniscus. So we referred her back to her MD. I believe the MD agreed because he ordered an MRI. And then we found out the MRI came back unremarkable. So we were all a little bit confused. The one piece that she did give to the physician that she hadn't given to us was that she had some complaints of this like lateral knee tingling and pain. So the MD had then ordered her to start gabapentin and referred her to a pain management specialist because he ultimately thought maybe some of this pain that she was dealing with was a nerve irritation. All right, so then in PT, of course, we did our best to continue with conservative treatment, which was as tolerated. This athlete really couldn't tolerate much. I definitely believe there was a big psychological component to this athlete as well, which I'll get into as we continue on. But, you know, in her head, there was something that seriously went wrong during that time she tried to play pickleball when she knew she wasn't supposed to. So there were a lot of things that were super painful for her. Like we couldn't really do any sort of loaded flexion. So anything standing was pretty much a no-go. We spent a lot of time on the table doing quad sets, straight leg raises, anything that we could do to target strengthening and endurance and keep her range of motion. And of course, we assessed the nerves, especially because they had mentioned that they thought maybe that this was some sort of nerve irritation. From our end, there didn't seem to be any conduction concern. So we had normal myotomes, normal dermatomes, no changes with nerve glides.
That only nerve symptom that presented was that tingling and pain on the lateral side. So we did initiate some nerve glides as well into her care, both in PT and at home. But ultimately there was no like major symptom resolution with those. Okay, so now we're about 6.5 months out of her initial surgery. She's finally gotten into the pain management specialist, which took some time. And ultimately, they ended up doing a ultrasound guided steroid injection along the surgical stars, the tibial hardware, and the genicular nerves. So I put a picture here of the genicular nerves just so that y'all had them for reference. If you don't know much about them, they supply the sensory innervation surrounding the knee. Most branches come from the common peroneal, but there are some different variations anatomically depending on each body. And they're going to supply the knee joint capsule and the lateral aspect of the knee. So makes sense why he targeted this for his ultrasound guided steroid injection. And it did take a little bit of time, but it did definitely drop her pain down significantly, probably to about like a 2 out of 10. So once the athlete was tolerating this much better, we definitely moved into more of the single leg strengthening, which was great. So it's been quite some time at this point. She definitely doesn't have that same quad strength since we were just mainly doing things on the table for loading. All right, so now we're getting into 7.5 months. Her pain's at that like 2 or 3 out of 10. And she's now cleared for the running progression since she has her pain under control. Physician was okay with her moving on. Big kicker is that cheer tryouts are in about 4 months. We haven't started running. So yeah, she's definitely got her single leg strength up to, I think it was about a 60 or 70% at this point using like a handheld dynamometer. So we tried to move into starting some jogging exercises. So for us, this is going to look like some sort of like jump rope, or we have like an offloading like leg press type of machine called a shuttle, if y'all are familiar. And we like to do jumps on there. She was not okay with any of it. She was terrified. So at this point, I had spoke with her about seeing possibly a sports psychologist. And we had talked about this early on as well, because I knew that she had expressed to me that she was afraid to go back to tumbling. But early on, she wasn't willing to budge. So I tried to bring it back up at this point, and she's your average sophomore teenager, was not here for talking to someone about this. So I had a pretty good relationship with the mom. So I had also reached out to the mom to try to express my thought and the importance of seeing this sports psych. But that also didn't go over too well with mom, and they wanted to just continue to move forward and think about pushing through on her own. So I was at a little bit of a standstill, and the best part of this entire story, or this case, is the story I'm about to tell you. So she ends up coming in and she says, I can't tell her mom this, but she was at like a party for high school and had to run because someone was coming for the party. And that ultimately just like lifted all of her fears with running. So we broke that, which was great. And from there, we were pretty good to go. We went through our running progression, and we were still playing catch up on all that single leg strengthening. So that was ultimately what we were accomplishing at this point. Okay. So then to break down, now we're at the 9-month mark. She goes back to physician and she's cleared for jumping and agility, which is great. And then also some like cheer tumbling with my approval. So this is a little bit of a breakdown, which I hope y'all can read, but I'll kind of walk you through it. I made this for her just so that she had something like firm to look at and to set as like a goal for herself of things we were going to work on each week all the way up until cheer tryouts. So I will say that this didn't go as completely as planned just because of holiday challenges. As you'll see, I started like the week before December, which was when this appointment was. So with both Christmas break and New Year's, I left some weeks at the end there so that she was able to catch up as needed. But initially we started the sports metrics program, which if you're not familiar, it's a jump count program. So you're starting with double leg jumping in a variety, and you're counting how many times you hit the ground, ultimately just to try not to overdo it or overload too early on. That's the point of counting the contacts. And it's starting with double leg. And then as you move into phase 2 and 3, you get into some vertical jumps. And then in phase 3, you get into single leg jumps as well. So for the first phase, as she's starting this jump progression and she's getting through running, my goal was to then start initiating some of these sport specifics to get her excited about rehab again and excited about going back to sport. So we started some what we call like non-impact skills. So handstands is where we're going to start, of course, and then some like cheer specific conditioning. So things that she would normally do for practice, and we just worked it in rehab. And then I gave her the clearance to start doing the conditioning as well at practice. After that, we moved into some additional non-impact skills. So cartwheels and back walkovers is kind of the next step before we're getting back into the round off and the back handsprings, which have like flight to them. So we started with the handstands, the cartwheels, and the back walkovers. And then we're, of course, trying to build up our mileage as well for running. As she moves into some of these like vertical jumps and more challenging jumps, we started to work into like introduction to sprinting to do a powerful tumbling pass that she needs to be able to do. She needs to be able to produce speed fast. So we started introduction to sprinting. And then we turned that the next week into something more sport specific. So they have to do a hurdle before, which is just the power move that you use to get into your running tumbling pass. And then from there, we moved into single leg jumping. And then that was the same time that I had introduced some of like the first flight skills. So we started with round offs. Since a cartwheel she had already done where you're turning sideways, this was the same thing. We're just adding a little bit of flight to it. And then we also started working in some change of direction at this point because we had to do a functional test before she went back for full clearance for tumbling. And then this stuff we're going to move into after the functional test. Okay, so she performed her functional test and she did great. We're at 11 months at this point, and she was her range of motion is of course clear, looking great. Her quad strength was at 88% at this point. And for all of her hop testing and her agility, she was within 80% of the uninvolved side. So with that, the physician was comfortable clearing her for standing tumbling with her coach and then turning that into running tumbling as the coaches and myself felt appropriate. And at this point, we have tryouts in 1 month. So in the clinic, we focused on a lot more of like base movements, things that she has to do for the basing and cheerleading. So she's standing at the bottom. It's going to require a lot of stability and endurance as well as strength. You're holding someone up overhead. And stability is going to come a lot with someone's moving above you. So you have to be able to react to whatever they're doing up top. So we focused on a lot of that. And then we focused on like her cheer specific jumps and single leg strength still, of course, and power to be able to develop power for those tumbling passes. And then at this point, we had transitioned a lot of her skills over to her coaches, and I made her send me and show me videos each day in order to progress her. But ultimately, so everything on this right side is going to be the skills that she had to do at cheerleading. And we started with trampoline stationary skills, so like stationary back handsprings and her jumps and her herkies. And then she moved into connected passes on the trampoline. So this is kind of the natural progression that we'll do. And then as she's doing these connected skills, so like a round off and a back handspring together, then she's starting her stationary skills at the same time on the spring floor. And then she'll move into flipping on the trampoline, and then she'll move the connected skills onto the harder floor. And then ultimately we're working our way towards that dead floor since she is a cheerleader. So trampoline to spring floor to dead floor. Awesome. And then she ultimately ended up making JV, which I was super proud of her, but of course she was a little bit bummed. But of course, like she went through a very hard year, and I wouldn't say that her rehab was simple at all. So at this point, she had made JV, and since she hasn't reached that 90% threshold that the physician's looking for return to full sport, she's still coming to me about once a week, or I'm sorry, once every other week, once a month now that it's summer, and we're going to retest soon, and she's going to be good to go here soon. Awesome.
So case study number 2 was one of my patients that I had a few years ago. She is one of the only patients that I was able to see from beginning through return to sport and then again after she returned to sport. A lot of times once they get back to the return to sport phase, especially in gymnastics during competition season, they just don't find time for PT. So she was one that was very diligent in making sure that I was involved in her process the whole time. She was a 12-year-old female. She was a competitive level 7 gymnast. So what that means is she is at the level where she kind of picks and chooses her own skills, but there's still minimum requirements that from USAG at her level. She competes in all 4 events. She's homeschooled. So a lot of times, if you don't know what gymnastics, a lot of gymnasts are homeschooled, but when they're homeschooled, a lot of times their practices are longer hours, so maybe 5 to 6 hours, or maybe they even do 2-a-days. And she was one that was doing 2-a-days, and she was doing that 5 to 6 days a week. And then at home, she recently increased her training activity where she added supervised lifting to her program. And then she also, because it was right before competition season, started ramping up on hard surfaces, landings. She was doing full routines, more reps on individual skills when she didn't do them correctly in routines and things like that. So the 4 events that she competes on: vault, bars, beam, and floor. And then the practice versus training surface. The one that's on bars with the green, that is an open foam pit. So they learn new skills in there. Their body goes down in between the foam, those types of things. A resi is basically made out of foam, and it's a big giant foam pit with some sort of mesh over it, and you don't go into it, but it's still a soft landing. And then each type of mat gets a little bit firmer. So ideally, the thinner the mat, the more dense the mat is for landings. And in competitions, usually the top mat is either a 4-inch or an 8-inch mat, which has a pretty decent amount of density to it. Again, this is just a picture of all 4 events that she competes on. And then also the importance to know these is to know what we're trying to get her back to, and then know if there's arching on some of these skills and if there's landings on the equipment versus off of the equipment. How high is she landing from? Is she someone that's a level 3 and doing just low bar skills, or are they coming from the high bar as well? Are they dismounting off the beam, or are they doing like a handstand fall? So in her evaluation, she told me her mechanism of injury was gymnastics. She has pain when she's going into arching skills. She has pain in flexion. She has pain in standing, and then she denies any numbness or tingling. So, and there was no neural tension involved at all. During the evaluation, we found that her pain was reproduced with in-range lumbar flexion, lumbar extension with rotation, and then she had decreased strength, decreased plank time, front and side planks, and then decreased hamstring flexibility. But then on the specific gymnastics side of things, her hollow hold quality and time was decreased, and her handstand quality was poor. So we basically took a handstand and we were like, what can we look at from this when we were developing the screening? And from anything from wrist pain, finger pain to back pain, we can see it in a handstand typically. And like I said, she's one that I was able to follow through. So I have a begin, middle, and end picture of what her handstand looks like and what we were able to gather from it. Basically, I assess it. I have them kick up into a handstand where their belly is to the wall, and I can watch from the back and look at from toes down to their hands. And then I can also look at it from the side and see what they look like that way. So basically, we want everything stacked on top of each other. So the guy on the left is not using the wall, but it's a great picture of a handstand and what we want to see from the side. And then the girl that's doing a handstand is how I look at it from the back. So she has a really good handstand. She also is not using a wall, so her coach is holding her toes so I could get the picture. So this is the handstand that I saw with my patient. Basically, what I saw with her is her hands were pretty even. Her elbows were pretty even. When we got to the shoulders, she had a little bit of a tilt, which doesn't really tell me much of anything unless she has shoulder pain, which she did not. But then the red circle kind of gives me a picture of what I see in typical back pain. So there's an area that is not activated in this handstand, and I have seen it 100% of the time with my gymnasts that have back pain. So I kind of been keeping track of this, and she's one, again, I can watch it develop. But my other question to her was she ever checked for scoliosis? And she said no. But that is what I was kind of considering when I was looking at her handstand and I saw this shoulder asymmetry. So based on the evaluation in the handstand, I wanted to do sport-specific physical therapy, and then I wanted her to see a physician because I believe she came to me direct access regarding her pain and extension, and then her asymmetry noted. So pain and extension, I always worry about stress fractures, and I'm very conservative when it comes to stress fractures, so I shut them down pretty quickly. And the only time that I kind of get them released is if they have imaging that supports that they do not have a stress fracture. And even then, I kind of push for treatment that way, just so that we don't develop it. So after seeing the physician, she did have a herniated disc. She was diagnosed with extension overuse injury, and she did have scoliosis. So again, that supported the picture that I saw in the handstand. So my goals of treatment was to improve pain-free lumbar range of motion, improve core strength and hip strength, improve handstand quality, and overall reduce the pain and send her back to gymnastics to full participation. Ideally by the end of competition season, but that's not always the case. So specific treatment plan, I did some core strengthening. I worked on our hamstring flexibility, hip and lower extremity strengthening, postural retraining. So we did a lot of plank work, oblique work. A lot of times when I see that flaccid side in a handstand, I'll do double the amount of oblique work on the flaccid side versus the other side. We did some ball walkouts, Palloff press. We did hamstring and hip flexor flexibility. And then just some motor control techniques, so a lot of static motion. We're trying to get her to find different angles and get in different positions correctly. So these are just examples of some of the exercises that we can do. So the first picture where she's hanging and her toes are to the bar, I don't have them come all the way down where their feet touch the bar on the bottom. I have them go to an L. That way they don't extend their back, and I can do it safely when they do have any type of extension issue. The middle picture on the top is a pike up. I do those almost with any gymnast. From hip all the way up to elbow, wrist, shoulder pain. Hollow hold is the picture in the lady in the white top. And then pull-ups, which the guy is hanging with his knees bent. Again, I don't want the straight body because I don't want them kicking into extension. So I have them hold in a chair position and I'll hold their legs up and then I'll assist them into the pull-up. Bottom is a candlestick. So she'll roll up into that position and come back down. Once we progress it, we can roll up and then come back up and jump. And then the last one, she's just doing variations of different hanging holds and things that way. So we finally got her to a point where she is pain-free. She's pain-free in all ranges. She can do a back bridge without pain. She was pain-free for about a month before I introduced the bridge. And then she also is pain-free with all functional activities and anything that she's done in school. So her handstand alignment has looked better. Gymnastics-based conditioning she was being able to perform that well. She was introduced to new skills in the gym, so handstands, cartwheels. She's been doing some bar swinging a little bit, and then she had extended times in between her PT sessions. So I usually start off with dropping down to once a week, and then every other week, and then would kind of balance it out with their training schedule. And then once she's fully integrated into sports, she began just doing the sport-specific training. So I gave her a home program to do that she can either do in the gym during their conditioning time, or a lot of times they have minimized reps. So I'll give them like 3 reps of certain skills. So then they have 20 extra minutes on the event. So I'll give them conditioning to do on each event as well. So her handstand here looks a lot better. The divot is not nearly as big, almost invisible, but the shoulder asymmetry is still there, again, which supports the scoliosis that she has. At that 6-week follow-up, she has now developed that divot again. So she's still pain-free with normal range of motion. Her strength was maintained except for her side plank. It started to decrease again. And the asymmetry in the shoulder is still there, slight divot developed, and then the presence of she's got a little shift in her handstand there. So for me, the importance of the follow-up is to make sure that we're not progressing in the wrong way. So she may have been back in the gym doing everything she wanted to do, but if she's not doing a conditioner to keep her strong, then she's going to progress back in the same path. And with her, she definitely did. So her divot had showed up. She was starting to get pain and a little bit of like impact extension exercises and skills at the gym. So we had to back off for a little bit of time, increase her side plank time, start doing her exercises again, and then we moved on from there. So then her handstand progression is just the picture from beginning to end. So pink shorts is day one, nice big divot. I think I have a laser here, right in here. Then at about 3 to 4 months post treatment, she no longer has a divot. And then at the 6-week follow-up after return to sport, when she stopped doing her home program, it started to show up again. But we were able to catch it. We did treatment. She is doing all of her exercises that I know of, and she is now a competitive level 9 gymnast. Her injury this year was an elbow, so completely different, but she is doing great. These are our references. Any questions?
Anybody have any questions? Okay, with that being said, ladies, oh, hold on, question. Hold on 1 second, microphone right behind you. All right.
Okay, I'm not being negative, but if you're looking at the handstand photos, okay, and you have your initial photo where you have the divot, and okay, shoulder alignment, it's not a big deal. It's related to her scoliosis. So we go divot, you work hard for 6 months, divot disappears, pain disappears, and then we let her go back to activity, and now pain comes back and divot's back. All right. Where are we at right now? I mean, is it a continuous cycle that you're seeing because of the nature of the sport? You know, it's like I have a swimmer that I promised to God, she's very similar to this young lady. And whether it's me as an athletic trainer or a physical therapist working with this person, fine, pain disappeared, but whenever she goes back, symptoms come back.
So for our gymnasts in particular, can you guys hear me? Okay, for our gymnasts in particular, it's a lot of the training that they do. So if our coaches don't really focus on quality of a plank and they focus on just getting a plank done for 2 minutes and say the athlete only knows how to do it well for 30 seconds. Now we're training this athlete to do a plank for 1.5 minutes poorly. So then that translates into their training. So now they're getting extra stress on that side, which is why the pain tends to come back. So it's not necessarily on the PT side. It's more so what are they doing when they're training back in the gym and how much are they getting someone looking at them?
Yeah, I wasn't trying to imply the PT side, but
No, I'm just saying, like in general, I just feel like a lot of it just comes from like how we're training them outside of the gym, which is why we try and motivate them to at least do what we give them on top of what they're doing in the gym.
Any other questions? Okay, thank you very much. Now, a few housekeeping remarks. So you will receive an email that's going to have a link to a survey in it. Make sure you do the survey. Once you complete the survey, your certificate will be automatically generated and sent out to you. If you do have any issues after you do the survey, for whatever reason you don't get a certificate, email Bob Marley. Okay, if you are a Memorial Hermann athletic trainer, we will meet in this front corner right here where Mr. Jones is. Everybody else, if you can please just make sure the trash is picked up around you. Thank you, KDISD, for hosting here. We greatly appreciate it. See y'all next year.
Tell us about it.
Yeah, on the surveys, please put topics for next year.